Good morning, everyone. Good evening, good afternoon, everyone, wherever you are. Today is the day we have been waiting for. We are hosting our conference, we're trying to bridge science, policy, and practice for the health community. And this is organized by the Zimbabwe Research Network, which I'm part of, and our conference is Society, Health, and the Environment. In this conference, we have a lineup of excellent speakers. We are based all over the world, who are studying different programs. We have people who are studying occupational medicine, those who research cervical cancer. We have public health experts. We have policy experts. We have water resource management experts, biochemists, chemists, psychologist, everyone is here so that we can all learn something important, so that we can see how the innovations that are taking place across Zimbabwe in this important time where health is a crucial issue. So today, as I'm waiting for Professor Chirisa to come up to give opening remarks, I just want everyone to share with your friends this link. I'm going to give just about 2 minutes so that we just share a link of this session so that they can join and everyone can take part.
Morning, everyone. There is one delegate who's just joined as guest speaker. Will you let us know who you are so we can rename you?
That's Professor Chirisa. Thank you.
Yes, we have
Thank
Professor
you.
Chirisa. Now you can, let me open your video. Yes, Professor Chirisa is here. Amy, would you go ahead?
Well, thank you, Professor and colleagues here.
We can't hear you. Professor Chirisa, you're on mute.
Good morning. Can you hear me now?
Perfect.
Yes, we can hear you.
Wonderful. I'm glad to be here with you this morning, and I'm coming in to give some few remarks. I don't know if I can perhaps allow me to share my small presentation.
Yes.
Maybe if you don't mind, let me just go ahead.
Yes, you can share your presentation now.
I can.
Yes. Thank you.
Well, I would like to basically say a few words, and I've entitled my speech Promoting Health and Resilience in the Anthropocene. As we all know, the theme of this important meeting that we're having this today is about society, health, and environment. So the Anthropocene now comes in as an important concept and factor for consideration. As you might know, since the 1800s, which was the industrial era, up to 1945, what was generally seen in society as it was evolving, this period 1800 to 1945 saw a substantial expansion in the use of fossil fuels. There was transition to high energy society marked by rapid economic growth, marked by innovative technologies, as well as high rates of urbanization, which means we have, as humanity, transformed the earth so much that it's no longer as it was in its pristine stages. Then when we look at from 1945 to about 2015, again, this is an era called an era of great acceleration, where we saw the increased population, extension of the global economy, increased urbanization, motorization, and innovation. And we grew aware that the human impact on the ecosystems was a reality. When we look at biodiversity, there has been rapid species loss. And from 2015, since we adopted the Global Agenda 2030, we are beginning to ask ourselves as human beings or as society, how can we be stewards of the Earth system? Because humans are the main geological force and we are seeing the need for rapid progress in research and technology as we are facing what is called the sixth mass extinction. We are transgressing planetary boundaries. So when you look at the quantum of fossil fuels, the quantum of greenhouse gases that have been produced, it has really increased from about 1850, and to date, major contributors being North America, Europe, the Middle East, and the North Africa region, and China since the 60s has also joined the league in the emissions of greenhouse gases. So the environment is the major victim of what humans are doing. Now, when we look at the planetary boundaries, what are they? They provide, or they are a framework that defines the limits to human activities on the Earth system. It is a framework that is based on the biophysical processes that regulate the stability of the Earth system. So the limits or the boundaries are around climate change, freshwater change, the stratospheric ozone depletion. And as I'm speaking right now, I think 3 or so days ago, the whole of Southern Africa, for example, is experiencing an intense heat wave. The planetary boundary is also looking to ocean acidification, the biogeochemical flows, land system change, and biosphere integrity. So if these limits are exceeded, the environment may no longer be able to self-regulate. The environment is supposed to be able to self-regulate, but when we exceed the limits, we are bound to cause a lot of disruption. And of late, we've been experiencing these extreme weather or climate events. 2 years ago, I think it was declared that Southern Africa, for example, will face a 3-year El Nino period. So that may be 2024, 2025, 2026. And we are seeing, and we are right in the heat of it. What is it? That's how society is impacting the environment. And I think the environment is also impacting back. And we are in some kind of a conundrum. So there's a high interconnectedness between environmental degradation and public health. And we are saying human-induced environmental changes contribute leading to respiratory diseases and cardiovascular issues. Climate change has exacerbated the global burden of disease through extreme weather events and impacts on air quality, water availability, and food production. This interconnectedness of environmental degradation and public health highlights the urgent need to address challenges to safeguard human health. So in all that we are doing, it is human health that is at stake. The environmental changes have direct and indirect health impacts, and this calls for resilience building strategies to mitigate adverse health outcomes. 2 days ago, I was making a presentation somewhere, and I was saying the existing stock of buildings now, they constitute about 20%. So by 2050, 80% of buildings which are not existing now will be added to the existing stock. That's high levels of urbanization and high levels of environmental change and impact. And if we're not careful, we are really heading for serious planetary disaster. Now, the question becomes, to address this, what may be needed? And because I'm talking about promoting, normally if you want to promote, say, resilience, education comes in, be it formal or non-formal education. The question becomes how to integrate environmental education, say, into the school, university, higher education curriculum. We believe that with environmental education, the students or learners will be able to get knowledge on sustainability practices, which can help to reduce climate change impacts. And it also helps promote healthy awareness. The integration of One Health approach enhances environmental education, promoting a deeper understanding of social environmental issues. Thanks to technology, we are living in a digital world, and we can harness technology by integrating it so that we really understand what is eating us. And we also create a sustainable mindset. By so doing, that will help in empowering students with environmental education, which can lead to positive behavioral changes and increased environmental consciousness. So what are we saying with environmental protection education? We are emphasizing on awareness. How can we make everyone aware of the challenges that you have bedeviling us? We are emphasizing on knowledge, both in terms of its creation through research, and even dissemination, allowing us also to communicate that type of knowledge. And I know sometimes as experts, professors, doctors, researchers, we may have our papers in high impact journals, but also how do we communicate the same results to the general public? So the need for environmental, what we call science communication, towards shifting or helping in tuning the attitudes, and also inculcating certain skills in the people themselves or communities, including the students I talked about, to be more aware of mitigating or adapting to the conditions we are subjected to. So this will revolve around participation. As long as communities are participating, Saudi Arabia Vision 2030, for example, it aims to integrate solar energy, behavior change, recycling practices in schools to align to the vision and to improve quality of life and foster sustainability. So what are some of the health impacts which we have generally seen?
Prof. Chirisa, I'm sorry to cut you short. Thank you for that. We have to invite you for a full talk next time. I'm sorry about that. Our day is packed. We're trying to just make sure that we cover everyone. I'm sorry about that. Amy, are you ready to introduce Prof. Moyo? Then we move on to the next speaker. Thank you so much, Professor Chirisa. Professor Chirisa is the Vice Chancellor of Zimbabwe is a Kelguti University. He is also a visiting professor at National University of Lesotho. He is a PhD, two PhDs actually, one from University of Free State and another from the University of Zimbabwe. He is an expert in urban and regional planning. So we'll be glad to have you next time. We are going to have another symposium very soon. Thank you so much, Professor Chirisa. Amy, go ahead and introduce Professor Moyo.
Thank you so much. Ladies and gentlemen, I think we're off to a rocky start. We didn't really welcome you, so we're honored to welcome you all to the Zimbabwe Research Network for Society, Health and Environment Conference of 2024. It's truly inspiring for us to all gather here as a community committed to bridging the gap between science, policy, and practice to foster a healthier community. So this conference, I think, is a powerful testament of our collective dedication to addressing the complex challenges that intertwine society, health, and the environment. So I'm happy to be introducing our next speaker, Prof. Dingani Moyo, who is a senior consultant, occupational physician and professor of occupational medicine at the National University of Science and Technology. He is also a fellow of the Royal College of Physicians in Ireland and a fellow of the Faculty of Occupational Medicine. He holds a master's degree in occupational health and safety and another applied management, both from the University of Newcastle, Australia. So welcome, Prof. Moyo. You're on mute. Prof. Moyo, you're on mute.
Oh, okay. Oh, my apologies. My apologies. Good morning, good afternoon, good evening to all colleagues joining us from all over the world. I'm going to take you through the topic about the impacts of mining amongst vulnerable groups, and I'll draw a close focus in terms of artisanal and small-scale miners. So in terms of the outline of my talk, I'm going to just give you an overview of the global landscape of artisanal and small-scale miners, as well as incorporating the issues of the key impacts on safety, health, and environment, and then I'll talk more specifically about local research findings on artisanal and small-scale mining, and also give more information in terms of issues of gendered occupational safety and health issues amongst this vulnerable group. So in terms of, by definition, there is no standard definition on what artisanal and small-scale mining is, but generally, we define it as a range of mining activities that employ basic tools for extraction and processing with a tendency towards high labor intensity. In some quarters, you always hear the words that this is a trade that is associated with rudimentary or archaic mining methods or the use of very basic tools within this population. And artisanal and small-scale mining can occur either men and women working on an individual basis, or people working in families or in partnership or in cooperatives. And generally, these groups can range from individuals, even up to 1,000 who come together. But in terms of the key issues is the use of basic tools for extraction and processing. And that has got implications in terms of the associated array of occupational health safety and environmental issues that are associated with artisanal and small-scale mining. In terms of the global landscape, we know that artisanal and small-scale mining constitutes one of the world's largest mining workforce, with over 45 million artisanal and small-scale miners directly involved in mining. And this, you can compare this with the 7 million that takes place in terms of who are formerly employed in the industrial sector. But as of 2024, there were almost over 225 ASMs across Latin and South America, as well as Africa and Asia. This includes those that are directly and indirectly involved in artisanal and small-scale miners. But we know that those that are fully occupied in this position is over 45 million. So, and women constitute about 18% of this particular population, which is quite a significant contribution, which has been increasing over time. Just by way of statistics, you'll find that sub-Saharan Africa has got over 13.2 million artisanal and small-scale miners. In Zimbabwe, we have got the officially reported figures in terms of literature. We always talk about 500,500,000 ASMs, but the latest research, I think that was presented last week in Cape Town, has put the number around 800,000 to 1 million ASMs. But I still believe that this is an underestimation in terms of the actual involvement in artisanal and small-scale mining. So you can see that generally artisanal and small-scale mining is a big trade. Big trade, but however executed through just basic extraction and processing methods the world over. What is quite significant is that there's been quite a significant growth of artisanal mining. If you look at the global gold production in ASM from 1990 to date, there's been quite a significant growth, both in terms of cobalts as well as diamonds. What we see is an increase in the global production. So artisanal and small-scale mining contributes quite significantly to our economies, much more bigger than the formal mining that we are all aware of. What are the characteristics of artisanal and small-scale mining that we need to be aware of? Generally, like I said, that there is exploitation of minerals of marginal or small deposits of mineral resources. And in general terms, ASM has also been termed a poverty-driven trade. I think it all comes through the exploitation just of marginal or small deposits. Yes, you will find that a significant few are quite, could be rich, but the generality of ASM is exploits marginal resources due to lack of capital, and this trade is labor intensive, and the recovery rates are low, and the access constraints to markets. But what is more fundamental that you also need to bear in mind are the low standards or even lack thereof of safety, health, and environmental management standards in ASMs. And ASM also has got significant impacts on the environment, leading to environmental pollution and environmental degradation in quite large scales. And this happens globally and also in sub-Saharan Africa. So mostly this is informal on a global scale. And this is normally due to poor and ineffective regulation, leading to quite increased exposures to occupational hazards that I'll clarify in my next few slides, as well as gendered or occupational safety and health issues in ASM. One of the major issues that ASM finds itself heavily burdened with are the full array of occupational hazards. We know that compared to formal occupations, artisanal mining is really worse off in terms of exposure to noise, heat, vibration, as well as chemical hazards. And in fact, the silicon dioxide and mercury exposures are quite significant in this population. I'll just go through a couple of studies that you will see the current findings. One of the major issues also now, especially in gold mining, has been the issue of biological hazards, issues of elevated incidence of TB, which is one of the major problems. Where now in mining, we know that even in formal mining, the risk of TB in ASMs who are exposed both to silica dust and also are HIV positive is in excess of 15-fold. So even before they start buying, you can see that that whole interplay of risk factors is quite significant. And that is one of the major issues that ASMs are struggling with. Economic hazards because of poor mechanization and also working in workplaces that do not fit good safety standards. A lot of musculoskeletal issues occur within artisanal and small-scale mining. Of late, there's also been issues of gender-based violence, sexual exploitation and abuse, environmental pollution and degradation. There are major key issues within artisanal and small-scale mining. Okay, fine. So let me just give you a couple of our experience of the research that we've conducted locally, just to give an overview in terms of the burden of occupational diseases and injuries amongst artisanal and small-scale miners. In 2022, we conducted a research that looked at the triple burden of TB, HIV, and silicosis in Zimbabwe. And in terms of findings, which I will just summarize, the silicosis prevalence is in the range of 18 to 20%, which means basically 1 in 5 you've got silicosis. This might appear high, but if you compare with our 2020 study in Lesotho, where we found this prevalence of silicosis amongst ex-South African miners to be at a significant high of 43%. And this is a chronic, incurable, and progressive lung disease. And this is what basically the mining sector falls under in terms of the prevalence. And HIV is also a major issue within artisanal miners. In that triple burden study, we found that 19% of ASMs were HIV positive, and the burden of TB was over 7,000 per 100,000. That is almost 30 times the general population. This is similar results have been found in Tanzania, where a number of studies have been done, and their findings with respect to TB, silicosis is just the same as our study, and also a study done in Malawi showed the same thing, where the burden of TB is significantly high. So we have known that in the Southern African space, at the moment, we are currently suffering from what we call the triple burden of TB, HIV, and silicosis, because all these are interrelated. Like I said, that the TB risk factor, TB risk in people that are exposed to silica dust is 3 to 4-fold, and those that are HIV positive increase the risk for 5 to 6 times, resulting in a multiplicative risk in excess of 15 times. So you can imagine in ASM, where there are poor occupational health and safety standards, there's very minimal use of the hierarchy of controls, even the personal protective equipment. One study, a recent study that we did, looking at the knowledge, attitudes, and practices, particularly on TB, HIV, and silicosis in Zimbabwe, where we looked at 652 ASMs. And what was quite important, I think, contrary to the widely held belief that ASMs have got a poor health-seeking behavior, what we then found in this study is that there is a very good health-seeking behavior amongst artisanal and small-scale miners. As you can see, 97% showed a positive attitude towards to seek healthcare services when they are sick, and also they were also quite willing to use protective mechanisms. That is quite high, and I think this is a very important point that we need to take into account, especially for future programming, that in terms of the attitudes towards healthcare service, towards occupational health services, ASMs have got a very good positive attitude. But just to share some of the important findings in these studies, or that 49% of the ASMs out of the 652 reported consistent use of condoms outside their homes. So that means almost 51% indulge in sex outside of their marriages without the use of condoms. This is a very important factor when we look at future programming in terms of ASMs. Like I mentioned earlier on, that the healthcare seeking behavior is very good. But however, ASMs are constrained by the following challenges that we cited in our study, where they lack money to pay for healthcare, They have to travel long distances to clinics, and some cited shortage of medicines at clinics. So the health-seeking behavior is good, but however, it is the access that is constrained. In 2024, recently, we published one research on treatment outcomes of TB among ASMs in Zimbabwe, which was a follow-up observational study using secondary data. What we found there was quite interesting in terms of the treatment outcomes. Because of the high mobility and the operation in remote and hard-to-reach areas of ASMs, the initial impression will be the treatment outcomes will be very poor, because this is a highly mobile population that is always been thought as having a poor attitude. But what we found in our study, we found that successful TB treatment outcomes were recorded in 87% of the ASMs who were on TB treatment, which is very encouraging, that despite operation in remote areas or the high mobility nature, ASMs, the TB treatment completion outcomes are quite good. But however, an important finding was that more than 23% of these ASMs who were in TB treatment had a history of previous TB treatment. This is not surprising, especially when we know that silica dust or silicosis confers a lifelong risk to TB infection. So once exposed to silica dust, you will forevermore be at a high risk of developing TB. I think this is what this study was just showing. Other important findings was the high proportion of risk determinants amongst ASMs. For instance, smoking and alcohol, we had quite a significant percentage of people with that risk factor as well. And over 58% of those that were on treatment had silicosis. So we had silicosis, so that we are looking at issues of a silicotuberculosis being very high amongst this population. In as much as those risk factors were not statistically significant. In terms of accidents and injuries among ASMs, there are very high injuries that occur in ASMs, with over 35% in one recent study done by Singo et al., which is a study that we did around the Kadoma area, but where we found the high proportion of injuries and accidents. So in terms of injuries, this is one of the major issues that ASMs suffer from. A study we conducted in 2018 and another one in 2019 showed high mercury levels, exposures in more than 50% of exposed ASMs. So in short, more than 50% of ASMs had elevated blood mercury levels. A previous study done sometime around 2004 showed that 30% of breastfeeding mothers had elevated mercury levels in breast milk. That also is quite a significant issue that must be borne in mind in terms of programming and the future design of programs for artisanal and small-scale miners. So another important feature of artisanal and small-scale mining is the engagement by women and girls in gold mining or in cobalt mining or in diamond mining within the ASM space. But however, this also creates quite complicated scenarios when we look at exposed women in these mining situations. For instance, pregnancy-related occupational safety and health issues are quite high, as we all know that they engage even in this mining, even during pregnancy. And obviously that leads to heightened chemical exposures. You can take, for instance, if they are exposed to mercury or any other chemical, because of the increase in the respiratory rate, in the circulatory flow, that leads to faster distribution of chemicals than when compared to men. And also the physiological and anatomical changes that take place in pregnancy, you've got an effect in terms of the PPE. You will find that traditionally, personal protective equipment was designed for men. And now with women and girls coming into the space, there is still a challenge, although I must note that some manufacturers are now tailor-making their PPE for to fit the female gender. It's also known that human rights and gender issues are quite rife amongst artisanal and small-scale mining. So these are important issues that need to be taken into account within the ASMs. As I conclude, one important issue that we know amongst this vulnerable group is that there is a high burden of tuberculosis, a high burden of HIV, a high burden of silicosis. Mercury exposures are quite high. And this is a global problem. If you look at studies that have been done in Brazil, in Chile, amongst artisanal miners, and those that have been done in Uganda, the DRC, Tanzania, Malawi, and Zimbabwe, they all point towards this increased burden of occupational diseases as well as injuries within the artisanal and small-scale mining space. So it becomes quite imperative that when we program, we have to look at mining, especially artisanal and small-scale mining, in the context of the occupational exposures and also in the context of the trade itself, which I mentioned earlier, that uses rudimentary mining methods, very little occupational health and safety management systems. But of note is that contrary to the widely held belief, our ASMs globally have got a very positive health-seeking behavior. They are limited by issues of access. So that remains quite important when we look at programming, we look at developing resilient systems to take care of the health and safety of artisanal and small-scale miners. Ladies and gentlemen, this crowns my presentation so that we keep up with time. Thank you so much.
Thank you so much, Prof. Moyo, for this very insightful presentation and also shedding light on how ASM impacts the environment and public health. Your presentation has guided us in understanding how evidence-based strategies and inclusive policies can transform ASM into a driver of positive change rather than a source of unintended harm. Just a reminder to everyone, please feel free to engage on these topics via our chat. We will be monitoring it. And if you have any questions for any of our speakers, we will be channeling those questions to them. So in conclusion, the topic of ASM provides a microcosm of the broader challenges and opportunities that we will address at this conference. And it reminds us also of the necessity to foster collaborations among scientists, policymakers, and practitioners to create and sustain healthy communities. I will hand over to Prof. Edmond to introduce our next speaker.
Thank you, Amy. Just maybe Prof. Moyo, if you are around, some questions, and I'm sure we have other people who have got some questions for you. I know I was just fascinated by the issue where silicosis and then the co-occurrence with TB and other diseases. Is it possible that that exposure to silica is making these individuals more susceptible to these infectious diseases?
That's very correct. Remember, if you are exposed to silica, just a simple exposure to silica dust, and also those that have developed silicosis, they have got a 3 to 4-fold risk of TB infection. If they so happen to be HIV positive, HIV increase the risk of TB, HIV alone, of 5 to 6 times. So if you have got both silica exposure or silicosis with HIV, the risk of TB is multiplicative in excess of 15-fold. I think that puts this population quite worse off in terms of issues of tuberculosis. That is why we talk about this triple epidemic in Southern Africa. Quite true.
Oh, thank you so much. Not to blast you. I'm just thinking because we have people here like Dr. Panankos is a biochemist. We have Yvonne again, which is an immunologist, and I'm just thinking like, how can we develop really the issue of mining health in Zimbabwe? What can we do from our different fields to work together to address this important issue?
One important issue, first of all, looking at the issue that especially silicosis or silica dust exposure, it's conferring a lifelong, even if you decide to stop to mine today and you've been once exposed, you've got a lifetime risk of TB. So the main strategy to curtail silicosis or TB in mining is to institute preventive measures. And to take it a step further, by the time silicosis is diagnosed, it's already at an advanced stage. At the moment, science and research is focusing on predictive biomarkers, they are microRNAs, which could then be quite predictive so that we can pick up this silicosis well before it develops, because the moment it's diagnosed, it's too late. So now we want predictive markers, and one of the major issues, like I mentioned, there are biochemists here, microRNAs have come into play. There are a lot that are being explored. MicroRNA 145, 27A, 27B, microRNA 19A. Those are a lot of studies are ongoing. Recently in India, they developed a point of care test called the C16, Clara or club cell protein 16, where silicosis can be detected even in urine by a simple point of care test, but it still requires extensive validation. So a lot needs to be done. Scientists need to come on the table. And also the issue that silicosis is incurable. We are in search of a treatment methodology. There are a number of drugs that have been put on the market that have been cited as possible therapeutic agents, but more research is needed. There are quite a number of drugs, some drugs that can be repurposed. So there is a need to channel resources so that trials or studies, further research is instituted in the local context. So it still remains a nightmare. As long as mining lives, the risk of silica exposure and silicosis remains, and consequently, the risk of TB remains. So we've got all of us, we need to put our hands on the deck. Even from legislative point of view, we need legal frameworks that are protective, legal frameworks that are robust, so that we can take care of our miners. And lastly, the institution of comprehensive occupational safety and health management systems across workplaces, across these artisanal and small-scale mining areas would be invaluable. Thank you.
Oh, thank you so much. I hope everyone was listening. Prof. Dinganimo, like I said, is a professor at National University of Science and Technology. You can contact him for any collaborations. If you have any ideas that you want to fly with him, please feel free to contact him. I'm sure you'll be glad to guide us and lead us in this important area of research so that we can all pursue a healthy life and improve our quality of life. So everyone, please clap hands to Professor Dinganimoyo. Thank you so much for being with us. Thank you so much for this valuable insight that you've given us and this important challenge to the research community in Zimbabwe. Thank you.
Thank you. Thank you so much, colleagues.
Our next speaker needs no introduction to me, but probably to everyone else. We have Dr. Laura Mzingwane. She was unfortunate to be my classmate for a very, very long time. I think it was since 1995, 96 or so. So yeah, she was unfortunate to be my classmate. So Dr. Laura Msingwani is the cervical cancer prevention lead physician at International Training and Education Center for Health, which is part of University of Washington. She's in Windhoek in Namibia. She's particularly interested in cervical cancer prevention and improving access to life-saving prevention interventions for women. She obtained a medical degree from the University of Zimbabwe in 2010 and has a postgraduate diploma in public health from the University of South Africa. Allow me to introduce Laura to give us the next talk. Thank you. You can have the floor.
Great. Thank you very much. Good day, everyone. Yeah, I don't know who was unfortunate, me or you. But anyway, here goes. Thank you very much for the opportunity to share with you some of the work that we have been doing with cervical cancer in Namibia. Just confirm for me if you can see my slides in presentation, or you are seeing the presenter mode.
No, it's presentation. It's correct.
It's correct. Okay, great. Thank you. So I'll take you through evaluating differences in cervical cancer screening and treatment outcomes by HIV status, just to share insights from our Namibia routine programmatic screening. So the presentation will go through the global overview. I will take you through HIV and cervical cancer, talk a bit about the program overview and the findings from our study in Namibia, as well as new developments and potential threats to combating cervical cancer. So in 2018, the then Dr. Tedros, the Director General for WHO, made a call to action to have countries actually strengthen efforts in terms of eliminating cervical cancer. And it's saddening to know that one woman dies of cervical cancer every 2 minutes, and each one is a tragedy that we can prevent it. Can you imagine how many people have died since we started this conference the world over? This speaks to really the burden that we have in terms of cervical cancer. And when you look at the age standardized rate, mostly you find that cervical cancer is more common in the less developed world. And the more developed world have actually come up with ways to intervene and actually stop the spread of cervical cancer. And as you can see, Sub-Saharan Africa is actually the major brand in terms of the burden for cervical cancer. Looking at the incidence throughout the world, in 2022, 662 cases were recorded with an age standardized ratio of 14.1, and more than 350,000 deaths were recorded throughout the world. And the rankings that are here really pertain to both sexes in terms of cancer cases that are there, and they're actually much higher. And you find that in the world, and amongst females only, cervical cancer is the 4th most common cause of cancer. And in Sub-Saharan Africa, most countries is actually the 2nd after breast cancer. For mortality as well, it's the same picture. It depends in terms of where you are born and where you live. These really are some of the disparities that we see in terms of the management. 9 out of 10 cancer deaths actually occur in the less developed countries, as you will see from the statistics in the following table. As you can see, we have got Namibia. I'll be talking mostly about Namibia because I've been here for quite a long time. We have got the 2022 statistics showing that Namibia had an age standardized rate of about 33.5, and annual number of cases were 350. Annual deaths 204, with an age standardized mortality rate of 20.5. So you see there that majority of the cases actually in Namibia will end up dying. Then in the world, the age standardized rate is at 14.1. This is the average. Then compared to Afro, like I was saying, the African region bears the major brand. We are 26.4. And Zimbabwe is actually even higher. It's twice what we have in Namibia. Compared to countries that have done so well, that have implemented preventive measures well, like Australia, they are actually on the path to elimination. And you find that their age standardized rate is as low as 5 cases per 100,000. And the mortality rate is equally low at 1.4%. So in Namibia, about 350 new cervical cancer cases were diagnosed, and cervical cancer rates is really higher in the world. In some of the sub-Saharan African countries like Namibia and Zimbabwe. And of course, in Namibia, this is the second leading cause of female cancer in Namibia. So let's talk about HIV and cervical cancer. How does cervical cancer arise? Cervical cancer is more than 99% of cases are associated with the human papilloma virus. This virus is usually sexually transmitted, but can also be transmitted through physical contact, which is non-sexual. However, majority of the cases that do result in cervical cancer are as a result of sexual contact from high-risk subtypes of HPV or human papilloma virus. Now, HIV and HPV, they really have a perfect relationship in terms of potentiating each other. Women living with HIV are actually up to 6 times more likely to develop cervical cancer compared to their HIV negative counterparts. Being on antiretroviral therapy really does not really alter much this risk that women have. And as Winnie Banyana has recently said, it's really unethical for us to continuously just focus on making sure that women are on ARVs and having them die instead of cervical cancer with the viral load that is really suppressed. This is the unfairness part that we have. So what is it really that causes cervical cancer incidence to be high amongst women living with HIV? It changes the natural history of HPV infection. 90% of people who have ever been sexually active have been exposed to human papilloma virus, but 90% of the time they are able to clear this HPV virus infection. It is the remaining few that are unable to clear it who then have this resulting in cervical cancer. And HIV makes it difficult for the woman to actually clear this HPV virus. So they are more likely to have genital HPV infection in multiple strains as well, and have persistent HPV infection and early appearance of cervical cancer and cancer compared to HIV uninfected women. Whereas it will take 5 to 10 years before you start seeing any precancerous lesions. For women living with HIV, it can be as low as 1 to 2 years. And they also progress to death very fast, sometimes within 15 months from time of identification, just showing how fast the disease progression is. Coming to Namibia, so the NAMFIA 2017 study showed that we actually have quite high HIV prevalence. We have made significant progress though, from when you compare this with the early 90s and late 2000s. And currently amongst women at risk, that is those who are 15 to 64 years of age, HIV prevalence is around 15.7%. We also do have geographical variation depending on the regions that we have. And currently, Zambezi region is the one that is in the lead. It's a border town. And there's quite high traffic as well within these regions, as well as the northern regions of Namibia. Whereas in the southern regions, we have got relatively lower incidence, prevalence of HIV. Now, the cervical cancer space, there is quite a number of partners that are on board trying to really have pull together resources to try and improve the outcomes for cervical cancer and for women in general. So Namibia is part of the Go Further countries. So Go Further is a consortium of various entities led by PEPFAR and include also Merck and Roche, who have come together and pooled resources to actually target countries that have got the highest prevalence of cervical cancer, as highlighted here. Initially started as just about 6 countries, and then later on from 2021 expanded to 12 countries to involve all these countries. These countries, if you check their statistics, they all have high cervical cancer prevalence. Unfortunately, most of the funding targets the women living with HIV. Yes, they're at risk, but you also still find that even the HIV negative women do face challenges in terms of accessing services and accessing screening and treatment services, which could actually help them to prevent themselves from developing cervical cancer. So these are the disparities you have in terms of having access to life-saving services, which then impacts in the outcomes there. So now looking at Namibia now, in terms of what has happened, before 2018, Namibia was using pap smear as the only screening method, and screening was opportunistic. In other words, it was not really organized, and you have like a reminder, you need to come for your screening and get your screening services done. It was more of you, if you walk into the facility, if you are fortunate, the nurse offers you screening services, then you take them, or if you head somewhere, then you'll be able to take them up. So from 2018, Namibia then introduced the new cervical cancer screening guidelines, which were based on the WHO cervical cancer prevention guidelines of 2013, and they recommended VIA. VIA is visual inspection with acetic acid, which enables one to screen women and using acetic acid, the table vinegar, and you actually get the results instantly and are able to provide treatment within that single visit. So this is the screening method that was introduced in 2018, and the screening ages were according to we slightly lowered them because we do not have the HPV vaccine in Namibia and wanted to see really what the results would show. WHO was recommending screening to start at 25 for women living with HIV. We lowered it to 20 in Namibia, and then for HIV negative women, we also lowered it from 30 to 25. And screening through VIA would be every 3 years and every 5 years for HIV positive and HIV negative respectively. So you find that those who were above the age of 49 years, due to the anatomical changes that do occur on the cervix, they would not qualify for VIA. They would then have to go for pap smear, and it was also used during using according to the same screening intervals as indicated. However, in our analysis, we concentrated mainly on the VIA for the services that were provided. So after the launch of the program in 2018, so COFED came into Namibia May 2018 and helped us to develop the guidelines. We launched the guidelines, and in October 2018, we kicked off with the training of healthcare workers and providers. As you can imagine, there wasn't anyone trained in VIA as well as cryotherapy in then Namibia. And we established the services first for the first 3 months in Khomas region, where the capital city is, Windhoek. And then from February 2019, we then disseminated to 6 additional regions based on the HIV positive numbers of HIV positive women. So in the beginning, we're using cryotherapy. We mainly use nitrous oxide gas to treat the precancerous lesions that would have been identified on the cervix, and then later on switched to thermocoagulation after WHO had approved the use of thermocoagulation for treatment of precancerous lesions, and that was in September 2019. So looking now, we analyzed the routine programmatic data from the cervical cancer screening program from 7 of the 14 regions. As ITEC Namibia, we supported 7, which is half the country, on implementation of cervical cancer prevention activities at the beginning. Then later on, we expanded. But for this period, we're supporting namely Erongo, Karas, Kavango East, West, Khomas, Oshkoto, and Ochosonjupa, which is a mixture of the northern regions I showed you, and some also in the central parts of Namibia. So we had to then integrate services for cervical cancer within the routine HIV clinic settings. So initially, we did not have integration. I know WHO is now pushing for integration of services, but we had standalone clinics called the CDC clinics or ART clinics, where ART services were being provided. So this is where, because of the target for the most at-risk women, we established the screening services and then looked at the screening outcomes as well as treatment completion by HIV status as well as by age. And then we also applied a bit of statistics in terms of looking at the data in terms of getting the significance there. So from looking at the results in the first 18 months of introduction of the program, we had trained 121 healthcare workers in VIA and ablative treatment, as well as 10 medical officers trained in large loop excision of the transformation zone and biopsies. I must also pause here and say, before 2019, we only had one colposcopy or one lead site in the country which was functional. The second one was just in another region, but it was non-functional. So it meant the whole country, as vast as it is, all treatment procedures had to be done in one place, the advanced treatment procedures. So with this activity, we actually managed to have the services decentralized to regional level, and as of the close of 2023, we now have a lead site in each of the 37 districts of Namibia. So, but as of 2020, it was just 10 medical officers trained, 4 net mentors who were also recruited to provide supervision and monitor the programmatic performance as per WHO guidelines. And we managed to conduct 14,786 screenings, 8,150 of which were first-time screenings, and 1,804 treatments were provided, and managed to set up screening services in 50 public health facilities. Then looking at the screening results, of the 8,150 women who received their first VIA screening, 4,805 were HIV positive and about 39% were HIV negative. So when we look at the ones who screened VIA positive compared to the HIV negative, we find that as expected from the literature, we found that there were more, more VIA positives amongst the HIV positive women compared to the HIV negative. And then of the 1,308 who received their first screenings, 33% were ineligible for cryotherapy or thermocoagulation. So cryotherapy and thermocoagulation would crudely be used as a measure to look at the severity of the lesion. So if the lesion is a little bit small, we use heat or cold to destroy the lesion. But the other criteria, if it is quite extensive, then it needs LETs, which is excisional treatment performed by the medical officers. So looking at this, if we have more that require LETs, it means that you've got more advanced lesions loosely applied. So it was quite common amongst women living with HIV, which is also in keeping with what the data we have previously compared to HIV negative women. And they were more likely to, although this was not statistically significant, women living with HIV were also more likely to present with suspect cancer compared to HIV negative women. So in terms of the results from the screening, you either get a VIA positive, which means there's a precancerous lesion, so eligible or ineligible for thermocoagulation, means you can be treated by the nurse. And when it is ineligible, then it's treated by the medical officers. And when we have suspect cancer, it's almost cancer, is too advanced and now needs to go for diagnostic investigations, to put it out there. Then looking at the treatment completion, we had quite good treatment completion rates. Looking at the data that we had, about 2,272 women who were screened VIA positive and follow-up, 82% of them completed ablative treatment. And it was also noted that treatment completion was high amongst women living with HIV at about 86% compared to HIV negative women, which was really also statistically significant. And looking at the age groups as well, the treatment completion rates were lower amongst the younger age groups. 25 to 30-year-olds by 8% and 5% among HIV negative women compared to the, in the 25 to 30-year-old compared to the 20 to 24-year-old. And it seems the older women were more likely to complete treatment as well. Then VR-positive women living with HIV completed same-day treatment more often than HIV-negative women, and that's about 68% of those. And then among those referred for LETs after any screening, 77% also completed treatment. This was largely due to having the services a bit closer to the women. They were now at the regional level compared to when initially we had them to all going to a central place, which is the equivalent of sending everyone for treatment to Parenya Hospital across the country. And so these higher rates of VR positivity, like I said, they align with also other published literature. However, they were not as large as we expected. So probably we thought this could be due to the fact that the women were actually on antiretroviral treatment and also virally suppressed, as the NAMFIA study reported that actually 92% of women living with HIV in Namibia are virally suppressed. So I find that compared to other countries where you have 40 to 20% variation, 14 versus 5%. Ours was really just 17 and 15%, which was low. So also a systematic review proposed viral suppression through ART supports immunological response to clear HPV. Although despite being virally suppressed, it does not really go to the same level as a woman who is HIV negative. And the completion rates really showed that it was using ablation was acceptable and also feasible in resource-limited settings. One of the challenges we had faced with cryotherapy was having to carry large containers of gas if you're going to do any treatment on this patient. And this is like a 70 kg gas tank that you have to move around with. Now with thermocoagulation, you actually have a portable handheld device that you can go with and you can pitch up your tent in any of the hard to reach areas and actually be able to provide services there. So, however, in contrast to results from Zambia, where treatment completion was similar across HIV zero status, we observed that there was significantly higher completion rate in women living with HIV, 86% compared to 77%. This could be attributed to the integration of services in the ART clinics. And this also could have shown that there might be a bit of stigma associated with visiting the ART clinic. So whereas those who are living with HIV are now used to interacting with health systems and are able to easily access services, it's another thing to be screened at a PHC facility or other and then be told go for treatment in the ART clinic. So people don't usually want to associate with those clinics. And as such, we are also working with the ministry to move towards more integrated services instead of having standalone clinics as well. In terms of year positivity, we're well within the range is expected by WHO, 5 to 25% there. I already discussed about the ineligibility as a proxy for size and severity of the lesion, and we did observe that this was quite high amongst the women living with HIV. So results do highlight the importance of availability and linkage to advanced treatment options in settings with a high HIV burden. So what were the lessons? Some of the lessons that we learned that within a short time, you could actually scale up services and decentralize services to have them closer to women. And the treatment completion rates that we observed there, compared with the the delivery data that we had for screenings that were done and treatments that were done at the Windhoek Central Colposcopy Unit, we demonstrated that if you move services closer to women and improve the accessibility and affordability of services, is more likely to succeed. So we continue to expand and supporting Namibia to work towards the WHO cervical cancer elimination targets, which will then go on to we'll discuss a little bit before. And this is also in relation to introduction of HPV tests into the screening and launching of HPV vaccination program, which will also support policymakers. So what is next for us? We are working towards adopting, actually we have adopted the WHO's elimination strategy, and this is the global strategy to accelerate elimination of cervical cancer as a public health problem by 2030. So by elimination standards, we need to have achieved 4 cervical cancer cases per 100,000 women years to declare elimination, and Namibia is currently at 33.5. Remember, I told you Australia is at 5.3, so they are most likely to actually reach these targets before us. And as guidance, WHO has provided us with targets to reach by 2030, so that ensure that we are on the path for elimination, and that is to have 90% of girls to be fully vaccinated with HPV vaccine by the age of 15, 70% women screened with a high performance test at least twice in a lifetime, screening at 35 and 45, and 90% of women with precancerous lesions or confirmed cancer to be managed. This is the comprehensive strategy that WHO has outlined. Namibia has adopted this, but funding constraints are still quite a challenge for us in terms of introducing this. So this is the current status. Sorry, this is actually supposed to be 2025. We still do not have the HPV vaccine available in the public sector. It's available in the private sector. We have developed the policy and strategy as well as the communication plan, and we are in the process of procuring 4,000 doses for the initial introduction. Secondary, as recommended by WHO, we need to be moving on to HPV DNA testing. It's available in the private sector, and we are working towards having this in the public sector by 2025. The policy is in place. We have assisted the ministry to get this organized, and the rest is already in place as well, the VIA, PAP, and thermocoagulation, as well as LEDs. We are still struggling, also like most African countries, in terms of the tertiary services. Currently, we only have 1 radio-oncology unit at the main referral hospital in Windhoek, and this is something that we are also lobbying with the GO further to see if they can assist the country to establish another unit in the northern region. So we cannot close this talk without talking about climate and the effects and the threats that we do have in terms of implementing cervical cancer preventive efforts. So access to services is really still something that is challenging. And with the current climate changes and the like, we find that roads with all these upheavals, they really disrupt services. And we also cannot run away from unpredictable pandemics that do come up. COVID-19, we all now blame everything on COVID, but really it had quite a significant impact in terms of interruption of services. And we still have the healthcare workers who are the heroes, the unsung heroes, who cross rivers with vaccines just to try to reach the populations and mass who are in the hard to reach areas. And these are the things that we also need to consider as we move on in terms of improving accessibility. WHO is also introducing self-care interventions. For example, for cervical cancer screening in some countries, they already do self-collection and there's no need to visit the facility. This can also be done in the community, and only the ones that need treatment would end up actually visiting the healthcare facilities. So we still need to continue working on this and come up with other ways to assist our population. Thank you. I think that's my last slide. Over to you, Edmond.
Thank you so much for the wonderful talk. I'm sure we have learned much, and I'm going to open for 2 questions. If anyone has a question, please post it in the chat. If you have a question, post it in the chat. Any questions, and Tatenda?
Not at the moment. should we have any questions, Laura, we will definitely reach out to you. I hope you will be part of the conversation throughout the day.
Yes, so Tatenda is in the economic side of health, so I'm sure we can have fruitful interactions. Then we have Prof. Dingani and Prof. Nune as well. I'm sure they are all eager to get into contact with you, because when you were talking after Prof. Dingani's talk, I was asking myself, okay, do we have a similar problem of women's health, particularly cervical cancer, among mining communities? Like, is it possible to do something really to look at that? Maybe I'll throw that to you.
Yeah, thank you. I think there is, considering the profile that Prof had actually given in terms of the mining communities and what goes on, most likely with the high HIV prevalence and the poor socioeconomic statuses, and also even knowledge in terms of accessing services and self-care. I'm sure we actually have quite huge challenges as well in that group of women.
Yes, my last question before I bring Prof. Nunu. I noticed you highlighted how in Namibia they're emphasizing training of healthcare practitioners. How can we, particularly, I'm looking back in Zimbabwe now, like how can we incorporate that strategy really of emphasizing training? Like which institutions need to take to take up the challenge? We have Prof. Dingani from the School of Medicine here. We have Nyasha Nkonoshiro again from School of Medicine. I'm sure they are eager to hear how can they take up the challenge of training our future professionals, especially when it comes to cervical cancer prevention.
Thank you very much for that. So there are two modalities to the training. There's the pre-service training, which everyone should actually undergo. And this was something that we realized that some of the components of the cervical cancer training were actually not included in the Namibian context. And then the other one, in-service training, as new developments come. I know we have got a CPD accreditation. Sometimes people submit, sometimes people don't. But having this as a structured approach and actually mandating that all the primary healthcare providers should be able to do this and this and this, and actually having a dissemination strategy in place whenever there are new advancements in cervical cancer prevention or any other field for that matter, just to make sure that we keep our population of healthcare workers actually trained. The other thing that we have really neglected as well are the community healthcare workers. When we hear healthcare workers, we are always targeting the nurses, the doctors at the facilities. But the people who need to do the most work are actually in the community, who have to educate the population so that they can also improve their health-seeking behavior. So these are some of the people that we need to also consider teaching. Then for the medical school, there's something that I think in Zimbabwe, we, at least from the time that I left, we had not really worked on. That is actually task shifting, because like for us in Namibia initially, LETS was done by a specialist gynecologist, but we had such a few number of those, such that we ended up saying, approaching the Health Professionals Council and say, if we have adequate training, can we just task shift and have this actually being done by the average medical officer? So those are some of the things that also as the medical school they can look into in terms of task shifting. Thank you.
Okay, we have more questions. I'm sure this was an exciting talk. You have all the time to answer, so don't worry. We are still going to, I'll start off with, I think, Catherine, because Catherine's question is really kind of very specific. She used language that as a chemist, I'm not familiar with, but I'm sure you are familiar with it. Catherine is saying, just thinking, are there plans to integrate this screening in IBBS, bio-behavioral surveys for KEP POPs? This would help tracking and treatment in female sex workers. If you have a comment on that one.
Thank you, Catherine. So currently we do not have that in place. we are in the process of putting a stigma and discrimination, as well as training of healthcare workers as well, to make them offer services that are tailor-made for the key populations. And for key populations for the group, these are people who are mostly at risk of contracting HIV, and they're also at risk of other things like intimate partner violence and the like. And this also includes female sex workers, transgender communities, as well as those who are marginalized. So currently in Namibia, we do not have, but we're working towards actually developing these surveys as part of the training curriculum for healthcare workers, and to make sure that they actually provide services that are tailor-made for the key populations.
Oh,
Thank you.
thank you. Thank you. There is another question coming from Chantel. Chantel Mangitsa says, which age groups are most responsive and which ones are least responsive to treatment? She's mainly focused with when it comes to treatment.
Okay, great. Thank you, Chantal. So from our study that we had, with the limited data that we had, we actually found that the younger population was not so responsive to treatment compared to the elderly. We're wondering, is it about stigma? Is it about just not being used to interacting with the health system compared to the elderly, who are probably being managed for other chronic diseases, the NCDs and the like, and they know that they actually have better health seeking behavior and know that they need to get the attention for whatever diseases or issues that they might be having. But it'd be good to look at other data from other countries as well to see if there is a similar picture.
Okay. We have another question coming from Muyaudziri Mago. It says, you stated that one woman dies of self-treatment. How prepared are the budgets in developing nations to cater for the funding of cervical cancer prevention and screening?
Great. Thank you, Muyaudziri. This is actually the challenge. The people who need these services, they can't afford to access these services, and governments also somehow cannot afford, and some are not prioritizing women's health issues. So you find, like I was talking about, the Go Further partnership is donor funded, and most of the donor funding, it comes with its own specific targets and specific frameworks in which you are supposed to then operate. And governments are not really ready, especially in sub-Saharan Africa. I find that majority of those that are really doing well are really still relying on donor funding. I can talk about also the HPV vaccine introduction. The Gavi supported countries. Gavi is the Global Vaccine Alliance that assists countries to actually acquire vaccines and at a subsidized cost to the government. Then this is done according to the HDMI index, whether you are middle income, low middle income, and the like. So for countries like Namibia, which are classified as upper middle income countries, they don't qualify for Gavi funding. And you find that this has dragged the introduction of the vaccine for years, because the government still is not able to commit the funding that is needed to actually run a vaccination program. So that is just one arm. And the other thing is, when you talk about HPV based screening, it's cost effective in the long run, but to set it up, it's actually very expensive. And so you find that these are the challenges that you find in countries that are lagging behind in terms of introduction of HPV vaccination. So we continue to lobby them, but there's still more that needs to be done.
Oh, thank you so much. Oh, questions keep coming. Next one is from Crossman, who's saying, I would suggest that policymakers push the issue of collaborations in dealing with health matters. Collaboration has been seen to add value than integrated disease support. Then, yes, that was a comment from Crossman. And just to answer Crossman, that was the idea behind this whole conference, where we are bringing experts from different fields, experts from different areas, so that we can gather together and discuss about these issues and come up with some solutions. You can comment, Dr. Laura.
Oh, thank you. I think you said it perfectly well. Yeah. So we are really pushing for really dismantling the siloed approach in terms of the activities that are being done. And like you are saying, you find that you've got various partners that are funding certain aspects of health. Like, for example, you find one is funding family planning or contraceptives, and someone is funding ART, and someone is funding the cervical cancer. But some of the resources, they can actually be pulled, and you actually have one plan, and you don't have redundancy in terms of doing the same thing, probably spending excess funding. So this is something that we are also pushing for. And in support of this, also PEPFAR has pushed for integration, even starting with the healthcare workers, because we used to have a nurse for cervical cancer, a nurse for ART, a nurse for TB. But this is the same healthcare worker who has received all these trainings. Why not integrate and find other loopholes that are there in terms of funding or resources where you can actually plug in instead of just having spreading resources like that. Thank you. I hope that helps.
Thank you so much, Dr. Laura Msingwan, for the wonderful talk. I'm sure everyone can witness that copying Edmond really helps. She'll copy it from me. That's why she's really this good. So thank you so much for being with us. It was an honor and privilege to hear from your excellent insights. I'm sure you are going to get emails from people here because this was an exciting talk, a lot of engagement. I'm going to hand over to Emmy to introduce to us Dr. Yvonne Dube. Thank you.
Thank you so much, and thank you for the opportunity as well. Good day.
Thank you so much, Dr. Laura, and thank you so much, Professor Edmond. And before I introduce the next speaker, if you have just joined us, welcome again to the SHE conference for 2024 under the theme, Bridging Science, Policy and Practice for Healthier Communities. We are so glad to have you here. In this morning session, we are talking about the transformative solutions in urban health for equity and resilience. We have had such brilliant speakers since we started at 9, but you haven't missed out yet. This conference, as a reminder, is brought to you by the Zimbabwe Research Network. In terms of who we are a network that aims to foster a vibrant and inclusive community of Zimbabwean scholars, professionals, and experts, both at home and abroad, that actively contribute to the academic, research, policy, and governance development of Zimbabwe. Our mission, once again, is to enhance academic capacity building and promote research and innovation within Zimbabwe by facilitating meaningful collaborations, partnerships, and engagements between Zimbabweans globally. We strive to influence national policy by providing evidence-based insights to create opportunities for international and interdisciplinary collaboration that contributes to the progress and prosperity of Zimbabwe. By harnessing the power of our diverse and dynamic diaspora, we aim to make a significant and lasting impact on our nation's academic and governance landscape. I will now introduce to you our next speaker, Yvonne Dube. Yvonne is a PhD researcher at the Institute for Infection and Immunity at the University of Melbourne in Australia. She has previously worked as a clinical laboratory scientist at Gamma Allergy and Immunity Laboratory. Yvonne holds a master's in medicine, clinical microbiology and biochemistry from the University of Witwatersrand, and a Bachelor of Science in Applied Biology and Biochemistry from the National University of Science and Technology. I think I know Yvonne. I kind of grew up with her. Yvonne, are you there? I hand over this talk to you. I'm so proud of you for, coming this far. You make me so, so proud. Well done. I hand over to you now.
Thank you, Amy. Yes, it's the you want that you know from the hood. Yeah, so let me try and share the screen first. Please confirm if you're seeing the presenter view.
It's in presenter
No.
view.
Yes. I
It's in
think
presenter
you
view.
can
Okay,
change
thank
it.
you.
Yeah.
Okay, so thank you for that. I'm
I
gonna
think-
start with hello.
Yvonne, you need to change your slides. We still see the presenter mode.
Oh, it's in presenter mode. Okay,
So
let me
go to
try.
display settings. And
Okay,
you
sorry,
can,
let me try again.
yeah. Yeah, no, that's fine. You can presentation. Perfect.
Okay. All right. So I will start. So I'm going to present some of the work that I'm actually doing as part of my PhD, that is investigating the role for non-viral CSA antibodies in protection from placental malaria. And this is just the basic outline of what I'll be presenting. Just look at the malaria in pregnancy, then I'll move on to pathogenesis of placental malaria, and then I'll move on to the antibody response to PFAS parent proteins, and then look at the potential antibody targets, which will then lead us to the study aim, the hypothesis, and the research question, and then the study design that we used in this study, and also look at the results that we got and the key takeaway points, and lastly conclude and address some limitations that we had. Okay, as you all know that malaria is caused by Plasmodium falciparum, most especially in Africa. We'll start with the statistics where it was where the WHO malaria report recorded that 35.4 million pregnancies were recorded as of 2022 in 33 endemic countries. And from these, 12.7 million were exposed to malaria infection during pregnancy. And these infections were highest in West Africa and Central Africa with a prevalence of around 40%, and were low in East and Southern Africa with a percentage of around 27%. From these few statistics, we can still tell that malaria in pregnancy is still an important global issue. And since we're talking of malaria in pregnancy, in this case, in Africa, the PFAS is the dominant malaria parasite that is responsible for most deaths. So in pregnant women, the virulence of Plasmodium falciparum manifests as placenta malaria, which is the primary mechanism that results in malaria in pregnancy. And because of that, it results in adverse perinatal outcomes such as preterm birth, the low birth weight, and the like. So this arises by when placenta malaria in this case is characterized by the infected red blood cells, which attach to the apical membrane. Let me try and get the data in this case. So we've got the infected red blood cells here, which attach to the apical membrane of the sincere trophoblast, and they accumulate in the intervillous spaces here. If we zoom in, you'll notice that this infected erythrocyte or the infected red blood cells have got a protein that is expressed on its surface, and this protein is the one that facilitates the binding receptor on the lining of the epithelial cells in this case. So what do we know about antibody responses to Plasmodium falciparum proteins? They appear to be important determinants of protection from placental malaria. However, it's still unclear as to what are the correlates of protection in this case. And the lack of immune correlates of protection continues to slow down vaccine development. And hence, that's why we need to understand how antibodies protect pregnant women from malaria. So one approach to developing vaccines is to identify the malaria proteins recognized by antibodies in plasma. And before we move on to that, I want to just take you through the life cycle of the Plasmodium falciparum in this case. What happens is that when the mosquito bites the host, it then feeds on the blood, and as it does so, it then the sporozoites or the parasites are then transported into the blood, and they get to the liver, where they then transport to the hepatocytes and develop into merozoites. And once that happens, they're then released from the liver, and then they're ready to invade the red blood cells, where they get to ingest nutrients in the red blood cells and develop into the different forms, that is the ring form, the trophozoites, and the schizons. Some may develop into gametocytes, which are then taken back into the mosquito and transported to another host. So that's how transmission occurs. So in our study, we're interested in some of the proteins that are expressed in these different stages. So one of them was the Plasmodium falciparum circumsporozoid protein, which is expressed in the sporozoites. And this is also was used as a subunit of some of the vaccines that are currently being rolled out for children, that is the R21 and the RTSS vaccines. And then we're also interested in the proteins that are expressed in the asexual reproduction stage, that is namely the schizon egress antigen 1, as well as the glutamic acid-rich proteins, which are expressed in the schizon stage just before these merozoites are released to reinvade the other cells. So the other proteins that we're also interested in this case were the proteins that are expressed in the merozoites. And for us to understand why we chose those particular merozoites, I'll have to take you through a further case where we see how the merozoites invade the red blood cells in this case. So this is just the red blood cell. And we've got the merozoites in this case. So what happens is that once it's released, it then attaches to a red blood cell. And then in this case, it undergoes attachment. And then if it's happy with the red blood cell, it then reorientates itself such that the apical end, this end, attaches to the membrane of the red blood cell. And when that happens, it then invades the red blood cell with the aid of a motor, a moving junction. And then this results in mature invasion or full invasion into the red blood cells, where they then use the nutrients to further mature and multiply. So in all these stages, there are proteins that are involved in each of the stages in this case. And if we zoom in and look at the structure of the merozoite itself, that it contains a nucleus and there are different organelles that are also present in the merozoite. And most of these, you've noticed that the merozoite has more than 800 proteins on its surface and in the organelles. So in this case, we're interested in representative merozoite surface proteins, that is the MSP1, MSP2, MSP3, and our expiratory protein MSP9. And some of these, we're also interested in the vaccine candidates, that is the MA1, and also the RH5 as well, that is the Plasmodium falciparum reticulocyte binding homologue in this case. As I had initially mentioned, that once the parasites reach the placenta, they express a certain protein that is only restricted in pregnant women, that is the VAR2CSA, which then binds to the chondroitin sulfate A in this case, and this occurs in the intervillous space. So we're also interested in the proteins that are specific to pregnancy in this case, and also because it has been mentioned or reported that the domain or the subunit of the VAR2CSA is also immunogenic, we also looked at its domain, that is the DDL1 ID today. So what do we know about antibody response to VAR2CSA? It has been shown that it's associated with protection from placental malaria and adverse pregnancy outcomes. such as maternal anemia, infant mortality, and morbidity. But to date, we still do not have any VAC2CSA specific vaccines. And the ones that were actually developed, that is the PAMVAC and PRIMVAC, they were not that efficient, and so they were discontinued. But then we do have other vaccines based on other parasite proteins that have progressed to clinical trials, such as the RH5.1 and the R21, as well as the RTSS vaccines. So in this case, in our study, we use the system serology approach to try and investigate if we can look for other antibodies to proteins that other than VAC2CSA that can contribute to protection from placental malaria, and in that case, allow us to develop vaccines for pregnant women. So we hypothesized that antibodies to merozoic proteins and the proteins that are active in the schizotomy or in the schizol stage, as well as the VAC2CSA, are associated with protection against placental malaria. So how did we approach this? We used the Malawi IMPROVE cohort. So IMPROVE is the study on which these pregnant women were recruited. So IMPROVE stands for Improving Pregnancy Outcomes with Intermittent Preventive Treatment in Africa. So it involved pregnant women who were selected. In this case, pregnant women were selected at enrollment, and they were all infected. At that time, they were actually at mid-pregnancy, that is around 16 to 28 weeks, and they were undergoing IPTP treatment. So IPTP is the intermittent preventive treatment in pregnancy with either dry hydroartemisinin piperacin or sulfadoxine pyrimethamine, or a combination of dihydroartemisinin piperacin with azithromycin. And like I said, these samples were collected at enrollment. And for us to check whether they had placental malaria or not, we had to use the placental histology data at delivery and group these into pregnant women who had evidence of placental malaria and those who had no evidence of placental malaria. So that was collected, and then we used the plasma to measure the antibody levels in these pregnant women. So how did we approach this? So we used a high throughput technology known as multiplex immunoassay, which uses, in this case, we've got our beads, our magnetic beads, which we couple with the recombinant Plasmodium falciparum proteins. So each color here represents a different protein that we coupled. And then these were incubated with the immune plasma. And then we added our fluorescent detector to detect different antibodies, that is the protein-specific IgG, as well as characterize the IgG subclasses, the IgA subclasses, IgM, and we're also interested in using the recombinant FC receptors to detect how well the protein-specific antibody can engage the FC receptors on the surface of immune cells. And also, we wanted to look at how well the antibodies were able to activate the complement pathway to help clear the parasites from the blood system. So with this technology, we're able to assay for 13 antibodies at the same time. And with 163 plasma samples that we use and 13 recombinant proteins against the 13 detectors, we had a lot of data set that we had. And further studies have shown that recognition and functional antibody responses are probably more important measures than simple quantification of IgG responses to recombinant proteins. So we did not stop there. We went on to look at the recognition and functional assays, where we wanted to further understand and see if these antibodies or the plasma, was it able to recognize the protein that is expressed on the surface of the whole parasite in this case? And if it was able to recognize, was it able to were these antibodies able to neutralize or block the binding of these parasites to the chondroitin sulfate A, which is usually found in pregnant women? And we also wanted to find out if these antibodies, if they opsonize the parasite, were they able to induce phagocytosis by the THP1 cell line or the monocyte, or by the neutrophil as well, because they express different receptors on those cells. And since we're interested in antibodies to other antigens besides the VAR2CSA. We wanted to find out if antibodies to the merozoite itself were able to induce phagocytosis by the THP1 cell line, okay, or by the neutrophil. So our results show that in this case, we looked at the Malawi pregnant women where we collected the samples from 5 different sites, that is Mangochi, Zomba, Mpemba, Madziabango, and Chikwawa. And this is the clinical characteristics that we're interested in, that is age, birth use, gestational days, gravidity, that is how many times did these pregnant women get, did they get pregnant? That is once, primi gravidi, twice, secundi gravide, or more than three times, that is multi. And we also looked at the IPTP arm as well as the hemoglobin in this case, and also the site from which the samples were collected. But what's interesting is that it seems like these age as well as gravidity and site, there were great differences between the two groups, that is those who had placenta malaria and those who had no placenta malaria, suggesting that probably these three clinical characteristics could actually contribute to act as confounders in this case. So from the results that we had, we plotted a volcano in this case where we've got our negative log of 10, the p-values here in negative log, and then our odds ratio, that is what's the likelihood of these antibodies to increase the risk of placenta malaria or protection in this case. So the results were not as we expected in this case because most of the antibody features that we measured seem to have the odds have to be associated mostly with the placenta malaria, and very few antibody features were associated with no placenta malaria. But what's interesting is that the CSA binding inhibition, that is the antibodies that neutralize the parasites in this case, were associated with no placenta malaria, which is what we expect in this case. And the IgG binding parasite was also associated with no placenta malaria in this case, which is what we expect in this case. What's also interesting is that we had IgA measures popping up in pregnant women who had no placenta malaria, which is something studies have shown that IgA measures seem to be contributing to protection in this case, but we're not sure whether if that's the same case in this study. But the takeaway message in this case is that most of the antibody features were associated with placenta malaria, and the ones of interest in this case were very few that were associated with no placenta malaria. Further on, we wanted to find out how well correlated were these antibody features. So we had to do a correlation network where each dot represents a feature, and the thickness of the lines and closeness of the dots represent the strength of the correlation, with only significant correlations shown in this case. So the responses to VAR2CSA here, as well as its subunits, the DBL1 ID2A, was formed a cluster on its own. As you can see, it formed a cluster on its own, which is separate from all the antibodies to the other antigens. And what's interesting, or what we expected as well, was that these antibody features to VAR2CSA and the DBL1 were also strongly correlated with the functional and recognition assays that use the whole parasite, that is the parasite that express this protein on its surface. And then what's also interesting is that we had IgM and IgA1 forming clusters of their own. In this case, we thought maybe it could be associated with the structural biology, since IgM exists as a pentamer, and then IgA1 usually exists as a dimer in this case. So we thought maybe it had something to do with its structural biology that was resulted in it forming a clusters of its own. We then, from this, but we still didn't have the information that we needed, whether how are these antibodies contributing, or how do they help us predict whether they have placenta malaria or no placenta malaria. So we went on to carry out some machine learning We used a machine learning tool. In this case, we used the simple lasso, that is the least absolute shrinkage and selection operator, which actually selects all those features that we saw, and it only selects like those antibody features that help predict placenta malaria or no placenta malaria by shrinking all the other features to 0. And then, so when it did that, we then remained with only 10 antibody features in this case. Of the 10, only 4 out of 6 were associated with the increased odds of having no placenta malaria. And again, but we still had 6 antibody features that out of 6 that had the increased odds of having placenta malaria. So in this case, the sign here just represents the direction of the association, and then the coefficient represents the strength of the effect in this case. So I wanted to further look at how these antibody features, the selected antibody features, were different between the two groups, and whether it aligned with the odds ratio that we had in the volcano plot or not. So as you can see that there were differences between the antibody features that predicted no placenta malaria, and these differences were quite significant. And we saw the same thing with the antibody features that predicted placenta malaria. In this case, they were all significant differences. So the key points or the key takeaway points in this case is that our analysis showed that few antibody responses were high in women without placenta malaria compared to those who had placenta malaria. But you'll find that we still had most antibody responses that differed significantly in the pregnant women with placenta malaria. And what's also interesting is that the simple lasso showed us that the binding inhibition, that is the assay which has the neutralizing antibodies in this case, was a strong predictor of protection from placenta malaria. The other thing was that the IgA1 responses to Merazoids showed moderate to weak contribution in protection. Though we had the IgA1 measures, the contribution was kind of weak. So we're still trying to figure out whether could it be just these were just antibody levels that were measured, or they were actually associated with protection. So the next thing that we're going to do to conclude is that there was limited evidence that non-VATO-CSA antigens or proteins play a protective role. And so the further work that we'll do in this case is to further analyze this data set and control for confounding variables such as age, gravidity, IPTP arm that was administered, as well as the site. The limitations with this study was the sample size. In this case, as you noted, that we only had around 163 samples. And with the Malawi cohort, we had, I think, around 1,000 samples, of which only those who had evidence of placenta malaria were around 163, which was quite a disappointment in this case. So probably we are thinking that probably this could have affected the results that we got. And the other thing is that we used pregnant women who were infected at enrollment in this case. So we're not sure whether could it be a bias in this case, that the fact that we used infected pregnant women, we're still thinking probably maybe the uninfected pregnant women could give us better results. We don't know. And the other challenge is that this clinical data set, we are missing the parasite count, so which could have been included, and we could have correlated just to see whether the more antibody features that we saw in pregnant women who had placenta malaria, could it be due to the fact that they had high parasite count in this case or not. So since we do not have the parasite count, we cannot really tell whether it could be the issue, or it's just that these pregnant women who were infected at enrollment had high antibody features, mostly in those with placenta malaria. So these are the limitations that I have, and I would like to thank my supervisors, Prof. Stephen Rochison, and my co-supervisor, Dr. Elizabeth Aiken. And this is my lab group. as well as my the statistician who helped us with some of the analysis that we had, Dr. Meka Rajaseka, and the Chang Lab, as well as the people who donated the recombinant proteins that we use in the study, my advisory committee, and above all, I would like to thank the Malawi women who volunteered their time and energy in this project. Thank you.
Thank you so much, Yvonne. When you were speaking, I was just laughing that the teacher has become the student today. I had to sit down and take notes and listen to what you were talking about. And I was asking myself, okay, how did it happen that you come from biology and biochemistry, and now you're deep into immunology? I think let me throw that as the first question. How did you end up doing this particular research? Then I'll open for more questions from others. Go ahead, Yvonne.
Okay, so I think the main drive was the fact that I attended during my undergrad. I had an opportunity of attending a conference in Victoria Falls, because an immunology conference, and sitting down there and watching and listening to people's presentations, I took a liking into immunology and infectious diseases, and I thought that I should just take that route and follow that. And during my master's, I wanted to do something immunology related, but unfortunately, I couldn't get a program that allowed me to do that. So I had to do some clinical micro and infectious diseases, but I was glad that there was still some, I was still inclined to infectious diseases. And after my master's, I then, lucky enough, because the importance of collaboration networking at conferences really helps. During the undergrad conference, I actually spoke to Prof. Ella Kisfanda, the Dean for Faculty of Medicine at NASP. Yeah, so I sent him an email. I was like, I'm interested in immunology and would love to work in your lab so that I could get more interest or more knowledge in immunology in this case. So he was happy to take me in as a research scientist, where I was actually doing some data collection and analysis. And then I moved on to the next stage of lab scientist in the same clinical lab that he was running, where I was now doing some diagnostic work. And from there, that's when I came here to pursue my PhD in immunology and infectious diseases. Yeah, so that's how I got to do some immunology stuff from biochem.
Oh, wow. Oh, that's really impressive. Well done. You've done a lot of us proud, really. This is really amazing work that you've done. And I was really impressed, like how you managed to kind of knit through different fields, starting from fundamental molecular biology, doing some public health work, and again, introducing machine learning, all in the aim of trying to understand malaria infection and its impact on human health, particularly in women. There is this question coming from Brunette Katandegwaza. Dr. Brunette is saying, Ivan, what is the impact of maternal malaria on baby gestation, as well as on the baby postpartum phase?
So the impact of malaria infection on gestation. So you'll notice that if you have babies with small for gestational age, so you'll give birth to small babies at the end. So yeah, that's how it actually impacts in this case.
Okay.
Because it's either you have small babies or you have it's also linked to also having preterm delivery as well in this case. So small for gestational age and preterm delivery are kind of linked in this case.
Okay.
Yeah.
We have also Dr. Pana. Are you there? You can open your mic and comment and talk about any potential areas of collaboration.
Yeah, thanks a lot, Prof. Thanks, Yvonne, for the very much interesting talk. We in our lab, we also hold very great interest in malaria drug discovery, which of course is slightly different from the immunology, but nonetheless, I believe there is areas of overlapping interest, which I think between the two of us will discuss at some detail to see how we can explore those. Yeah, thanks.
Oh,
Thank you for that.
thank you. Any questions? Any questions for Brunette?
For Yvonne, sorry, can I ask a
Sorry,
question?
for Yvonne.
Edmond?
Brunette.
Yes. So thank you, Yvonne. This is a very great research and it's quite interesting. So I just wanted to know, I might have missed the beginning of your presentation. So I don't know if you mentioned this, but if the mom is previously infected with malaria, is it possible for the baby to be protected against malaria?
Yeah, so that's where we're looking at yeah, it's possible that they might be protected because the mother has developed the antibodies, right, against that particular infection, malaria infection. So it's possible that they may develop protection for the baby. But sometimes some of these antibodies may wane, that is, they're not long lived, especially like IgG, they've got a shelf life. So you might find that even if they were once infected and then they had antibodies, and then they get pregnant again, the antibody levels may go down such that at the end the baby may not be protected and will still get infected, or in this case, or it will still affect the baby in this case. Like they might be born with a small weight, or it may result in preterm delivery in this case. Yeah.
Okay, thank you.
The questions are open. If there is anyone with a question, you can go ahead, throw it in the comment section. If you have a question, please put it in the comment section. Okay, it seems like there are no questions right now. So we are going to have more of open discussion, just a debrief of all the sessions that we had so far. We are fortunate, Prof. Dingani is here, Dr. Loram Singwani is here, and all the speakers are here right now. So we want to have this session just to have a crosstalk, maybe between our speakers as well as with everyone who is participating right now, so that we can see how can we started off talking about the issues surrounding silicosis among mining communities, the issues of TB and HIV infections among mining communities, and we looked at another important aspect of cervical cancer, and the cohort was mainly focused on Namibia. Now we are looking at malaria, focusing on the immunology aspect. So let's just take a step back at all these different conversations that we have. How can we now start planning for the future? How can we start talking together in these different fields? And what are the potential areas of research that you think from all these talks we need now to start looking at these different areas? So this is going to be an open discussion, open from everyone. For everyone who's participating here, you are free to raise your hand. You are free to post a comment in the chats. For our speakers, if you want to speak, those who have been our speakers, that's Dr. Loram Singwani, Professor Dingani Moyo, and Yvonne Dube, if you are ready to comment on another speaker's talk, you are free. You can just open your mouth, your mic, and go ahead and comment. So this is going to be an open discussion. Thank you. Guest speakers, you are free to open your camera right now. If you are available, you can open your camera. Yes, you are free to go ahead. Anyone who is ready, you can go ahead. Prof. Dingani, go ahead. Thank you.
Thank you very much. Thank you very much for this quite interesting and very insightful workshop. Yeah, I really like the different dimensions from cervical cancer to malaria to occupational health. You see, I'm always biased towards occupational health and safety. Any subject that is good safety in it, I always open my ears wide. So what I wanted to say was in the current space, just to add on my earlier presentation with respect to issues of health and safety. It is quite important that all of us who are here, maybe even attending this workshop today, we can all be classified as workers in one way or the other. And one important challenge that I wanted to give to you was in terms of occupational issues on mental health, we all know that out of 1 in 5 he has got a mental health issue. So if all our presenters, maybe if we count 1 to 5, one of us might be dealing with this issue. What am I trying to say is that it is important to bring issues of occupational health and safety management systems into play so that each and every moment we build resilient systems in our, across our workspaces. Just like you find that artisanal and small-scale miners, they are a vulnerable group with very little systems in place. And this is not only Zimbabwe, but across the globe. And it becomes quite important to put in place even workplace standards. I think issues cross-cutting with malaria, one of the major issues that we find in occupational health will be either expatriates who are traveling into areas with malaria, where even issues of fitness to travel or fitness to work become very key. And there should be close collaboration in terms of fitness for work standards, looking at all the other diseases over and above malaria to make sure that we are safe. And occupational health generally being the promotion and maintenance of the high standard of physical, mental, and social well-being needs to be cut across all centers. I know in the past, I have also had an issue where I've been confronted by a lady who wanted to be pregnant, but did almost 3 miscarriages for no apparent reason, only to realize that this person was working in a dry cleaning company where they are exposed to solvents. And we now know that solvents cause relaxation of the uterus and it causes a lot of miscarriages. So in each and every discipline, these issues become key so that even you could be talking from a malaria point, from a cervical point, at the end of the day, we always zero on the health and safety of citizens. So let me stop here. I'll take it up when my other colleagues have also taken it through. Thank you.
Thank you so much, Prof. Dingani. I'm going to throw this to Dr. Laura Mzimane. Prof. Moyo mentioned the issue of building resilience. That is really important that we build resilience in our communities. How is it, how have you explored that aspect of resilience in your work in cervical cancer?
Thanks, Edmund, and thanks, Prof, for those comments as well. We are still really at the beginning in terms of building resilience for health systems. Actually, we experienced quite a huge knock, with the reliance on donor funding. And then when donor funding comes to an end, you find that our health systems are not really ready to absorb health workforce that would have been built up actually from the donor funding. And this year we are actually starting to experience that. So we have sat down with the ministry, and the goal is, instead of hiring additional staff who tend then to just go when the funding goes away, we're looking more at capacity building, which is something which might be more sustainable for the ministry. Then talking about occupational issues and cervical cancer screening, it brought back to mind some of the issues that we actually experienced here. And they also affect access to services. We have got another community that's called farm workers here in Namibia. And the farms, you find that they're like really deep and far away from major towns or major activities. And the farm workers, they are paid a wage on an hourly basis or on a, like that. So if you ask this woman to leave her workplace and come to the facility for screening, she's actually losing income. And we found that they actually did not come because of some of these issues. So things that we started looking into was actually bringing healthcare services to them in the form of outreach. And you cannot do your outreach during the week because they are working and they are going to lose their income. So we actually resorted to doing it after hours, in the weekends, and things like that. So probably these are some of the things that we could also look at for the marginalized communities. And also you find that the owners of the farms actually don't let you into the farm. They're like, no, you're going to disturb the workflow, you're going to disturb this, because they also don't have an understanding that if you make sure that your workers are healthy, they're going to serve you better and you have less downtime in terms of the activities that you be doing. So these are some of the things that we need to think of for client-centered care and near-patient care services and decentralization of services. Thank you.
Okay, thank you so much. You mentioned the importance of decentralization of services as a way of building a resilience in the community. And thank you so much for that. Now I'm coming back to Yvonne. In your work, I'm particularly interested with work that you did with Malawi Improve. Right, you were working with the community and looking at the understanding the antigens. There is a question coming from Svang, and I'm coming to Svang soon. So I was just interested in understanding now when you got these results, how was the reception of the findings from the community? Are there any steps that are in place to make sure that the results that you obtained are going to be beneficial to the community that you were looking into? You're on mute.
Okay, thank you for that question. But what I can say is that for the samples that we used in the study, they were collected, I think, around 2019. So in this case, there were other people involved in community engagement who did this, were involved in community engagement in this case. So they were the ones who collected the samples for us, and then we did the experiments from this end in this case. So in terms of like the reception, we haven't really conveyed back the results that we have received so far, since it's still in its preliminary stages and we're still yet to do more analysis so that we can finalize and get a better understanding of how this, what's the meaning of the results that we're getting in this case with regards to malaria in Malawi.
Okay. Thank you. I'll follow up. I'm going to be biased. I'm from Karoi. As you know, Karoi, that's the capital of malaria, I would say, in Zimbabwe. So how can we really, I'm thinking we have several researchers in our team here. And how can we really consider doing similar work in Zimbabwe? What advice would you give to some people who are interested in this type of work to study, say, the malaria infection in, say, in Karoi, where we have a major problem with malaria? And yeah, you can go ahead.
I think the main issue that we're facing in Zimbabwe, we do have malaria researchers who are actually doing some malaria research, but I think the issue is collaboration. Like, who are you collaborating with? Because the ones that I know collaborate with UK universities, and they're looking at malaria in children, like, and linking it to other tropical diseases such as schistosomiasis and bilharzia and the like. So I think the issue, and I don't think there's anyone, if there is, probably there are very few who are looking into malaria in pregnant women. So The main challenge that I feel is actually affecting us in Zimbabwe as Zimbabweans is actually collaboration and getting the funding to actually engage the community, collect samples, and also make a follow-up and try and get a better understanding of how best to actually also reduce malaria infections in Zimbabwe as well. So that's the main challenge, because you notice that most of the people who are doing malaria research are focusing on high transmission areas. And it seems like Zimbabwe is also a high transmission area, but then it's not really included. When you look at the WHO malaria report, Zimbabwe is not really included. It's mostly Uganda, Malawi, Nigeria, Tanzania, Kenya. So those are the main countries that are actually regarded as high transmission areas in this case. So yeah.
All right. Oh, thank you so much. I'll come to Svangan. Go ahead, Svangan.
Good afternoon. Can you hear me?
Yes, we can hear you.
All right. Sorry, I missed the greater part of the first presentations. I was picking bits and pieces here and there because my network was very poor. But I'm particularly interested in the issue of malaria because the area where I come from is basically, you say Karoi is the capital of malaria. I want to believe my area is also another capital. I don't know how many capitals are going to have. But what I have seen so far over time, when it comes to the issue of management of malaria, it's more of a reactive approach rather than a proactive approach. And also the whole aspect of management of malaria seems not to really take care of contextual issues in the rural areas as well as in the urban areas. And my biggest worry is that currently we deal with issues of resistance to medication and so on. And my question to my presenter, Yvonne, is when you look at this whole aspect of the management of malaria vis-a-vis the experiences that we have learned from TB, from COVID-19, what are some of the issues, especially around the resistance to malaria treatment? Mostly when I have malaria, I quickly go to I'm given Paracet, whatever chloroquine. But there seemed to be no follow-up to say, how has this treatment worked for this person and what could be the issues? Once I feel good, okay, it's fine, it's all good and bad. Mm-hmm. And then when you go again, last year I was in a conference in South Africa and I learned that wastewater actually can be used as a determinant of disease sort of identification, because you, like the municipal water that we normally use at our homes, it is said that you can actually tell what kind of diseases and where are they coming from, and then necessary interventions. If you look at our local authorities in Zimbabwe, for example, how proactively do they use such kind of developments to make sure that they inform the Ministry of Health? And also, even in the rural areas with our pit latrines, pit toilets, the same can be done so that we don't seem to be wasting resources and also compromising the health of the people, especially from a proactive approach, and also the post-management of malaria for those who have been treated. For me, it's a very big worry, because also we are talking about the interface of malaria in that belt of Bingawange. You've got Tete. Where do you say this is malaria? Where do you say this is a tsetse? Because people are bitten by tsetse. And nowadays, because of disinvestment in that area, I want to believe that tsetse fly is becoming a very serious problem again, causing sleeping sickness and all the other problems that comes along with malaria. Sorry for giving you such a mouthful of questions, because yeah, it's my area of interest, and yeah, thank you.
Oh, thank you so much, Smangan. This is going to be really engaging. We want a response from Yvonne. Laura, if you are there, I understand you also did some work in on infectious diseases. You might want to comment on that one from a practitioner point of view. Then we'll have Yvonne to comment from the side of a researcher point of view. Then Prof. Moyo, if you're around, you can also give us a joint view of a practitioner as well as view of a researcher. We'll start off with Yvonne.
Okay, from a researcher point of view, from some of the discussions that we usually have with regards to resistance, is that you find that, let's say, pregnant women or adults in general, they don't like using insecticide-treated bed nets for some reason. And because of that, chances of resistance tend to rise. And looking at mostly people who are affected in rural areas, you'll notice the distance now of the clinics from where they stay. It's very far, such that they can go once and get their medication, and it will be hard to actually follow up on them, or sometimes they don't even come back for follow-up in this case. So it tends to be hard to do follow-up in terms of whether they have recovered or they need more medication in this case. And the other thing is that, okay, I'll hold on to that for now, then I'll come back to you.
Okay. All right, thank you. Before we move on to practitioner view from Laura, I'll get a comment again from a researcher point of view. Brunette, Dr. Brunette, can you go ahead?
Okay, thank you so much. This is quite an interesting discussion. So I've actually sent in the chat a paper on malaria bacteria. So I think the main issue that we have, which was raised by the previous person who asked, I'm sorry, I forgot your name, is that it's the approach that we're having to malaria, especially in Africa. You see, it's different when you're presenting on the immunology of malaria, but it's quite different if you ask a researcher in Zimbabwe or in Africa to present on malaria. They don't really talk about the immunology aspect. We're talking about prevalence, incidence, and spread and whatever. So it's the approach that we actually have towards malaria. And this approach, yes, it is taking in good data, right? But it is not moving us towards eradication of malaria per se. It is just collecting data for other people to use. So it's quite interesting because I went to one meeting in immunology and they're talking about a bacteria that infects the Anopheles mosquito and prevents the transmission of the Plasmodium, right, to humans, right? So this is something that as a nation, I think if we had a very good research center that collects such information, as a nation, this will be something interesting that can be employed to control malaria prevalence in Zimbabwe, right? Because you then ask your own researchers and your own scientists, okay, can we do this? Is this practical? Because these guys were presenting on this bacteria they actually had a grant from their countries to actually create these mosquitoes and spread them into the environment, right? So that they become the dominant mosquitoes, which are incapable of spreading Plasmodium to people, right? And that way you control the prevalence. So just by collecting data on how many people got malaria, what is the incidence, which is the most important malaria zone in Zimbabwe. Yes, it's important information, but I don't think it's moving us forward. We are collecting and collecting. And like what I think Laura Mzingwane also mentioned about, sometimes this research is donor funded, right? So we've got these researchers, because they don't have the data on prevalence, they're going to donate funds for us to collect the prevalence data, right? But then that's all that we do. We only do what the donor is donating us to do. And then we don't go a step forward to see, okay, how can we ourselves try to eradicate this disease before we wait for information from donors to say, okay, we found that Karoi has got the highest malaria, which is not really helpful to us. People are dying of malaria, right? So we need to be more proactive, and our research needs to move towards an area where we're looking at eradication, not only at understanding. So I'm not really going to talk much about this because I actually talk about it in my presentation, which is going to come in the afternoon. And I think also what Dr. Dingani or Prof. Dingani, sorry, I'm not so sure the title, but I'll say Dingani at this moment. I hope it's okay. At what Dingani said about mental health, I also touch a lot about it in my own presentation because this is something that has greatly affected me during my journey. And I'll be willing to also have questions on the different aspects of mental health and also on our approach to research as African scientists. Thank you.
Oh, thank you. Thank you so much, Brunette. This was really insightful that we now need to invest more in basic research so that we can be able to eradicate malaria. So we are really grateful to have Brunette in the afternoon session. Please we look forward to attend to this session. If you have any comments, you can go ahead. Laura, if you have a comment, you can go ahead.
All right, thanks, Edmond. Yeah, so I would just like to echo Brunette's sentiments that really our research or data collection is just focused on the prevalence and the incidence, and that is it. In terms of other surveillance, like what I'm not sure, I think it was Wangani who said, what happens to me after I feel okay and I go? So one of the things that we have not really been good at is to make sure that people complete their anti-malarial course that they would have been given. Because after 1 or 2 days, the fever subsides, everything is okay. People tend to abandon their medication and then they don't really take it. The only resistant forms we really see is only later when we have tried the primary, the secondary course, and then this person is really not responding to treatment. Then we say, okay, no, this one has got complicated malaria, probably there's resistance and the like. So if we could come up with a test that could tell us right at the outset, no, this is actually resistant, this is going to be responsive to this medication, then that way we could actually do more. So I do agree in terms of really going through a step further in terms of our data collection and the like, to really look at what exactly it is that we want to achieve. Thank you.
Oh, thank you so much. Any other questions or comments, please? This is the time. A comment from Linda. Linda is saying, yes, we need to find ways of eradicating malaria. This should be our priority as a research community, that let's work on trying to find ways of eradicating malaria. And so wonderful talk from our wonderful speakers. We are so glad that you came and shared your insight with us. It was really an honor and privilege to learn from you. So if there is any questions at the moment. There are no questions right now. So at this moment, I'll just ask, maybe we're going to take a 5-minute break. Then when we come back, just before we go for the afternoon session, we are going to have an open discussion. In this open discussion, we are asking the question, does your mother know what you are doing? So we are not going to be going anywhere, just write your comments. If you want to present on that, you'll have 2 minutes to talk about what motivates you to do your research. The question is, does your mother know what you are doing? If you want to talk about that, you are going to be given 2 minutes. You talk about your ideas, your views about what motivates you in engaging in research. So right now, please just write down a comment. Then I'll take note if you are interested of those who are going to be presenting. You have 2 minutes to present. Does your mother know what you are doing? So in the meantime, is Emmy here so that you can just go give us a run through of who we are, what we are doing today, just for those who have just joined right now. Are you there, Emmy? Just give us a run through of who we are and why we are here.
Yes, indeed. Just give me one moment. You caught me unaware there. So we are the Zimbabwe Research Network, and this conference is our SHE conference for 2024. And this morning session, we were looking at the transformative solutions in urban health for equity and resilience. In this session, we were exploring innovative solutions to improve health, equity, and wellness for the vulnerable and marginalized populations. Presentations that we've been having throughout the morning were covering community-driven, scientific, and culturally informed approaches to address health disparities and promote resilience. We have a day that's fully packed. Our afternoon session will be looking at building greener and healthier futures through transdisciplinary science and international policy engagement. We are the Zimbabwe Research Network. And please support us by following us on our social media platforms. We are on X as at ZimResNet, and we are also on LinkedIn as the Zimbabwe Research Network. We aim to foster a vibrant and inclusive community of Zimbabwean scholars, professionals, and experts, both at home and abroad, that actively contributes to the academic, research, policy, and governance development of our beautiful country. Our mission is to enhance academic capacity building and promote research and innovation within Zimbabwe by facilitating meaningful collaborations, partnerships, and engagements between Zimbabweans globally. We strive to influence national policy by providing evidence-based insights and creating opportunities for international interdisciplinary collaboration that contributes to the progress and prosperity of our beautiful nation. By harnessing the power of our diverse and dynamic diaspora, we aim to make a significant and lasting impact on our nation's academic and governance landscape. So we will be meeting you, I think, in 4 minutes, top of the hour, where we will continue into other, and proceed with our next session. I see Prof. Ed is commenting. And if you are also interested in contributing to this discussion, as Prof. Ed has posted, please feel free to reach out to either of us, and we would love to engage with you on some of the topics that we talked about. We will talk about later on. So see you in 3 minutes. Thank you. Prof, we can't hear the sound. I think you didn't share with sound. Yes, we can hear the sound now.
So step aside. Come up last of that. Federal. It's multiple times.
Up next is going to be our open discussion. The theme of the open discussion is, does your mother know what you are doing? Research that informs public policy. And we said, if you are interested in contributing to this discussion, you are free to just let us know. You can write in the comment section that you are interested in contributing on this discussion. Then we are going to call you up, then you share your insights. If you are interested in discussing, does your mother know what you are doing? Research that informs public policy. From our early conversations, from the presentation by Professor Dingani Moyo, we understood the importance of looking at how our occupations can affect our health. The things that we do for making money, how does they affect our health? Dr. Laura Msingwani pointed out again that even our occupations can also determine our health-seeking behaviors. This was coming from a practitioner point of view. Then we got exciting talk again from Yvonne Dube, who showed us the importance of basic research in disease eradication. So we looked at all the layers of research, indeed, that we started off from the high level of developmental research. We looked at applied research from Dr. Mzingwan, and also we looked at basic research from Yvonne Dube. So all these different types of research that we have looked at, from the basic research up to the developmental research, how can we use this research to inform our policies? And when you are formulating your research, well, for all those who are engaged in research right now, how does your understanding of the impact of your research informs how you design your research? If you are a practitioner and you are interested in improving your workplace practices, how does engaging in research help you to design your research? The purpose of this discussion is so that we can find an opportunity to work together as researchers. We can find an opportunity to work together between researchers and practitioners, and we can find a way also of working together between researchers, practitioners, and policymakers, or the whole triple helix system. So right now, if you are interested in commenting on this particular important issue, you are free to raise your hand or add a comment in the chat, right? So I'll have Emmy and Tinaya, if you are there, to help me with coordinating the conversations. So this is an open discussion. Everyone is free to contribute to this topic. Does your mother know what you are doing, conducting research that informs public policy? Yes, Dr. Tatenda, can you go ahead and share with us your insights? From Dr. Tatenda, I'm going to call upon Tinaye. Be prepared to make a dominant contribution on who informs the research that you do.
So for me, my mother, she kind of knows what I do, but all I know is that she just tells people that her daughter is a doctor and that's it. But she at least has she's a nurse, so she kind of understands that my research has something to do with health, and that my dissertation was in Zimbabwe investigating HIV among educational outcomes of HIV positive of children with HIV positive mothers. Apart from that, she doesn't know anything beyond that. I need to do a better job at maybe discussing this more But I feel like the more I talk about it, the more she starts to lose interest in when I go in depth. But she kind of does know.
Okay. Interesting. This is really interesting. Can I probe even more?
Sure.
Because she's a nurse.
Yes.
She benefits from the research you are doing.
Not really.
Does she use the research that you're doing?
No.
Can she use the research that you're doing?
I think mine was more on the economic side of things. So she may not be able to use it. I feel like if she was maybe a community health nurse, she would, but she's in geriatric care.
Okay.
Yeah.
Okay.
So that makes it, I think, not as useful in her work, but rather I find that I was able to actually learn from her more on like the health side of things because I'm not I'm not a I'm an economist and I was trying to understand some of the physical health stuff and I would actually learn more from her, if anything, about the physical implications of the disease.
Okay. Dr. Tisna brought an interesting aspect to this discussion that we are saying, does your mother know what you're doing? And she's pointing out that she's probably an expert in what you are doing, that she's contributing not as a consumer of knowledge, but as a provider of knowledge.
Yeah,
correct.
Yes, because also, like I said, I was looking at the educational outcomes of children who are HIV positive or have parents who are HIV positive. And I think from her training, I think part of the nursing training, there's like the child development part of it. And also the, just knowing the physical implications of what HIV does to the body and mentally and stuff. I was actually sometimes able to draw from her knowledge to kind of understand some aspects of my research because I was mainly looking at just the educational economic side of things.
Okay. All right. So the purpose of this discussion, we are trying to get to a point where how can we conduct research where the community is not just the consumer, but also a collaborator in that particular work, so that when we are now conducting our research, even policymakers are ready to engage with us. Tinaye, are you ready?
Yes, Prof. How are you?
I'm good. Congratulations are in order. We are
Thank
happy for
you.
you. That's an important achievement. To those who don't know, Chinaya just got a master's yesterday, and we are so happy for her. So, does your mother know what you are doing?
Thank you. So in terms of my master's, she knew I was doing a master's, but she didn't have the details of the research that I was doing, which is I was looking at access to and knowledge of sexual and reproductive rights and services in Djibouti. Because when I was looking for an area to study, there was no data in Djibouti, even on UN FPA websites and even government websites and things like that. They were always blank. But in terms of my mother knowing, she just knew I was doing my master's in development studies. But I am looking into. I know Dr. Tatenda knows this. I'm still skeptical about doing PhD. I'm sure, the mental health issues that have been highlighted, and I'm glad it's part of the discussions today. Just seeing how my mentors were struggling a little bit. But regardless of that, whether I do a PhD or not, I'm looking into a certain research area. and my mom knows about that one. So because she was there when I was having meetings with my potential, if I do my PhD, then that would be my potential supervisor. But she was in the meeting where we were actually discussing the research. So she has an idea of what I am planning to do.
Okay. Thank you. Not everyone has an opportunity of having their mom sitting right there when the conversations are taking place. So I'll go to Solomon and then go to Sibangani. Solomon, go ahead. Does your mother know what you are doing and how does it help you in designing your research, a research that is impactful to the community? Go ahead, Solomon.
Hello. Thank you very much for giving me a chance to speak. My mother doesn't know what, she just knows that I was studying a PhD in music and nothing more. Even in my family members, they just know I'm studying. I'm interested in music, but they don't understand why I'm doing that, and even the relevance of studying music, because they think it's something that is not important in terms of maybe getting a job and even contributing to different sectors of life. Yeah, so that's the issue.
To those who don't know, Solomon works in ethnomusicology. I got it right?
Yes, yeah.
Yes, he works in ethnomusicology, which is very important in the preservation of our cultural heritage. Right now in Zimbabwe, we know that one of the major area really that is sustaining our health is the music industry. Not in terms of selling CDs and cassettes, but in our consumption of music, it contributes to our health. I would like for you, Solomon, just to talk a bit about how, as an ethnomusicologist, health of community health is really important, is an important aspect, either in the preservation of the cultural heritage or really in the population health, so to speak.
Thank you very much for that question. So yeah, ethnomusicology as a discipline is a very broad area of study with different branches. For example, there is the applied ethnomusicology, there is public ethnomusicology, there is conventional ethnomusicology. But my area of interest is in applied ethnomusicology, whereby we use music as a practical intervention to promote sustainable development among different communities. For example, issues to do with economic, cultural sustainability, environmental justice, as well as social health. And there's also a specific branch of ethnomusicology that is called medical ethnomusicology, which focuses on how music can be used to promote social health as well as well-being of different communities. So in my case, for example, at PhD, my research was on how the Ndau people in Zimbabwe can use their intangible cultural heritage to promote sustainability or community development in its broad sense. So I was focusing on how the Ndau people can adapt their music to promote sustainability. For example, issues to do with participation, inclusive participation, social justice, which are also important issues when it comes to community health. Because what I learned, for example, in Zimbabwe, when we are talking about health, we tend to focus on health in medical sense, whereby we focus on issues to do with medicines and maybe hospitals and clinics, and issues to do with social health, for example, participation, inclusivity, justice, well-being. We tend to relegate those issues to a marginal position. Yet they are very important, because we cannot just be a community that focuses on maybe other things and take for granted other issues that are important when it comes to the community. Because if we're talking about life is holistic. It's not just a certain direction, and where we also have a situation whereby we ignore other issues. So in my research, I tried to I worked with the Ndau communities, not as a research subject, but as collaborators, because I collaborated with them in developing a cultural festival, and establishing that festival as a means of sustainability. And it's now an ongoing project, which started in 2022, and they had the second edition in 2023, and they had the third edition this year. So this is something that I did with the community as a way of promoting social health. So in short, that's all what I can say for now.
Oh, thank you so much. We have medical doctors in the house. I just wanted to like your contribution really on ethnomusicology in the social health aspect. I understand Professor Moyo actually talked a bit about that important aspect of social health, and I'm opening the discussion to everyone right now. Like, how can we really invest more in this aspect in ethnomusicology, because we are all benefiting from it one way or the other. Without it, we won't really become a healthy community. So I'm opening. If you have any questions for Solomon, please. You can raise your hand, but right now I'm going to Sibangani. Are you still there? Sibangani, are you still there? Sibangani, the question. Dr. Sibangani, you can go ahead. You can unmute yourself. Okay. Okay, while we are waiting for Dr. Sibangani, anyone else with a comment or question?
I have a question for Solomon.
Yes, go ahead.
What is your reception or your view towards the way music education in Zimbabwe is viewed as far as a research topic, particularly with the ethnomusic part of things, versus to other research areas? What is your perception on how your research is received in Zimbabwe and its usefulness in our society?
Thank you very much, Dr. Tatinda, for that question. What I can say is the general perception of people, particularly in Zimbabwe and maybe beyond, is kind of a negative one, because most people think that we are studying useless things, and they don't understand how we as ethnomusicologists or people interested in music research, how are we going to benefit, and what kind of job are we going to do after our studies. But what I can say is that there are so many opportunities when it comes to music research, because, for example, in Zimbabwe, we have a ministry that deals with arts and heritage, and there are people working in that ministry. And beyond that, we world over, we have a specialized organization, United Nations organization, UNESCO, which deals with intangible cultural heritage, and music is the part, is an element of intangible cultural heritage. Despite that, music, it permeates all sectors of life, whether religion, economics, politics, and environment, and even in churches, we sing, we dance, we do different, we express ourselves artistically. So music is it's an important aspect of life. But when you tell people that you are studying music, they don't understand what exactly are you doing, and they wonder what kind of job are you going to get after that. But according to my own experience, even when I was still in Zimbabwe, I had no any issue to do with or problem in getting a job, because I worked with I was in the Ministry of Education, and when I was a teacher, I got a lot of consultants jobs, for example, with the National Arts Council, ZIMSEC, in terms of writing their exams, and a whole lot of issues. But when it comes here, for example, here in Europe, there are so many programs, there are so many research projects, and there is a lot of funding that is available for music. And it's an advantage for us people, for example, from African countries or other non-European countries. They are so much interested in learning what's going on in those areas. So yeah, but generally, even here in Europe, music is not a subject that is yes, yeah, they try to promote it, but there is also that negative perception whereby people think that we are studying music. That's all what I can say. Yeah.
Thank you.
All right. Okay, thank you so much, Solomon. Next up is Catherine Chinyandura. You can go ahead, open the mic, and give your comment.
Hi, everyone. Thanks for this platform, and thank you so much. I really appreciate that for organizing this event. It's really helpful, and I hope to be attending more of this. So I was just thinking, when you talked about how can we translate our work into what communities understand, and how can we partner with communities, and I'm just thinking, I'm so much interested in working with communities, and I've worked with communities in different countries, including Namibia, Malawi, Zimbabwe, South Africa. And currently I'm in public health, more of health system strengthening, but I've also interest in socio-ecological systems. And what I've seen in all this work is sometimes we neglect community structures which are existing in our communities, which if we piggyback on what they are doing, we can actually go far. And I think, not revealing my age, but I think some of us, we already know that there are some structures even back home in Zimbabwe, which have been there for years. You have traditional leaders, you have churches, all these are structures which we can make use of, but we rarely consult them. And when I've seen that as we consult them, they're actually interested in what we are doing and how we can collaborate with them to work. And let me share on one of the projects which I'm working on now at work is how to, a collaboration framework for working with traditional healers in providing HIV services. And we all know that research tells us about 80 to 90% of people in sub-Saharan Africa actually consult traditional healers before they even come to the health facility. And the question is, are we making use of that structure? Or we have these distinct biomedical and traditional practitioners. but it's something which we can actually bridge this gap and come and work together. And remember, they are quite a very respected structure in the communities. And what we have seen is sometimes people actually don't go by what the health facilities tell them, but they will surely do go by what the traditional practitioners tell them. So those are some of the structures which we can make use of. You know, you can have community advisory board, which you can actually bring the community to be advising you, to be giving, you know, their recommendations, because they are based in the community and they know what works for the community. So that's one part. There are structures which are there which we can make use of. And then the second part is we do have indigenous knowledge systems, which I think all of us here know about. Some of us, I think you know, we were told if you have an ear ache, you can make use of this. If you have a stomach ache, you can do this. And they do work. And the question is, are we making use of those indigenous knowledge systems? How do we bring these indigenous knowledge systems with what we are calling medical, biomedical, scientific systems to work together without, of course, you know, piracy, where we end up just stealing what their knowledge and everything. So I'm just sitting here thinking, the work I'm doing and what I've done in the past, there's quite a lot of ways which we can collaborate with communities for them to understand what we're doing and to even translate our work into the language which they do understand. Yeah, so that's my contribution. Thank you so much.
Oh, thank you so much, Catherine, for this informative. We'll go for our next symposium. We might have to call upon you because we really want to learn more about this integration of the indigenous knowledge systems in the healthcare. So please, you will receive an email from one of us, either myself or Amy or Tinaye. We might contact you as we organize another session related to this discussion. So thank you so much. Right now, hand over to Tinaye to introduce our next speaker, Professor Tafa Zonashe Mabaudi. Prof. Mabaudi, are you here?
Yes, I'm online.
Yes, thank you. Okay, Tinaye, go ahead and introduce Prof. Mabaudi.
Thank you, Prof. And for those who are just joining us, thank you so much. Welcome to our conference. I just want to take this opportunity to introduce Professor Zonashe Mabaudi. He's a professor of climate change, food systems, and health at the London School of Hygiene and Tropical Medicine. He is currently the lead of the Water, Energy, Food, Environment Nexus at the United Nations University Institute of Water, Environment, and Health, and the director of the Institute of Natural Resources in South Africa. He also holds a PhD in agronomy and crop science and a master's degree in crop science, both from the University of KwaZulu-Natal. He has more than 250 research publications in reputable international journals, which has amassed nearly 9,000 citations. So welcome, Doctor. You may take the floor.
Thank you very much, Tinaye. Pleasure for joining you today. I'm joining you from Kamuzu Banda International Airport, where I'm in transit from Malawi, coming back to the UK. So I won't be able to put my camera on, unfortunately, but I hope you can still hear me. I was asked to just talk a bit about the water, energy, food nexus as a concept, an approach, and a community of practice, looking at how that is evolved. Now, to take stock of what we're trying to do with the water, energy, food nexus, really we have to first understand the subject of complexity and complex systems, and also complex systems in transition. So we all understand that, especially in the global south, we are facing significant challenges in terms of food and nutrition security, water security, energy security. There is growing pressure and demand in terms of the resource base from an increasing or rapidly increasing population growth, rapid urbanization, environmental degradation, and climate change is also having a multiplier effect on the stressors for across water, energy, and food. Currently, where I've been coming from these last 2 weeks, or basically this last month, I've been in Southern Africa, and the impact of the El Nino drought from last season is still very visible, not just in terms of the hunger that it has pushed people into, but also the ripple effects. The low water levels in the Kariba Dam have led to massive power cuts and blackouts in the region. As a result of massive power cuts and blackouts in the region, it has also constrained food production in terms of winter wheat production, which required irrigation, which then needed energy to pump and distribute water. So the interdependencies across water, energy, and food are what we basically refer to as the water, energy, food nexus. And the approach itself is trying to better understand those interdependencies and better manage the trade-offs that exist in the management for these three resource bases, but with an outcome-based approach that is focused on social equity, inclusion, sustainable development, and basically sustainable natural resources management. The approach itself has been around since the early 2000s. That's when people started talking about it. It has been mentioned in different iterations, water, energy, food, food, energy, water, or food, water, energy. But it has been around since the early 2000s. But it came to prominence really in 2011 at the Davos World Economic Forum, where it was highlighted as one of the key approaches for achieving sustainable socioeconomic development because of its ability to catalyze progress and development beyond just the three sectors of water, energy, and food. Then importantly, when the SDGs were formally launched in 2015, because of its direct linkage to SDGs 2, 6, and 7, the approach again shot to prominence as an approach that could be used to integrate the SDGs and also catalyze progress of other related SDGs. Most recently, we've been talking about it in terms of catalyzing progress towards the SDGs, in light of how we are behind on achieving the SDGs by 2030. So it's always been around, but really from 2011, that's when it shot to prominence. In Southern Africa, we've worked on the approach from around the same time, 2011, 2012. The Water Research Commission in South Africa took a lead back then and established a lighthouse within their research development branch. The SADC, Southern African Development Community, in partnership with Global Water Partnership Southern Africa, also then launched a program called the National Regional Dialogues, which was funded by the European Union at around the same time, which then looked at how the approach could be adopted for Southern Africa to achieve three particular goals. The first goal being simultaneous water, energy, and food securities. The second goal being job and wealth creation. The third goal being sustainable natural resource management. The approach also facilitated or led to at least three SADC multi-stakeholder water dialogues, which then adopted this as an approach at a regional level. We developed a framework for its governance and its implementation, and this was adopted at a regional level. And so in those years between 2011 to 2016, we mostly focused on understanding the concept and how it could be contextualized for Southern Africa as a region. Beyond 2016, after the concept had been basically accepted and adopted, the next question was instead of in terms of how do we better understand and quantify trade-offs and synergies across the systems? How do we identify them? So the next stage basically led to a stage which we call the analytical phase, where there's been development of nexus models, several with nexus models that all look or try to quantify trade-offs across water, energy, and food. So there are several models that have been developed. Locally in the region, we developed the integrated analytical wave nexus model. We also developed what is called analytical livelihoods framework. We also developed another one called the Global Wave Nexus Index. Globally, there was also several models that were developed around the same time or during the same period. And the focus of all these models was really looking at being able to identify and quantify trade-offs across water, energy, and food. Post that period, the science of the wave nexus has evolved to discourse, which is really around the relevance of the approach for informing policy and decision making. And this is where the discourse or the science currently is in terms of how do we then take the understanding of trade-offs and synergies and the quantification of those trade-offs and the identification to develop investment programs and projects, or to manage existing programs and projects in a way that enhances the outcomes, that creates positive outcomes and synergies, but that also minimizes environmental risks, social risks, and the risk of maladaptation. So this is where the conversation currently is in terms of developing investment programs and projects, as well as reviewing existing programs and projects from a wave nexus approach. Second to that has been the subject, which emerged especially during and post-COVID, of broadening the dimensions of the water, energy, food nexus to also include environment and health. And this was mostly because when COVID evolved, or when it emerged as a public health risk. And in many places, the immediate response was a public health response, which were the lockdowns. But the impacts that were felt immediately were usually in the water space because of low access to water, issues of water sanitation and hygiene. The disruption in food supply chains led to massive food insecurity in many regions, and some spontaneous riots that also occurred because of those disruptions. And there was basically a food security emergence in the region. So it led to the realization that health is also linked to the wave in one way or the other. And there have been initiatives since then to broaden the dimensions of the water, energy, food nexus to include health and environment. And this is one area where we are currently working on, looking at the impacts of water management within catchments, such as Nkomati Usutu catchment, that feature all three dimensions: water, energy generation, agriculture, and the incidence of waterborne diseases within those locations, and seeing how we can better integrate and manage across the three resource bases for improved human and environmental health outcomes under climate change. So that's where we are with the science of the nexus, trying to link it to practical application, demonstrate its relevance for people and planet, and also develop investment programs that are conceptualized from a nexus perspective. So I think that's pretty much what I have to mention about the evolution of the nexus as a concept, as an analytical tool, as well as a discourse. over the period of years that we've been working on the research, we've also undertaken a program of capacity development, which has included online masterclasses looking at Africa and the Middle East and North Africa. And we started these in 2021, and they have grown. We've now trained more than 1,500 participants through this online masterclass. We also undertake a winter school, which for people in the North would be a summer school, which is an in-person training. And through that, we have trained more than 150 participants, again, in Africa and the Middle East and North Africa. And we have recently launched a community of practice called the Global Wealth Nexus Community, where we now seek to convene conversations, discourse, workshops, symposia, partnerships for promoting the approach, as well as capacity development and mainstreaming of the approach. So that is the community of practice that is now there. We launched a podcast series called Unveiling Synergies earlier this year in April, which aims to amplify voices from the South, especially those of early career researchers working in any of water, energy, food, environment, and health systems related research, and providing a platform for them to share their work and what they're doing, and also to engage experts in the field and provide opportunities for experts to interact more with early career researchers. So that's the community of practice, and it's growing. It now has more than 1,500 active members on the LinkedIn page who are coming from across different and diverse backgrounds. And it continues to convene various public engagement platforms. And we hope that it will continue to grow in the years to come. I think I'm done with my talk. Back to you, Tinai and Edward.
Thank you so much, Prof. That was very informative. Just for the all right. If you have any questions from the presentation, you can just send them in the chat, and then we will direct them to Prof. But for now, my question to you is, in terms of WEF nexus that you were discussing, what challenges do you foresee in integrating the health dimension within that nexus?
So the challenge is mostly convening the health dimension, and also in terms of the conceptual thinking. The WEF itself has mostly been underpinned from a natural resource management perspective or a biophysical perspective. So bringing in the health component for most of the players or active players in the nexus, there's just a challenge in terms of how to better incorporate health outcomes in that perspective. The second challenge also is traditionally health is not formed part of that cluster. So even when we've been convening our workshops in the region and so forth, it has been challenging to get participation or active participation from the health sector. We are hoping that with better engagement or more active engagement, we'll be able to get the health sector to be more involved. The water, environment, and food sectors are very easy to engage with and bring to the table. But energy and health, it's been a bit of a challenge to bring them on board.
Thank you. And also, I just wanted to find out, in terms of, in the context of Zimbabwe, do you have, what are your recommendations for building a community of practice in Zimbabwe, especially when you look at resilience, for example, or even community-based governance? You know, how can it be when you come back now home, because that's the point of it, or we want these policies and we want these practices to apply to Zimbabwe and to be implemented in Zimbabwe. So what recommendations do you have in terms of the situation in Zimbabwe, resilience building, governance, community-based governance, etc.?
So I was recently in Zimbabwe in October, and just last week we're launching a new program funded by the Wellcome Trust that is essentially trying to promote more integrated planning across water, energy, food, environment, and health under climate change, and provide evidence synthesis to inform policy and practice. So far from the scoping that we have done, which is not anything new under the sun in terms of the outcomes, what has emerged is the issue of policy incoherence across the sectors, the 4 sectors themselves. So there's a lot of policy incoherence. There are very established institutions, which then also means very established silos, and very low intersectorial governance, intersectorial policy mechanisms. There are also implementation gaps, so such that even in instances where there have been some progressive policies, there are no clear guidelines in terms of how to then operationalize them, how to monitor, evaluate, and assess impact on the ground, and so forth. The governance mechanisms that exist are usually at a higher level and are not replicated at community levels. So there's a need to strengthen or to build and strengthen grassroots institutions, and then link these with, you know, the bigger level institutions for coherence, especially when it comes to implementation and avoiding what we call system level or scale level trade-offs, where different actors acting at different scales can make decisions that create problems at another scale, not the one that they are operating at. So that's part of the recommendations so far that we are looking at for Zimbabwe.
Thank you so much. I'm just checking the chat. Okay, so Muyeldzili Magoho says, how available is the data linking water, energy, and health as a foundation to the development of sustainable resilient models in this nexus?
So far, for the models that we have, they use global and national data sets that are used for reporting into the SDGs or MDCs and things like that. So Zimbabwe generally is actually good data sets. They do surveys like the SAVAC for the vulnerability assessment, which gives a lot of information on food. There's good water data also, especially for surface, but not for groundwater, but it needs to be updated. Energy data is also reasonably good at a national level. It's only at household or community level where the data is not very good, but national level data sets have been useful for one of the modules that we have operates at a national scale. It quantifies an index, a worth index that says whether it is sustainable or unsustainable. So we're able to compute that across water, energy, food, environment, and health. The other model is able to work at different scales, sub-national scales, such as catchment, provincial, and household level. So in provincial and catchment, there's still some reasonably good data, but at the household level, that's when things start becoming a little bit trickier.
Sorry, thank you, Prof. Catherine Chinyandura says, thank you, Prof, for sharing interesting work that you're doing. This seems to be a beast, a daunting task. What issues, maybe challenges playing out in transboundary water basins? Just thinking of some tensions that have been arising in the basins in Southern Africa. So maybe, Prof, you have a comment on that?
Yes, one of my students likes to call the nexus a fantastic beast. So it is a beast in that water, each of the systems on its own is complex. And there's its own governance and institutions and everything. Trying to then work across them and merge that complexity and understanding of trade-offs and what just adds to the complexity of it all. But the Nexus approach is premised on the concept of restructuring partnerships. So whilst it's mostly been understood from a technical perspective, its development was less from a technical perspective, but more from a need to restructure partnerships, a need for more inclusion in terms of how we manage across these sectors, underpinned within concepts of equity, gender, social justice, and all of those things. Now, when you look at it from an outcomes-based perspective, and you come into what is happening within our transboundary catchments and so forth, it becomes a very useful approach for convening discussions. It is also premised on the principle of polycentricism, which says all sectors are equal. There is none that is more important than the other. And that becomes also important in how you approach discourse, how you convene discussions without saying water is more important than everything else, or agriculture is more important than everything else. They're saying that all are equally important and all are equally dependent on what actors in the one sector do and how they do it. And we need to sort of always engage and work with each other so that we don't transfer problems from one sector to the other and vice versa. So in that regard, it is useful for convening conversation. It is useful for mitigating or anticipating sources of conflict and mitigating them. So we've adopted it in that regard in terms of, we are using the Songwe River Basin and the Limpopo River Basin as case studies for how we can use the approach to inform the development of development programs within those catchments and so forth.
Thank you, Prof. Again, if you have any questions, you can just direct them to the chat and then we'll forward them to Prof. For me, Prof, I'm a social scientist, an upcoming one, and my questions will, evolve around sustainability, the risks involved, and communities. And I'm going to take you to Zim context. I know you are not working in Zimbabwe on this, but when you look at sustainability of the WEF Nexus, if it were to be adopted in Zimbabwe, are there any potential risks that you foresee to the sustainability of this Nexus approach? And also, how do you think these risks can be mitigated in terms of proactive policy making and community engagement?
So we've actually worked a lot in Zimbabwe. We did a background paper on Zimbabwe back in 2018. And then in 2022, we did a position paper on Zimbabwe that was stakeholder-led in Zimbabwe. And we convened stakeholder consultations and established what is called the Zimbabwe WEF Nexus Technical Working Group, which brings together actors from water, energy, food, and environment. Then we hadn't looked at our society as water, energy, food, and environment across public, private, and civil society actors. So we've already convened different actors in Zimbabwe, established this WEF Nexus technical working group with a view to have it as an institution or to evolve it into a community of practice and institution to facilitate multi-stakeholder discussion and conversation, joint planning, and program development and implementations. So far, it has been well received by the various stakeholders in Zimbabwe. I think the attraction has mostly been from the emphasis on efficiency and resource utilization and the enhancement or multiple gains. To say if we adopt this approach, developing multi-use or multi-purpose infrastructure, the job creation aspect that I mentioned earlier on. So the reception has been good. What has been a challenge is the institutionalization in terms of how do we institutionalize it. That's been the challenge really, for it to become sustainable. Currently, it has been driven as an approach by the water sector. So it is still perceived to be a water initiative, despite that we say it is polycentric, but it is driven from a water, perspective. So trying to move it into a space that is intersectorial, where then that image, is cast away. In Malawi, we've just had a good experience where, it has been taken up into the National Planning Commission, which is an intersectorial body that is already established to work across sectors and joint program development and so forth. So those are the challenges I see in Zimbabwe, really. But I think over time and working closely with partners, there are lessons that can be adopted from elsewhere in the region.
Thank you, Prof. And speaking of, I'm actually glad you spoke about partnership. How then can Zimbabwe leverage partnerships with international organizations to create this framework for implementing, the WEF Nexus? I mean, I'm thinking about Zimbabwean context where there's shortage of water already. There's shortage of energy. It's a lot of challenges that we face as a country. So to implement this WEF Nexus, how can Zimbabwe leverage its partnerships with international organizations to ensure that this gets up and running, and not only that, but be sustainable, not only that, but address the challenges that exist in the country?
Okay, so we've been working on it in terms of investment planning from that perspective, and primarily from a climate change perspective, to say how can we support governments in the region, not just Zimbabwe alone, but governments in the region, to develop nexus projects, focusing on building climate resilience. And how do we then support these governments to access international climate finance through institutions such as the Green Climate Fund or Global Environment Facility, GEF, but then use the nexus thinking to design programs that are cross-sectorial, that are including all these sectors and that deliver on those multiple gains and across different systems and levels. So that's the investment planning and investment screening. There are strong lessons to learn again from other global South countries in terms of what they're doing. India provides some very good examples around how they've addressed the issue of water and energy and food. in terms of solar irrigation, the incentives that they've put in for solarization, as well as the disincentives that they put in to mitigate over abstraction of water, the independent power production that they've allowed farmers to be able to get sell excess energy into the grid to disincentivize, over irrigation and so forth. So there are lessons that can be transferred to, into the region and so forth, mostly from a global south perspective. And what we need to do really is to then be able to develop these projects then be able to access the global finance, especially the climate finance. That's where we see a lot of hope.
Oh, thank you so much, Prof. Tafadzana Shemabaudi, for such an insightful talk. It was a pleasure to have you. I hope you are going to have a lovely flight back to UK. I hope to meet you next time, because when I came visiting that was sometime last week, you were not there. So yeah, hope to meet soon. Thank you so much. It was really wonderful to have you. Our next speaker is Dr. Sandile Mthethwa. Sandile is a research analyst at GEMSEV and a policy advisor at Hydrogen UK. Sandile is interested in clean energy policies and their implementation. She holds a PhD in material chemistry and a master's degree in chemistry, both from the University of Cambridge here in the UK. Where at University of Cambridge, Sandile was a Gates Cambridge scholar. She has a first-class BSc honors from the University of Zimbabwe. I'll be interested to know, how did you jump from material chemistry into policy? I hope you're going to answer that question in your presentation. So over to you, Sandile.
Thank you so much, Edmond. I will answer that question. Perhaps I could start by answering that question and maybe give a background as well, which would be perhaps beneficial. So I have a PowerPoint presentation just asking if people can see that, which I'm presenting at the moment.
Not yet.
No, okay.
Yes,
How
now
about
it's
now?
sharing.
Great.
Yes.
All right, so good day, everyone. So my name is Sandile Mthethwa, as Edmond said. So I have a chemistry background, did chemistry from my bachelor's to an MPhil where I, researched energy storage materials at the University of Cambridge. And then I also went on to do a PhD on energy production or green energy production methods as well. So I think I would say that my interest in chemistry came more from an innovation perspective, not necessarily to say that I wanted to become a chemist in the more like traditional sense. I'm interested in deployment of innovation. I'm interested in people actually having access to things like clean energy. And, the underlying issue a lot is the policy, right, behind that. So innovation has to go in tandem with policy. Innovation has to go in tandem with the commercial issues surrounding it. So I think the way I jumped into it is also I engaged in other things besides chemistry. I engaged in other programs that also helped me understand what policy is, that also helped me understand how to deploy innovation. And I think that is what was attractive when I started applying to policy center jobs. So my current position as a policy advisor is actually within the green hydrogen industry. So of course, that's a very technical area, but I use my chemistry expertise to then inform or give recommendations to the UK government to say, this is what we think from a scientific angle, and this is what we think you should do. So yes, it's possible to jump if people are interested, but I think the issue is it's really good to recognize that policy has an effect on everything that we try to do. And we can't just step aside as scientists, we need to do something more tangible in the community. All right, now on to my presentation. So I was asked to talk about green energy futures and the effect on, sustainable urban health. Sorry. So I am a, energy person by background, but I will try as much as possible to link that up to urban health issues, but really more looking at what it is when we say greener futures and what it is should we think about right now to be able to get us to that point where we say, you know what, let's say Zimbabwe in 2050 or beyond is perfect. We have all the energy we need. The climate is good, but how do we get there? So perhaps this presentation will help us answer that. So I think as a bit of an introduction, which I think is important, is when people think of Zimbabwe, let's say in 2050 and beyond, what do you picture? Of course, courtesy of our favorite chat GPT, I, got this image. So that image is showing, of course, not the best way to show solar panels, but that should be solar panels, wind turbines, nice roads, people on bicycles, everyone looking good, greenery everywhere, lush, everything, right? So that's really where we're trying to go. Even if things look dire right now, there could be a potential to actually realize that future. But of course, drastic steps need to be taken. And I think those are the things that people are trying to look at today. So if you think of maybe what are some of the words that you would describe Zimbabwe in that space of 2050, words like sustainable, resilient, green, thriving, eco-conscious, smart, harmonious, progressive, but that wild future cannot just be dreamed of. It has to be made, in practice, really. All right. So then, yes, we've looked at Zimbabwe 2050, but of course, that's not where we are right now. Right now, we need to look at what's the reality on the ground. So energy, when looking at its effect on health or urban health, I think there are perhaps 2 or 3 main things, really. Firstly is how does energy relate to air quality, which is of course a huge issue when we're talking about health. So the energy industry, quite well known for producing things like particulate matter, oxides of nitrogen, oxides of sulfur, ammonia, as well as volatile organic compounds that could be, methane based or non-methane based. Also, when you're talking about transportation, which, we are putting in our diesel, petrol, things happen during combustion, then we get all those things out. So really, it's a full circle. So many things can impact the air quality. So I think in a nutshell, it's really looking at what is the problem right now. Of course, many of us know what it is, but really it's looking at the kind of scale of the problem that we actually have. Right, so I will not really go through this in detail because that's quite dense, but really the idea is, of course, what is the type of pollution we're talking about that comes from energy industry, either making our energy or using our energy. So as I said, particulate matter known to be carcinogenic. Depending on the size, they can enter your lungs, they can go into your bloodstream. We're also looking at oxides of nitrogen, which are known to inflame airways, causing, production of mucus, shortness of breath, things like that. Oxides of sulfur, known as irritants as well, and, can also block our airways. Ammonia, indirect issues related to agriculture. So ammonia could potentially cause eutrophication, acidification, and that directly affects maybe the food that we could potentially get, right? Ozone, known for cardiovascular system issues when we get long-term exposure to it. Carbon monoxide, won't even say much about that. It can be very fatal if you're exposed to that. But a lot of these things stem from the energy industry. And I think that's why people really need to move away from these fossil-based systems and go to cleaner energy systems. So that's energy and air quality, but also how about energy and not having energy? What does that do to our health? So of course, there are issues centered around that. So poor healthcare delivery, think of having to refrigerate your vaccines, think of having to allow neonatal care for young babies in incubators, waterborne diseases, sometimes we need water purification methods that need some sort of energy for them to run. Poor nutrition, refrigeration of certain foods. Perhaps they can only be available if they can be refrigerated. So the fact that they are not available can actually cause issues with people's nutrition. Mental health issues, maybe not something that's talked a lot about, but just the lack of energy. I mean, imagine what that does as well to just your well-being. Lack of educational opportunities, I think that one is quite straightforward. We're looking at, students when they need to maybe read after hours, or even right now with the color curriculum. I know my daughter always talks about that, but it leaves a lot of internet access, and sometimes when you don't have the energy, what do you do? Then gender-specific health risks. We know that women and children tend to bear the burden of having to collect firewood for cooking. So that also has an effect when it comes to having no energy access. And sometimes it's not just not having energy access, but also it's really being specific that the energy has to be clean. So some facts, which I'm sure most people here would know about. So 1 in 4 health centers in sub-Saharan Africa has no access to energy. This are stats from the UNDP, by the way. 90% of people who live in cities are above the air pollution levels recommended by WHO. 50%, so that's nearly half of all air pollution related deaths are linked to household air pollution when we're using inefficient cooking systems. And the last one is 7 million people die a year from pollution related issues. That's quite significant. Right, so the lack of access, energy access as well, it hinders the quality of healthcare, as I said before, and unfortunately it affects the poorest, most remote areas. And I think some areas, fall under our nation of Zimbabwe. So a bit more stats, again, according to the WHO, it looks at, what kind of sources of fuels or technologies are people using for cooking. So if you look at Zimbabwe there, we are in the 50 to 75 percentile of the kind of energy that we're using, which tend to be polluting. And of course, that is our good old biomass. So if you look at the trend from 2020 up to 2022, we've actually steadily increased the amount of biomass that we are using. Coal, of course, I mean, that's virtually becoming non-existent. Charcoal, not so much. Electricity is going down. Of course, we know that sometimes that is also related to things like drought, also related to climate change, and even also goes back to the fact that we are burning fossil fuels. So you see that link there. So biomass increase is of concern in our country. And I think to be more specific there is, okay, why is biomass? We know that biomass, we're cutting down trees, we're causing deforestation. And another issue that's there is urban heating. So urban heating, of course, why do we need forests? So forests are good because they shield us from the heat that we tend to get from the sun, especially now that we are experiencing global warming. So we have, inner forests that are very close to us that results in clean air, shade from the sun, wildlife. Those that are far away are good because they tend to be carbon storage mechanisms. I'm sure people are aware that, we can use trees to be able to capture CO2. And of course, that's the natural way of decarbonization. Also help us with rainfall generation, things like medicine. Of course, we were leveraging on local indigenous solutions for medicine, as well as biodiversity. So of course, if places where there aren't a lot of vegetation or trees due to deforestation tend to always be warmer or hotter than those that are more covered. And I think if you look at some trends that have been seen or simulated, I think this is from the World Resources Institute. That area there where Zimbabwe is, it shows that Precipitation result from complete deforestation in Africa. So it shows that, what then are the precipitation patterns or effects thereof due to deforestation, right? So again, dire, because we're realizing that the issue is becoming more sort of more intense than it should, because maybe of interventions that we think we're doing, but we're actually seeing that it's not actually lessening the issue. So we've talked about the problem. Problems are there, challenges are there, but I think the issue is also, so then what happens? And I'm not sure how much more time do I have, because I feel like I'm about to need to close. I still have a lot of slides.
You have 8 minutes, 3 minutes for completing the
Oh, okay.
slides,
Okay,
and 5 minutes for question and answer.
that's fine. All right. So at the moment, I think one thing I need to say is that I'm currently a fellow of what's known as the Next Generation Foresight practitioners. So these are people who look at research that includes futures and foresight on different topics. So my topic is actually looking at what the future energy and climate of Zimbabwe would look like if communities are more involved in shaping those futures with less reliance on, say, governmental institutions. So when we're looking at these futures, there's something called the futures triangle, and three things that need to be considered. The first thing is the pool of the future. As I showed in my first slide, is what exactly are we looking forward to in the future when it comes to Zimbabwe? Energy linking into climate, right? And urban health, we can also include that. What it is that is being done now that's pushing us towards that future. So we call that the push of the present. And then we look at the challenges that we have, usually challenges that tend to be traditional based, culture based, policy based. So what is the weight of the past? So all these three things need to be understood. And what we're doing is we're going to communities and actually having all these questions that align to the three key areas so that communities also understand how important their role is in shaping those futures. Of course, we are not saying governmental institutions should not do anything, but also saying that communities should also be able to see a gap that they can feel as well. So when you say about pull of the future, what are some of the things we think about? So things like adopting renewable energy sources is what we see in the future. That's what's going to happen. Innovation in these clean technologies is what we see. Affordable and equitable energy access is what we see in the future, right? And also strong policy frameworks for sustainability is what we see in the future. What's happening now to get us to that future is things like rising awareness of climate change. Of course, a lot of programs are happening to sensitize people on these issues. Community-led initiatives for sustainable development is also something that's pushing us there. A lot of investment that's happening right now in green energy projects, something that's pushing us there, right? And also people even being aware of these issues would demand more. They want better living conditions. They want cleaner energy. That's a role that communities can also play in terms of advocacy. But we have the weight of the past, obviously. There are things that are just challenges that are just bringing us back. Dependence on fossil fuels. I think for us, obviously, coal, oil, and gas, a good thing they are not too much of a problem in Zimbabwe. I mean, of course, we don't have gas resources, we don't have oil resources, but I think coal is dwindling. But of course, the issue for us is biomass. The other issue is weak infrastructure and planning, limited resources for green technology. That's also an issue. Things like lack of education and awareness, things like that. So we need to address those things so that they can help us in pushing forward, right? So I think my last slide is really on the call to action. Once we've done those futures and asking questions to people and making sure that we understand all those three pillars, we then would be able to come up with very community specific interventions. And I think these look like, how do we promote the best renewable energy adoption mechanisms? Sometimes it differs from community to community. Not all communities will want everything to be solar-based. Not all of them would want hydropower. Not all of them would want biodigesters. Because I guess also with community, you also think about maybe more decentralized technologies at times, but these are things that we also need to be aware of. Leveraging traditional knowledge is also an important one, because as much as traditional knowledge is also looked at maybe a barrier, it can also actually be a solution, and people will be more engaged in some of these things when it comes from them. Encouraging sustainable transport, I think that's twice, shouldn't be twice. Foster community education and awareness. So I think those are some of the things that in my own research, we're trying to find the best ways to be able to do that, but I also found that it's always good to talk to communities, hear what they think, and then try and build interventions from that. Okay, I think that is it for me. Thank you very much.
Oh, thank you so much, Sandle, for the excellent talk. It was really engaging and really you touched some of the questions that I wanted to elaborate more, particularly on issue on community engagement. So maybe I'll just start off on that one. Like, how do we really try to build or develop or implement policies that kind of target people who are in urban areas, because of our energy drought that is taking place right now, there is now over-reliance on biomass for energy, particularly in urban centers. And that is also leading to an increase in different types of diseases, particularly respiratory diseases. So how can we develop really policies that protects public health whilst at the same time encouraging clean energy? Do you have any way we can try to address that particular issue?
Yes, so as I'm not really a health person, perhaps I can answer it from an energy perspective. To be honest, I think that a lot of intervention needs to go into incentivizing people to use clean energy solutions. We are aware that solar kits, especially those that are high quality, are not within the affordability range of a lot of people, right? But it is one of the things that can work. However, I think, of course, I work a lot on the UK, so things like subsidies always come into play. But it's also like, how then do you convince, our own governments to be able to give such subsidies to people so that they are able to either purchase long term, and yeah, so I think there is a role that government needs to play here so that the clean energy provision is not too privatized, which I think in our country it perhaps is. Although if someone else has a different opinion, but I think that is probably the problem, because there aren't mechanisms in which people can afford some of these solutions that they need. So I'll say subsidies to encourage adoption.
Oh, thank you so much for the response. We look forward for more of your work, and I hope our policymakers, we can collaborate in the future to develop some policy briefs or some policy statements to try and push for clean energy here in Zimbabwe. As part of the Zimbabwe Research Network, that's one of the things that we do, bring together people from different fields so that we can write policy briefs that can help to inform the policies that are being implemented here in Zimbabwe. We have one success story. I'll share after Prof. Julius Mkwagwa speaks on how we engage the government and influenced policy here in Zimbabwe. So thank you so much, Sandile, for the excellent talk. Thank you so much for all the work that you are doing. It was an honor to listen to your talk. Up next is Professor Julius Mkwagwa. Professor Julius Mkwagwa is a professor of health Innovation and Public Policy at University College London, Department of Science, Technology, Engineering and Public Policy. He also currently serves as UCL's Global Strategic Academic Advisor for Africa and Global Health Thematic Director for UCL's Global Governance Institute. With undergraduate and postgraduate qualifications in biological sciences, biotechnology, and regulatory innovation in the life sciences. He has worked in veterinary research, pharmaceutical research and development, manufacturing and quality assurance, harmonization of medicines, regulatory systems in Africa and Europe. It is our great pleasure and honor to invite Prof. Mgwagwa. Prof, the floor is yours.
Thank you, Edmond. Can you hear me?
Yes, I can hear you.
Right.
Thank you.
Thank you very much. Let me try to share my slides from here. Just a moment. I don't know if you can see them.
Yes, we can see them.
Okay, that's great. I'll just go to the beginning. So it's my pleasure to be part of this very fascinating forum to hear the exciting work that different colleagues are doing. Congratulations, everyone, for the excellent and timely and very relevant work you are doing, and to the organizers as well for bringing such a rich panel or sets of panels of speakers together. So I'm going to be talking about these issues, tackling disparities in urban health through science, technology, and innovation. And I think it's a nice segue from what Sandile was talking about. So I will really not go into some of the issues that she has covered. It also connects very nicely as well to what Professor Mabaudi talked about, and even to some of the issues that were highlighted earlier as well. So I will essentially be singing to the choir here, because a lot of the speeches or the presentations have really shown the central role of science, technology, and innovation in the issues that we are grappling with. So I will not spend a lot of time elaborating, but I thought I should also connect to a question that you raised, Edmond, around whether your mother knows about what you're doing. I found that quite intriguing, really. It is an important point to reflect on as we do our research in the different areas that we are interested in. And it got me thinking that, we grew up knowing or talking about, and even now, that charity begins at home. And I got thinking that I think we should also start thinking about how influence and relevance should begin at home as well. So I think we need a new framing, we need a new way of thinking about this. So the influence of our research, the relevance of our research must start at home before we think about influencing policymakers and other stakeholders. How relevant is it right next to us? So I thought I should just reflect on that as well. So part of what I've been doing, among other things, building on the background that has been highlighted and all the work I've been doing, is to do some work on health disparities in London, here in the UK. So I've been doing quite a few projects on tackling health disparities in one of the boroughs in London, but also increasingly expanding that into other areas as well, using digital technologies. You will be amazed, surprised to the level of inequality that's there in London, sometimes based on the histories of some of the boroughs, the structure of the NHS, but also the demographics in particular segments of those boroughs, in particular segments of the country. So there are some issues that we've been looking at. And I'm now beginning to think about how we can look at some of those issues in Zimbabwe as well. So this presentation is really highlighting some of the preliminary work I've done around urban health disparities in Zimbabwe, and trying to see how we can really proceed on addressing some of those issues. So in terms of context, a lot of some of the challenges, the deficiencies within Zimbabwe have been highlighted already. The issues around rapid urbanization, the infrastructure deficits, the energy issues we're just hearing about, resource constraints, then also some public health crises, which really exacerbate already challenged realities for the healthcare system. And to just reflect that the proportion of people living in urban areas in Zimbabwe has been increasing steadily over the years. I think it was around 24% early on after independence, 1982, it was about 24%. And now we are sitting at around 35%, according to the stats from ZimStats, the World Bank, our golden data, and other sources as well. And then, of course, compared to the rest of Africa, where the average is 43%, people living in cities, then globally 56%. And for the UK, where I'm sitting, it's 84%. So the urban space really brings its own particular challenges, as we are hearing, in terms of provision of different utilities. But for health, it's a particular challenge. It's a context with particular challenges. So some of the key challenges in urban health, again, I will not go into much detail on this because some of it has been highlighted already, but issues around inadequate water and sanitation services, where quite a big proportion of the population or urban dwellers do not have adequate access to these services. Current stats show about 42% of urban, only 42% having access. Then the infrastructure issues and workforce shortages, again, it's well documented. The maintenance issues, climate-related challenges, even to do with pollution, as we're just hearing as well, water scarcity issues, issues around resourcing, funding deficits in the public healthcare systems, the municipalities struggling to not only to provide because of limited financial services, but also some of the inefficiencies within the system, for example, around billing for water in the health services, and how that further strains the infrastructure that's there. Then the issue of informal settlements in some of the peri-urban spaces, which are not adequately covered, but very much dependent on the facilities in the urban areas. So that's a lot of challenges. And we know that science, technology, and innovation plays a big part in addressing some of those challenges, for example, in terms of identifying disease hotspots through GIS mapping or epidemiology studies. And when you step back or look around, we see that ST&I tools are already key in driving healthcare systems. So this is a slide that I'm acknowledging one of my colleagues, Dr. Brighton Shireka, who talks about how in clinical settings, we see already the dominance of artificial intelligence in interactions between clinicians and patients, in diagnostics, in interpretation of data, in report writing, and so on and so forth. Telemedicine and virtual care, wearables for monitoring, whether it's for blood pressure, for sugar, and so many other aspects. These are tools that are coming from science, technology, and innovation, which are already in use. Genomics and precision making, robotics in healthcare. So there is a lot that's already happening. But how do we couch all this within a broader framework where there are dialogues at different levels between research, technology, innovation, implementation, and then the outcomes that we desire. And picking particularly on research, I think it has come through already. I remember, I think it was Catherine who was talking about the role of indigenous knowledge systems. And for me, that's really fundamental, that while we are talking about science, it's important to realize that we are not only talking about the natural sciences, your biology, your physics, your chemistry, or different varieties from those, but we are also talking about the social sciences and how they are really important as part of the multidisciplinary research that needs to be done, so that we can be able to have technologies that are informed by the context and the realities that are there within urban settings, whether we then result in mobile health tools, or we result in we then come up with some sensors for monitoring the water quality, but how do we embed that within the socio-cultural realities and some of the other contextual elements that are important as well. So there is some work that's already happening in Zimbabwe, for example, around health, around sensors for water quality. Some work also happening on eco toilets in Harare and Bulawayo, and work on solar clinics with some non-state actors. For example, the organization called Practical Action has been involved in solar-powered clinics to really deal with the energy challenges that are there. And then some community sanitation projects as innovation that are coming through from there. So this is just a framework that's trying to just really look at a holistic way or how we can actually bring these different elements together. And particularly, like I said, the departure point and also even the continuation at different points being the need to harness different ways of knowing, different ways of doing, or essentially different knowledge systems in that. Again, just an elaboration on what I was talking about, smart water monitoring systems, eco-friendly sanitation, solar-powered clinics, where we've got reliable, renewable energy to power critical medical services in urban clinics, health solutions, the real-time access to healthcare advice and telemedicine for the populations. I think there are a lot of lessons that came through from COVID, which have been carried over, particularly from health applications, community recycling as well, the environment itself. How do we keep it clean? How do we recycle so that it's a health issue, but it's also an employment creation issue for the urban population? So let me zero in on another specific issue, which I would call the proverbial elephant in the room, the issue of health insurance coverage. It's a live problem. It's a wicked problem. Now, if you reflect on these sobering statistics that at present only 7% of Zimbabweans have healthcare insurance, and this leaves the majority vulnerable to financial strain when accessing medical care. And some people just do not access medical care because they don't have the money to do that. And we were hearing, I think, one contribution earlier on that people, for example, in farming communities, that they cannot even afford to take time off work so that they can go to the clinic or the hospital because they don't want to lose earnings. And that's the reality for a lot of people, particularly in the informal sector, that they just have to keep going until your body then says you cannot go any further. So the need for health insurance is really an important existential matter for a lot of people that are really vulnerable. So the government has identified some vulnerable groups: children under 5, the elderly, people with disabilities, as priorities for free healthcare. But again, this priority is for a much broader segment of the population. So there's been discussion for a national health insurance scheme since the 1990s. It's been a while, actually, while this has been in discussion. And just stepping back and talking about national health insurance coverage by country, you see that the challenges that are there in Zimbabwe are not unique to Zimbabwe only. It's actually a problem of many low and middle income countries. This graphic here just shows the countries in red where more than 50% are uninsured. And that's a cause for worry, particularly for people in urban areas, but in other parts of countries as well. So the countries in blue will be the countries where there is universal health insurance coverage. Not surprising, really, given that it's very much connected to the GDP per capita and the level of development of those countries. So that's part of the backdrop, really, that there is a lot to do. It's a challenge, but it's also an opportunity for ST&I. So in terms of some of the key features and the goals for the National Health Insurance Scheme, it's about universal access, seeking to ensure that health services are available to all citizens at no cost at the point of use. Here in the UK, the National Health Service is actually well known for that it's free at the point of use. Of course, there are certain services that you'll have to pay for. The other key feature or goal is about funding mechanisms where contributions will be compulsory to the extent that is feasible, and also sourced through different mechanisms. For example, earmarked taxes on health levies, and then harmonization of different existing health funds into a single pool for efficiency and equity. The big question around how do you collect contributions from people that are employed informally, people doing their work, earning their living through informal markets. How do we get contributions from there? And then public-private collaboration will really be important as well for that. So the implementation challenges will also be an opportunity, because as you can see, the National Health Insurance Scheme is both an issue around financial sustainability, as it is a governance issue, and it's also a health infrastructure issue, because when more people are covered, it means there's going to be a higher demand for healthcare services. So covering everyone through health insurance has to move in tandem with expanding the healthcare provision itself. So the Minister of Health and Child Care Permanent Secretary, Dr. Aspect Maungani, highlighted in June, or remarked in June, that we recognize that the journey to implementing the National Health Insurance Scheme will be complex and will require the concerted effort of all stakeholders. And that's absolutely true. How do we get that concerted effort to happen? So that's where maybe drawing lessons from elsewhere will really be key. And I'm sure in the consultation that have been happening in Zimbabwe, that there is a lesson drawing from elsewhere that has been happening, and how that then becomes refracted into local context, embedded and made relevant will really be important. So there are examples from Denmark through the integration of healthcare records, from Singapore, digital identity systems for allowing seamless verification of patient information and insurance claims, because there could be issues there in terms of the claims that come through. So efficiency and transparency will really be key. From Iceland, integration of electronic health records, again, eliminating duplication and minimizing administrative burdens. That will really be key. From Rwanda, lessons around leveraging mobile technology. So there's really need to expand people's access to mobile technologies, so that people can then be able to utilize those technologies for their healthcare insurance. Then from India, again, identification systems being very important, then leveraging telemedicine and mobile health apps as part of the insurance scheme. So like I said, the National Health Insurance Scheme and tackling health disparities broadly is possible through science, technology, and innovation. There is an opportunity there to really try and see how this particular health challenge can be addressed through science, technology, and innovation, to ensure that there is improved efficiency, there's equity, and also sustainability of the system. Empowering communities is really key, and digital technologies are important for empowering communities to really own their health-seeking behaviors and what they can do for them to access health services. But embracing these tools at a broader level requires really that all the different actors are mindful about data security issues, integration and interoperability. The weight of the past, as Sandile was talking about, there are legacy issues, there are institutions that are there. How do we ensure that whatever we introduce is interoperable with what is there? Then issues around equity and access as well. No one should be left behind as we move on with the schemes like this. So this is a framework that I'm proposing, and this is probably my call to action in terms of some of the ideas I'm thinking about, and whether there could be opportunity to collaborate on this. But just trying to really see if we can use the National Health Insurance Scheme as a case study where we explore these multi-level dialogues between research, technology, innovation, and implementation, drawing from different disciplines. And I would be curious to know from those in the room, just maybe through the chat, if you can put in there how your discipline could contribute to this research. I can see very clearly the role of finance. I can see clearly the role of people involved in urban studies, policy scholars, people in data analytics, and the other social sciences as well. So I would want to hear from the engineers in the room, even from people from ethnomusicology. For example, how will music be able to help us in a multidisciplinary undertaking that's desiring to operationalize the National Health Insurance Scheme? And then the kind of technologies, the kind of innovations, and the implementation mechanisms that can emerge from there. So that's it from me, really. This final slide is just indicating or just summarizing again what I'm really keen to get and to contribute to this community. That I'm open to collaborations with academics, fellow academics, people from industry, people from government, and practitioners as well, to explore some of the wicked problems in urban health, particularly keen on issues around entrepreneurship in health or entrepreneurship for health, tackling issues around agency, around scaling, sustainability, localization, and inclusion. So let me end it here. Hopefully I've left us with a bit of time for a discussion. Back to you.
Yes, thank you so much, Prof. Yes, you have given us something to chew, a bone to chew on. Can you go back to the previous slide? Yes.
This one here. Okay.
Yes. I'm in environmental chemistry, and I just posted it that from my environmental chemistry perspective, I will look at the multidisciplinary research that, like Sandler mentioned, those toxicants that we really need to continue monitoring that. We don't have data for that. And my area will be contributing in that aspect of the monitoring the toxicants and trying to link them to our health. That's an area that I'm interested in. So we are opening the chat now. If you are available to make a comment, maybe you can just tell us your discipline, how you would contribute to this framework, and also throw in a question for Professor Mukwagwa to respond. So this is your opportunity to engage with him. So you just give us your discipline, how you'll contribute to this framework, and then ask your question. Any contributions? Can I call upon Dr. Tatenda?
Hello.
Yes. How do you contribute to this framework?
I think for me, it's in the multidisciplinary part, also innovation, part of it, and possibly improved urban health, because I'm quite well-rounded as well, quite multidisciplinary in my approach.
Mm-hmm. Okay. And Tatenda, you're an economist, right?
I'm an economist by training, but now I'm transitioning more to like digital research and etc. So I'm more leaning into the computer science world, the digital health world, etc.
Mm-hmm.
Yeah.
Mm-hmm. So what models would you suggest for collecting contributions from the informal economy?
Personally, I am more inclined to traditional qualitative approaches. I think that that's what proves to work, if anything. And even if we're to go to quantitative route, you would still need surveys, because the only way you can understand informal sector is through talking to people in the informal sector. There's no other way.
Okay.
Yeah.
So we could use that to get the ideas, for example, around how they can actually contribute to this insurance scheme. Because
Right.
that has been one of the challenges that these are men and women, boys and girls that do not get a pay slip, and maybe their money does not even go through a bank account.
Yeah.
So how do you actually get them to contribute to this scheme? Because they'll be one of the biggest beneficiaries as well. But
exactly. So
yeah.
we cannot have a top-down approach, but rather a bottom-up approach when it comes to understanding how to have an insurance scheme of some sort at the informal level. I mean, think about it. When it comes to Nyadzima rounds, I'm sorry, I'm using Shona right now, there's already systems in place when it comes to people creating social protection mechanisms for themselves in our society. And there's no need to reinvent the wheel, but rather try to use the existing methods. Because when we talk about the concept of maround, it's a way of protecting ourselves for the future. And that can be easily transferred to the health side of things, where we can have health savings accounts, for example, using the same concept, where we're contributing to a fund that not only is like for the household side of things, but also for the health side of things. And we have a trust-based system in that. There's more trust in the system around than it is in some banks, for example. And so that can also be incorporated. And I think we cannot resist what people want. I think traditionally, as researchers, we tend to resist what works for people, because we always want to say, no, let's formalize, let's involve other parties, let's involve insurance companies, etc. Whereas we need to understand what people trust, what they want, before we say, hey, this is what works in Western countries, this is what works in developed countries, or those that are middle income. What do Zimbabweans want? What works for them? Who do they trust? And we can take it from there.
Yeah, that's fascinating. I could see Edmund nodding as well in agreement with your suggestions. I think the issue of trust is really quite key in this, and that's a message that cuts across many areas, really, in terms of adoption of new technologies or even introduction of new schemes, that people need to be able to trust the scheme that you're talking about. And if there are local level structures that people are already utilizing, which are built on trust and transparency, like the rounds you're talking about, then those could be utilized. I saw something on taxi associations from Catherine. I think that's really important. So how do we build on what people have already normalized, people have already accepted? Because if they can't trust the national level structures, or if that trust is going to come, we can't just impose it. Let's build towards that trust, but maybe more localized solutions could work. And in Rwanda, they've actually implemented successfully community-based health insurance schemes. So where the communities is the more homogeneous, where there's more trust and people know who they're dealing with, and then that can be scaled up as needed. Thank you.
All right, thank you so much. I wish we had more time for this engaging talk. Maybe you can go to your last slide so that people know how to contact you. If you have more questions, or if you are really notice some particular area that Prof. Mkwagwa mentioned that you are keen in partnering, in collaborating with, these are his contact details. You can reach out to him and work out something for the development of our research community here in Zimbabwe. So thank you so much. I can give a clap to Prof. Mkwagwa for such a wonderful talk and for opening up our eyes and ears to start thinking more outside of our confines, of more outside of our disciplinary silos, so that we can really come up with some innovative solutions to the wicked challenges that we are currently facing. Next up is Dr. Margaret Siawamaya. Dr. Margaret Siawamaya is a visiting senior research fellow at the University College London, in the same department as Prof. Mkwagwa. She's also a lecturer at the University of Zimbabwe. She holds a PhD in pharmaceutics and drug delivery, and also a master's degree, which she converted to PhD from the University of Witwatersrand. She was previously the secretary of Zimbabwe Young Academy of Sciences. Without further ado, please allow me to introduce Margaret. Your floor is yours.
Thank you very much. I don't know, can you see my screen? Is it showing it?
We can see your face.
Okay. Yeah, but anyway, thank you for the kind introduction and for inviting me to speak. This really has been very fruitful, and I've enjoyed every moment of it. And I hope we can have more events like this. And it's just exciting that, the focus is on Zimbabwe. And it's amazing what people are doing. And yeah, very encouraging, actually. It encourages us to keep going. So I'm just going to start off my talk by giving you a brief overview of my experience as a pharmacist in a public hospital, and mainly in a pediatric cancer ward. Because mainly my talk is looking at the realities that we have. So we've been talking about health, the problems that we have, sometimes the solutions. And just now, as Prof. Mkwagwa was talking, someone commented on how sometimes we adopt lessons maybe from the global north and try to adopt them, but we need to know what's happening. So I'm just going to give a brief overview of what really is happening on the ground and where the contention comes. So yeah, typically in a pediatric ward, just like any healthcare worker, you wake up and you really want to do the best for people. You really want to apply your knowledge, what you learned in school. But once you get in there, it's a different system altogether. There are many times where even my science was questioned. I didn't know which book to open and look for answers for, because the problems that we're faced with, really, I didn't know what to do about it. And that's largely because of many issues and systems that are not in place, that could be in place, and things that we could do that we are not doing. And working with children, you soon realize that children have specific needs. We can't treat them like they're just small adults. In most cases, when you look at drug development, and you realize that children usually come as an afterthought. So the first thing in the forefront is medicines for adults. And then later on, we're like, oh, how about the children? And because of that gap, you find people are making plans to try and make, they're trying to manipulate what has been made for adults to try and make it suitable for children. And my main message today is we can do better. We can do far much better than that. Because when you look at access to medicines, usually we're just looking at having a product in Zimbabwe, having a product in the hospital, but we forget so many other dimensions and facets to it. Talking about the availability in the setting, but also affordability, something which Prof. Mkwagwa touched on when he was talking about health insurance. And then geographical accessibility. Can the people in Zimbabwe, in the remote areas in Zimbabwe, also access that? And then we talk about the quality. Quality is important, especially when we're looking at children, because they are vulnerable. And then acceptability, something that we overlook, and yet it can actually be the difference between a good and a bad health outcome. Children are fussy, give them something they don't like, they will not take it. It's difficult to actually convince them to take something because unlike adults, adults understand that if I take medicine, I'm going to get better. But that's not the case with children. They just don't understand why you're giving them this very bitter pill or liquid. So because of my experiences there, that's where I've reached where I am now, where I'm working with Prof. Ngwagwa, and we're looking at the health industry and science policy interlinkages. And this fits in well with what the previous speakers have been talking about, multi-sectoral approach, because the problems we are seeing in the clinical setting cannot be solved in the health sector only. We need many other sectors on board. For industry, the solutions for the health sector, which are medicines, they are coming from industry, which is why we need industry on board. And then interestingly, also science policy, there's a lot that we can get from there. So why the focus on child health? So briefly, just looking at the population of children in Zimbabwe, they make up almost half the population. So this is a population that is going to contribute to the economy of Zimbabwe. So we need to prioritize their health, because if certain things are not fixed at this age, when people are growing and developing, if we miss that chances I would actually never be able to fix it. So we're talking of lifelong disabilities that can be avoided. And as some pediatricians have noted, that actually there are children that have rare diseases, and these children are dying prematurely, not because of the disease, but simply because we lack the appropriate medicines. So it takes us back to that issue of access, where we're saying we just do not want a medical product, but we want a product that is appropriate for the population. And in this case, a product that is suitable for children, a product that they can accept, because if we don't use it appropriately, it's not going to work, and we are not going to have the health outcome that we want. What is often happening, as I mentioned earlier on, that if we don't have the right products, we just take the medicines for adults and we manipulate them, we cut them in half, we crush them. And there's so many dangers associated with that. Because all these unverified methods actually are potential avenues for medication errors. So in as much as we might think that we have solved the problem, we might actually be making things worse or actually not going anywhere. But what's the situation like in Zimbabwe? So there's been a lot of focus on the infectious diseases, but we see that our disease profiles are starting to mimic those in the developed countries. So there are more and more non-communicable diseases, and there is actually a shortage of medicines for children in this regard, where the other issue is when we look at manufacturing again, we could look at the local manufacturing and say, why aren't they doing something about it? But manufacturing is a different ballgame. Again, there are market forces to be considered, economic benefits, because a manufacturer is not going to start making a product if there is no tangible profit coming from it. That is the reality. So it doesn't matter what's happening, in public health. Manufacturers need their return on investment. And the current model is that our manufacturers are mainly making generic medicines. So medicines that are off patent. And for them to be competitive in that space, numbers matter. So they need to make these medicines in huge volumes. But now it becomes tricky when they're working with children, because it's a market size that has been described as being small. Maybe it's not really small. It could be that it's just fragmented. But because those numbers are really not what the manufacturer is looking at, because they're looking at the huge numbers. If you take, for example, adults that have hypertension, you can supply the same product for so many people. And that way you can have the huge numbers that you need to make up for the return on investment that is required. So there is actually a gap in terms of homegrown innovation, which is why industry is currently underperforming. But we can actually look at having our own innovations locally as a tool for leaving no one behind. And in this case, leaving no child behind or no subpopulation behind. So I'll give an example of some of the examples from Zimbabwe. For example, for treating whooping cough, according to treatment guidelines, you need to use erythromycin, so an antibiotic, erythromycin. And there is a company that is actually making that locally. And this product is very affordable and it's available in most public and private facilities. But there's only just one problem, the clinical application. So you find that this product really is not easily acceptable by the patient because of the taste, because of the stomach upset that is associated with it. So eventually, clinicians then look for an alternative, something that is not in our treatment guidelines, but something that has been studied to work, and it's an imported product. So again, we are not, that's money that could be spent on a local product, but then now we're relying on an imported product instead. So that's where this is an example of how maybe innovation could actually help. And that's where we actually have to look at other sectors. It's not just, the solution is not just embedded within industry, because industry are doing their best, but the health sector can also contribute and give that feedback on clinical application. Science policy can also come in as well and try help us again with that innovation and to try to de-risk industry. Then another example, this one is a success story now. This is one of the cases where newborn children need to be given vitamin D. But at one point, it happened that there was only one supply of vitamin D in Zimbabwe, and their import permit expired, so they could not import the vitamin D from India anymore. So there's a shortage of this product on the market, and people, the clinicians were now using those unverified methods to make the vitamin D drops using tablets. And there's so many worrying things about the methods that they're using and the ingredients that they're putting in there. So one local startup decided to fill in that gap. So they used resources from the University of Zimbabwe. They used resources from local manufacturers. They did toll manufacturing with an established manufacturer until they actually managed to make this product available on the market. And it's actually very suitable to what is recommended in our treatment guidelines, which is a plus. So in closing, I would say, given what I've spoken about what we need for us to have good treatment options for children and the possibilities and what is happening in Zimbabwe is, initially we looked at it and thought, okay, we need to just look at the health sector, we just need to look at industry and make sure that there are interactions between the two. But then we realized that no, we actually need science policy, because it's in science that the skills that are needed in these sectors are actually being groomed and embedded, and science can actually help with the agenda setting. But then I think the story doesn't end there. There are possibly other sectors that could come on board to actually help in this situation. And I would like to leave you with a question. So what limits your discipline from contributing to this challenge? Since I've highlighted that actually so many people can be involved, so many sectors and disciplines can be involved. So I'll be just curious to hear from people in the room, what really limits us from contributing to this challenge. And thank you. I think that's as far as I go.
Thank you so much, Dr. Siawangwaya. I think everyone in the room, you have heard the question. Think about it. If we have time, we will have just a few, maybe one or two individuals to just come in from their different fields and just see how they can collaborate. But Dr. Margaret, now what you've spoken about really, I was laughing at myself because I just went with my son the other day to the doctor and there were no syrups available, and we ended up getting like actual tablets. And some of them were made into half. Some of them, the doctor said, just make him chew or put it in ice cream. So it really resonated with me in so many ways. But given that, you talked a lot. I think my questions were centered around the gaps that exist, the trust issues as well. As a mom, I have trust issues in terms of medication. So I'm just gonna ask you a few questions around that. So in terms of the social reality being, like for me personally, I have trust issues when it comes to certain medication, certain vaccinations, when it comes to administering them with children. also because I have lived in, like in Kenya, it's the hub of experimentation for vaccination. So when they call a vaccination that's not on the schedule in my child's book, I'm not listening to that. You know, if they bring in some innovation and say, oh, let's do this for children, I'm not participating because of trust issues. So I'm sure the reality also exists. That reality also exists in Zimbabwe. What do you think? What recommendations do you have in terms of that? How can you, being a pharmacist by profession, you've worked in Zim context, what do you think can be done to address those trust issues?
Thank you very much, Tinai. I mean, it's good to hear just from someone that is first-hand experience in this. And right, so to address your question, trust, I think, yeah, it's not just in children, even adults as well. We need to have trust in the health system. And I think that's where, you know, for example, I was talking about science policy, and because when it comes to, for them to actually tell us that you can use this medicine in children, I would say possibly two things would have happened. The first thing being that studies have been carried out, and there is certainty that you can use this product, how often and how much in a child is safe. However, we don't always get a chance to do those studies in children. It is difficult, even if you get a chance to do that. It's very difficult to get ethical approval because they're actually quite strict on how they assess your application. So sometimes some of these products that we are using, it's really based on the clinician's experience. So where they try to use, and we call that using products off label. So that's based on, you know, reading around theory, and they say we're going to try this and this is what we're going to do to make sure it's safe. So, and as they use and exchange notes, then that's how they arrive at a conclusion to say we can use this product. So there's no written document that says this study has been carried out. So that is the reality. And we're saying about 70 to 80% of medicines used in children are being used off label. And that is where I think we can also come in as researchers and say, this has to change. And we need people that are well trained to do this. And there is currently a shortage of people that are well trained to actually carry out studies. And that applies to Zimbabwe, that applies to Africa. So that is where, you know, a network like this can actually start mobilizing something like that, build that network, to start building those skills, because we need them. And the beauty of it is that once you have people that are capable to carry out such studies, it means the other ones that are less demanding, we already have the capacity. So we're not just doing it for children. We now have a whole, we have the capabilities to tackle many other challenges that we have in other populations as well. And yes, I hope that answers your question.
Yeah, I mean, it's gonna take a long time, but thank you for that. And then you also talked about the gaps that exist in terms of, you know, pharmaceuticals and the health system in Zimbabwe. I'm just paraphrasing. I hope I got that right. But how, as a recommendation, what do you think can be done in our Zim context? You have experienced the best of both worlds, you know, so you know what happened in the Western world, you know what happened in Zimbabwe. So what do you think can be done to improve, especially medication administration? You were talking a lot about sorry about the noise in my background. You were also talking about health outcomes for children as well. So what can be done to address those gaps in Zimbabwe?
Okay, yeah, certainly we can learn from what other people are doing, but then let's not forget our context. For example, in the UK, they're encouraging manufacturers to start making medicines for children. So if they're filing an application for marketing authorization for a product for adults, they also have to show that they are considering children. They're doing studies to make sure that, you know, there is a product for children as well. So that way they're trying to encourage research in that way. And I think it's something we can look into. Also based on what is feasible. So that's one way. And then another way is sometimes we always look at just maybe the industry and we say, give us the solution. Maybe there are other ways around it. For example, I was giving an example of that local startup that managed to fill in the gap. So that whole project was funded out of pocket. And they've managed to put a product on the market because they use the resources around them. They use the university, they use the established manufacturers, and they ask them just to make that product for them because they already have the infrastructure. So if we can have that sort of network and collaboration happening, I think we can solve some of the problems.
Thank you, Dr. Sam. Lastly, as a social scientist, I have to ask. We talked about traditional medicine versus modern medicine, and because we are, in an African context, if I'm told that this herb works to cure cancer and I have a cancer, I'm going to follow it instead of, going for chemotherapy or, the modern medication. So how do you think in Zimbabwe, how can we integrate traditional and modern medicine in a way also that is culturally sensitive, a way that is sustainable, a way that is ethical as well? I know you touched on a little bit of ethics when you just in the last question, but how can we have that integration without offending one or the other side?
Yeah, very interesting. I could easily comment on how we can, talk about integration, but regarding offending the other side, I'm not so sure because I'll just give a few examples of what is actually happening on the ground. So the good thing is with Western medicine, we've got diagnosis and we've got tools to help us to diagnose. And then we've got the medicine. And that medicine is actually coming from years and years of research. And we keep researching, even if the medicine, the product is on the market, we are still watching what's happening. Are people still safe? We don't have, unfortunately, those mechanisms in the with traditional medicines. We're not so sure what's happening. It's a bit blurry sometimes, hit and miss. So I think the way we do in both worlds, there's research going on, but there are different ways of doing research. For the Western medicines, we document it, we watch what's happening. Whereas for the traditional medicines, it's like the work is happening, the research is going as people are using and as they are prescribing things to people. And one situation was someone claimed to have given a patient some cure for cancer, and they're saying this works. But when people actually spoke to that patient, they realized that what was being referred to as cancer was actually very bad period pain. So traditional medicine might have the medicines that we need and they're working, but I don't think they're good at diagnosing, which is what the Western medicine is very excellent at. So integration would be maybe they can work together to say, let's use the tools that we have because they're backed by research and try to find out what is wrong with this patient. And then maybe traditional medicine can also come in, but there has to be that openness, because if people go to one side and get something, go to the other side, they get something, so many side effects. And that's one thing that we are not talking about. There are many people that are being hospitalized because they have taken traditional medicines. So they are not bad, but they have to be used appropriately. And also some of these Western medicines, their origin is actually in herbs and plants. And so in a way, there's an element of it being advanced because then they refined it. They came up with a dose. They came up with the right dose that's going to make sure that you're not exposed to any toxins. And so it's the same origin, but one side, at least, they tell you how to take it and how to be safe when you're taking it. On the other side, sometimes it's hit and miss. So yeah, it's a bit difficult because also when you talk about traditional medicine, there's that spiritual side of things which you really can't argue, with anyone about. If someone is saying because of spiritual reasons, this is why we're giving this, you really can't say much about it. So it's really about respecting what is happening, but it's good to bring them on board and make them feel and know that, their input is valuable. And it's a matter of us working together to use our strengths to actually help people.
Thank you so much, Dr. Siawangwaya. We have learned, I'm looking for the Shona term I've forgotten, but thank you so much. There's a Liberty Navaya, a student He's a second-year master's student in biochemistry with drug discovery being his field of interest. And he's saying, as an upcoming researcher and scientist who is versed in computational biochemistry and looking to build my own network, how can I be of use or how can I contribute? So maybe this is from the chat. So Dr. Margaret, you can interact with everyone on the chat so that we move on to the next session without taking so much time. So thank you so much, Dr. Siawangwaya. It was really informative. So now I'm going to introduce Dr.
Thank you.
Brunette. I'm going to introduce Dr. Brunette Katsande-Gwaza from the University of Liège in Belgium. She's going to talk about a passion for science, a journey in infectious disease research. So just to introduce Dr. Brunette, she is, sorry, my screen just got away from me. Dr. Brunette is a scientific researcher at the University of Liège, where she was previously a research fellow. She was a postdoctoral researcher at the University of Cape Town and a lecturer at the Chinhoyi University of Technology. She holds a PhD in immunology from the University of Cape Town and a master's degree in biological sciences from the Vrije, please excuse me if I failed the pronunciation, Vrije University, Brussels in Belgium. And she's interested in experimental immunology and data science. So welcome, Dr. Brunette. Thank you for taking your time to engage with us. You have the floor. We can't hear you. I think you're on mute.
Can you hear me?
You're still, yes.
Okay, perfect. So thank you so much. As Tinaya introduced me and Edmond, I'm Brunette. I'm currently at the University of Liège. Yes, in English you can say Liège, yeah, but in French they pronounce the E as a yeah, so it's a Liège. At Liège in Belgium, yes, and I'm currently an assistant professor, right, or we can say a glorified postdoctoral research fellow. Is after your first postdoc, and then you go to the next stage, yeah, and you become an assistant. So today I'm talking about my passion for science, a journey in infectious disease research. I'm a very visual presenter, so you're going to be seeing a lot of pictures, but then every picture has a story and it is trying to convey my presentation. So if you are going to be picking up some tips and some advice and some pointers or even some questions, just take note of how I'm presenting the slides and the pictures and what it actually means. Okay, so first things first. Okay, my slide is not moving. Is it moving on your side?
No, it's not moving.
Not yet.
Okay. So I'll stop sharing for 1 minute and then I share again. Yes, share screen. Okay. So yes, this is the beginning and this is me. You'll be wondering why I'm showing this picture. So this is a picture of me, my siblings, my mother, my paternal grandmother, and the mother of my paternal grandmother. So we say great-grandmother, right? And then also my maternal grandmother. Then this is also me. So I don't know if you can pick me out here, but I'll help you. So this is me, right? And so the first picture, this is me in Marondera with my family. And then the second picture is actually me at Maris Brothers Dete, where I was doing my secondary school. So we'd gone for a field trip and we got lost somewhere in the forest. If you know about Maris Dete, previously it was a very open school. So there were no fences. So and we were right in the middle of the national park. So we went for a field trip in the national park and then we got lost. we started singing with students, and then we took some photos, of course, but then, yeah, so that was me. So when I was looking up some information for this presentation, I just Googled my name. I don't know how many of you actually do that, but I do that a lot because I've forgotten what I've done and where I've come from. But I Googled my name, and then as you can see, one of the first things that came up was Brunette, a profile on LinkedIn. It's an old profile, Brunette Katsande, as the Vice President of Cake Biological Society. And it's actually quite interesting because I wanted to see how old Cake Biological Society was. And I found archives from the Tree Society of Zimbabwe, which states that they had a field trip, and they wrote a document in May 1986, and they were accompanied by students from the Cake Society from the Department of Biological Sciences at UZ. So I was actually a very active member of Cake Biological Society, and this is where my passion for science started, where it's like an advocacy group, but mostly based on nature and biological things. And we used to do a lot of field trips, and here you can see me with my friends and colleagues. When I was very young, of course, it's easy to pick me out here. I'm the only girl, but you know, we live in a very advanced world. Things might change. So yes, this is me. Yes, and I think here it was the first year as a Cake Biological Society member, and I was the treasurer, if I'm not mistaken. So we had been called to Mkovisi Woodlands because they were having a problem in the pond of algal bloom, and they really wanted to know what the issue was. So Cake Biological Society from the UZ who played a very important role in the monitoring of water bodies in Harare mostly, and then would collect water samples and then take them back to the University of Zimbabwe for screening. And we used to get a lot of help and advice from Professor Nwatiwa as part of Zetara, if I'm not mistaken, as well as Professor Basson, who used to help us in these field trips and in relaying the data back to the community. So we really helped a lot of people, and I hope this society is still running, right? But I'll start. So the first start which I got into my infectious disease research was in parasitology. So I don't know if any of you know this guy, but I'll tell you, I wrote about it online sometimes, and I'll tell you a very short story about it. So it was, we were in our first year, we were sitting in class, I think it was zoology, and we had been told by the secretary, the professor who was taking me for zoology he was a doctor then, was Dr. Maxwell Basson. So, you know, we were so happy, like, oh my God, we're going to get a white person teaching us zoology and everything like that. So we're sitting in class making noise. And then this guy shows up at the door and then he says like, what are you students waiting for? Are you waiting for anyone? And then confidently, I'm actually the one who replied, because, you know, I'm like that person. I was sitting in front. So I confidently replied, yes, we're waiting for Dr. Maxwell. But and then he goes like, so we are all surprised and shocked, of course. But anyway, Dr. Maxwell Basson then, and is now a professor, is a fish parasitologist and is also generally a parasitologist. So he introduced me to the world of parasitology. And then he was also my mentor for my undergrad dissertation where I looked at liver fluke, right? So liver fluke, the scientific name fasciolasis. But then liver fluke is something that is very common, that if you talk to people who actually, even in the rural areas or at abattoirs, who were in charge of killing cows or sheep, they'll actually look for this fluke because it is a disease that parasitizes the liver, and it can also be transferred to humans and cause disease in humans, but you can get treatment for it. But however, in your animals of agricultural importance, it causes a lot of money loss or economic loss because it causes animal wasting. As you can see on the bottom left corner, you can see the cow is wasted, it has lost weight. So I did my undergrad research at Kuala Park Abattoir, and I was collecting data. I was right inside the abattoir when we were dissecting the cow. The cow is killed outside, it gets inside, we're opening it, I would get the liver, then I would dissect the liver and then look for liver flukes. So this is a liver that you can see that is highly infested, right? So the liver flukes, they stay in the bile ducts of the liver, right? And they cause cysts, they block the liver, and then the animal actually suffers. So this drawing is quite interesting because it shows you the basic morphology of a fluke, but the reason why I'm showing you this drawing is because I'm the one who drew it. While working on the microscope. I think I was a very good student and motivated student back then, yeah, because my professor would say, Brunette, you need to draw the fluke from scratch. And then I would go like, is it somewhere? Then it goes like, no, you need to sit on a microscope. So I sit on the microscope. Right. But then the interesting data that we got from this research was that we're looking at carcass weight, right, first, and you'd see that there's some, so koala park, the way it operated then, I don't know if it operates like this now, is that there were animals which were pen-fed at koala park. So we'd call these animals the koala animals. But then we also had other farmers coming from different parts of the country coming with their own animals to be killed at koala, and either they would sell the meat to koala or they would go away with the meat. But we'll still actually record the data and say where this cow is coming from, right? And then we'd check all that data. So we would then segregate, put the data according to source of origin, and you can see here that animals which are coming from Zarabani actually had less weight compared to all the other animals, right? Okay. Sorry, my PowerPoint has stopped working again. I don't know why. Okay, so there was less carcass weight from these animals from Zarabani, and the same animals actually also had less liver weight. And you can see that if you look at animals from koala, they had a high carcass weight and they had a very good liver weight. And unfortunately, the same animals from Zarabani were actually found to have a high infestation of liver flukes, right? So you can see from this data that a high infestation of liver flukes was going to affect the liver weight. So it's going to have less weight and then it is going to have less carcass weight. So this is very important to note because when we're inside, there were always arguments with farmers outside, like koala is trying to undercut us, they're trying to charge less for our cow because the meat was also going to be graded afterward. Right. The moment we see liver flukes in the liver, we're going to grade it, like it is going to get a very poor grade because they already know that the meat quality is also bad. But then the farmers not understand, like my cow is healthy, why are you, or it looks good, why are you giving me a low grade and why are you giving me less money? But then these are some of the things that are actually driving the decision making in koala, right? Behind the scenes, what the farmers were not seeing. Behind the scenes, the parasitologists were actually contributing to the information into how koala was going to be paying out the farmers that were coming with their cows. So this was actually a quite interesting dissertation for me and fieldwork under the guidance of Professor Basson. And then it also culminated in my undergrad dissertation, which Professor Basson said to me, Brunette, I could have given you a distinction, but I did not give you a distinction because it's spelled honors without a U. We're a British colony. Your honors should have a U. Which I don't think is true anyway, but it was okay. Yeah. So Professor Basson was my mentor and is still my mentor. And him and other colleagues, including Professor Nwatu and Professor Dalu, had been recipients of the Valerius program from Belgium. So Professor Basson advised me to apply for the Valer program in Belgium, which actually offers ICP Connect Masters. It's currently open for anyone who's interested in getting a master's. It provides for you a full scholarship. It provides for you a full return ticket, right? So it pays for your airfare. It also pays for your visa processing. It's only that just now you need to go to South Africa to do the processing. Previously, you didn't need to go to, but that's only the major expense that you get, which I think anyone can sacrifice for if you want. It takes many people from different parts of Africa. So if you want, please apply for the scholarships open until the 1st of February. So I applied for this scholarship during the final year of my undergrad. And then, of course, I totally forgot about it. I graduated. Yes, so this is the picture of me and my husband. And then we got married and then we had a baby. And then during that first year, you know, with a baby, the message comes in, congratulations, Punet, you've been chosen for a scholarship, right? And we had to make a serious decision, my husband and I, and then we agreed that, okay, I'm going for the master's. But then unfortunately, I had to leave a baby. As you can see here, this is I'm at the airport of Zimbabwe. This is the first time I'm at the airport of Zimbabwe, and I'm going to Brussels, but then I'm leaving my 10-month-old baby. So this is also something that we need to think of when I was saying that I'm going to present on mental health and how some decisions that we make in academia or as scientists, they actually impact your mental health, even if you feel like you're going ahead, but you're also going behind in some aspects. So this is my family coming to send me off at the airport of Zimbabwe. And then it was a new beginning and a journey of first. So this is my first time landing in Europe. So I took this picture while I was coming off from Ethiopian Airways and reserving them because I needed to show people back home. You know, people back home had never had anyone going to Europe. So I needed to show them evidence that I've arrived and I was safe. So this was the first picture I took. I think this is about 12 years back. Yes. And then, of course, we went sightseeing with my friends. And then this is my first time seeing snow, which is quite interesting. So do not laugh at people when they put it on social media that there's snow here, yes. If it's your first time, yes, you're going to definitely post the picture, right? And then this was my first time on a fishing boat, right? The very big fishing boat on the North Ocean. It was part of our course. Because I was doing my master's in biology, which is human ecology, and I was doing different aspects from different fields. But then for my master's thesis, I had to make a decision on which field I wanted to specialize in. And because for my undergrad, I had done parasitology, I decided to do something that is quite similar, right? But then this was the shocker that I came across. I wanted to do parasitology. I went to the department involved with this, and they told me, Brunette, this is not Africa, right? This is not Africa, so please don't take this in the wrong way. I know that in Africa we do a lot of good research, but then they just do different research. So this is not Africa to me. They told me, Brunette, here we don't do prevalence and incidence research. We look at the immunology, right? So yes, you've got the experience, but your experience does not matter here. Here you're coming to learn again from zero, right? So that's when I got immersed into the field of immunology, and then I learned a very new technique known as flow cytometry. So in flow cytometry, you take your immune cells, which you can see here as cells. They're in single form. You put them in a tube, and then using hydrostatic pressure, they're poured into the machine. And then these cells are actually tagged with different fluorophores. For example, when you say you've got a low CD4 count, what do you mean for the low CD4 count? We mean that your cell, your immune cell, has got markers or receptors on it on the outside that are CD4 positive, CD8 positive, that are TCRs, that are this, and that. So we add antibodies, right, or just colors, which are in different color ranges, right? You put it in different color ranges and then you put it in the machine. The machine is going to put light through your cells. And then the light is going to be scattered depending on the color that is being shed on that cell. And then you collect your data in this form. So your data is going to show you the size of the cell that passed, where it sits, and then whether they're single cells, and then the markers. So we collect the colors, which are then translated back into markers. So the color red was for CD4. So you've got how many CD4 positive cells. So this was the interesting technique that I really learned from my master's. It was just a one-year master thesis, but it was interesting. Then which pivoted me into the field of immunology, which is quite a complex field, but it's quite interesting. So for my master's, I looked at the impact of Trypanosoma brucei on the development of collagen-induced arthritis. So some of you may not know what trypanosoma is, but trypanosoma is the causative agent for sleeping sickness, which is spread by tsetse flies. I think someone mentioned tsetse flies previously. So tsetse flies, they actually carry this parasite known as trypanosoma, which is found in most African countries and along the Rift Valley. And then so it causes sleeping sickness, and then it also causes trypanosomiasis in animals. But then we wanted to see if there's an impact of this disease on an autoimmune condition known as collagen-induced arthritis. So as an experimental scientist, of course, I used animal models. I used mice. And then you could actually see that when a mouse has got trypanosomiasis first, and then you try to induce the autoimmune condition of arthritis, that mouse is not really going to get arthritis. This is the taking that you should get. It is not really going to get arthritis. It's not going to get a lot of antibodies towards arthritis. So it will appear like it's normal. So what does this mean? This actually is a way that scientists are trying to understand why previously in the less developed Africa, we didn't have a lot of autoimmune conditions, right? And then they're saying, oh, it's mostly because there are infectious conditions like trypanosoma that are causing a suppressive pressure on autoimmune conditions in Africa. So this is the basis of our research. And then, so this is my master's supervisor, Carl Detre, whom I recently met 1 week ago, and then you published this in PLOS ONE in 2015 for anyone who's interested in reading on that. So this was the end of my master's, and then I could have done a PhD because I was, I'm not bragging this, but I could have done a PhD because I was the best academic student of the year. But then academia being academia, there are many issues. So I went back home to Zimbabwe. And then my daughter had grown a little bit. And then I was also now at Chinhoyi University of Technology. I do not have a slide on Chinhoyi University of Technology. I think I didn't record that part. I don't have photos from there, but then I actually did great things. I actually have one of my students from Chinhoyi University of Technology as being a participant here. Is now based in Ireland, and I no longer call him my student because he's now a colleague. He's now also a postdoc. So now postdoc to postdoc. And I've got another student also in America who is also now a colleague. And you might be wondering, oh, but it's only 2 students. Oh yes, I'm very proud of these students because at CASH then when we're teaching, the work class consisted of 4 students. So 2 students out of 4 is 50%, which is good. I'm mentioning this because when I went to Brussels, they only knew of University of Zimbabwe, right? They didn't take note of other universities. So I'm also saying, us as scientists, wherever we are, we must not discriminate students depending on which university they're coming from in Zimbabwe, right? Any university can give you very good students. Don't only say I only need students from University of Zimbabwe. No, you can get good students from any part of Zimbabwe. So I finished 1 year at Chinhoyi University of Technology. Then I went to UCT for my PhD, where I was in the Faculty of Health Sciences. And then I did my degree in the Department of Pathology, the Division of Immunology. And for my PhD, I was looking at the impact of Helicmosommoides polygyrus infection on the development of colitis, which is quite similar to what I did for my master's. So what is this? This is a parasite. So Helicmosommoides polygyrus is a worm, or it's a helminth. It's a worm that is a model for pinworms, which most babies have, most kids have. Even in Zimbabwe, you've got pinworms. When we say most usually it's pinworms. Most babies get pinworm infection when they're young. So this is like one of the first worm infections that you get. So we're trying to see if a prior worm infection, which most of us get when we're young, can impact an autoimmune condition that comes on later on, or an inflammatory condition. And in this instance, we looked at colitis. Colitis, in simple terms, is inflammation of the colon, right? There are two kinds of colitis that we usually consider in medical terms. We've got ulcerative colitis, or we've got Crohn's disease, right? And usually these are the drivers of colorectal cancer, but then we're looking at the earlier stages of colitis. So what we noticed is that with colitis, a prior helminth infection actually exacerbates or drives or makes the colitis worse. What we're saying is that if you've got a helminth infection, then you start getting colon inflammation. That prior helminth infection that you had is going to make your colon inflammation very bad, right? So what is the interesting technology that I learned during my PhD? During my PhD, I was introduced to microscopy, right? You notice that the first picture on my cover slide was a histology picture, right, which I actually took during my PhD. So I was introduced to microscopy, area scan microscopy, confocal microscope, which allows you to take very nice images. So this image is a confocal image of the cross-section of a mouse colon, where you can actually see the different crypts. And what you see in green is beta-catenin. These are proteins that you find on the end of a cell-to-cell junction, right? And then you also have got in blue, that is a DAPI staining, which you get for the cell nucleus. So every blue is showing you that this is a cell nucleus. So that is a cell that is surrounding the blue. So it's quite interesting technology that I learned, and it was quite labor intensive because you can sit there for 1 hour to take a picture of one slide because it goes pixel by pixel, and it is in a very dark cold room, and you can spend the whole day there just taking pictures of 10 slides. But it is quite rewarding in the end. So the main findings of my PhD research is that worms will drive colitis. Worms will drive colon inflammation. What you see here, H&E staining, it stands for inflammatory cells. And then PAS staining, it stands for your goblet cells that produce mucus. Your intestinal organ or your gut has got a mucus layer that protects your cells from inflammation, right? So when we say naive, we say our mouse was not infected, right? It had nothing at all. So this is a healthy mouse. But when you give a chemical known as DSS, which induces colitis, you start seeing an influx of inflammatory cells, right? And then you start seeing the depletion of all mucin-producing cells, which means that your stomach is no longer in a healthy state, right? And then if you give a helminth infection 7 days before, 28 days before, if you give a worm infection, that colon is destroyed, right? It's under super inflammation. We cannot help you anymore. You are under constant inflammation. The best way is to take an anti-helminth or to treat the colitis. But if you don't actually know what is causing it, you'll be always under constant colon inflammation. So we try to see if we can prevent this colitis, or we can prevent colon inflammation. And we give these mice probiotics during the worm infection. And we actually notice that if you take probiotics, right, which is the last picture here, you do not have a lot of inflammatory cells, unlike HPDSS. HPDSS plus V, that is the probiotic mouse, has got less colon inflammation and it has got better mucus producing cells, which means that your colitis and your worm infection are all derived from a dysbiotic state. Your microbiota is the one that is being affected when you've got a helminth infection and then you've got colon inflammation. But if we balance your microbiota, it is going to provide some protection against colon inflammation. So academia, nightmares being academia, you see, when I started my PhD, I had a promised fully funded PhD. So at the moment it was 60% funded. And I was told, oh, no, you know, when you get here, we're going to get more funding when the moment you get here, and then you'll be fully funded. Unfortunately, this did not happen. So my funds ran out before I could actually finish my PhD. So they say, don't panic, yes, but I panicked. You know, when your funds run out and you don't have anything else to get back on, and I was in South Africa, and which is not home, of course. Home was Zimbabwe. My family was back home in Zimbabwe. And I was in Cape Town, which is a very expensive city. I did not have rental money. I did not have food money. And I wasn't getting any more funding. It was also the time when we had a new VC at UCT who was very pro-South African and anti, I will not say anti, but not pro-immigrant students. So even if there was funding for PhD students, the funding was not being directed to anyone who had an immigrant status. And also, unfortunately, helminth research is not very well funded internationally. It really needs a local funding, and we can discuss this later on. So I panicked. I got a Malaysia to take me back home. And this was also one of the most traumatic experiences of my life, because with the Malaysia, he actually stole almost everything of mine. So, but I was so stressed, I was focusing on my PhD. Then I got home. So I actually finished writing my PhD from home, and I did not have a screen monitor. So what I ended up doing was that I ended up converting the house TV into my screen monitor, and I would write. But then this was also challenging because in Zimbabwe we had internet issues, we had electricity issues, and fortunately I bought a solar backup system so I could work during the day on using the solar electricity, but then I did not have internet access. For me to get publications or literature, I would actually have to wake up in the middle of the night when the internet was performing quite better, then download papers on my phone, then I'll transfer them to my laptop during the day, and then I'll read the papers during the day and write during the day, and then in the evening, I'm doing literature reviews on phone. So I managed to finish my PhD from Zimbabwe, right? And then these were the major findings. So to simply summarize, you start from the extreme left. Your intestinal gut, if you've got an intestinal gut helminth infection, right, it is going to affect your intestinal gut immune system and then prime it towards a Th2 immune system. And then so when you get something that causes colon inflammation, it can be a genetic predisposition, or maybe you're taking in food that causes colon inflammation consistently, right? they're going to affect your gut microbiota and make it dysbiotic, which is going to affect as well your immune response in the gut. And then your immune response is going to be inflammatory. However, if you get probiotics during this inflamed state, you're going to actually rescue your immune response and have less inflammation. These were the major findings, and then we can summarize this in a review. And the manuscript is still to come. Yes, this is one of the academic challenges. That's why I'm saying it's still to come. We can discuss it later on why it's still to come, and it's not yet here, but it's still to come. So I finished my PhD in 2020. We didn't graduate. We are the ones who didn't graduate because of COVID. And then I had gotten an offer to come to Belgium for my postdoc, and then we applied. We went to apply for our visas because we're coming as a family. And then this is when I really took a big knock, right? This is when I really took a big knock because, you know, it's expensive to apply for the whole family for visas. And then we actually had to sell our car, and we had to liquidate a number of things. And then you got a big no. You got a big no because even if the university had offered me a postdoctoral position, they rescinded it because all the borders were being closed to everyone coming from, mostly from Africa. I think you remember this quite well. So we had paid monies, everything was ready, and then you got a big no. You got a big no, but we had liquidated everything to pay for this process. So we came back to zero, right? And then it was a challenging period. I even went with my son. I had a son now, a toddler, to Gurube. From Dindo, some of you are from Gurube, from Dindo there. And it was just a time where nothing was working, honestly, and my mental health was taking a knock. So I decided to go back to the basics, you know, just to regroup and redirect. But then sometimes when you get a no, it's not like it's a eventual no, but just a redirection. I was so happy afterwards for this period because it allowed me to de-stress from my PhD experience and go back to my best level before I continued with my postdoc, because you all know a postdoc is much crazier than a PhD. So I really needed that boost. So however, because of the challenging things that were happening in Zimbabwe, I didn't have a job. I finished my PhD. I didn't have a job. There was no job for me. And my husband was working at the University of Zimbabwe. But I'll not say much, but you all know what that means. So we had to seek another source of income. So I'm very proud to say that I started a side hustle. And I know that there's this discussion of whether academics should have side hustles and what kind of side hustles they should have to show that you're a doctor. You know, yes, I'm a doctor, but I started a side hustle. So I opened a soft toy shop. So if you're from Zimbabwe and if your partner or your kid once came back with a plush toy, just know that there's a 30% chance that I was your supplier, because there were actually 3 main suppliers in Harare at that time, and I was one of the strongest suppliers. We actually helped other people to start their shops, but I started a soft toy shop, and it seemed funny. People were laughing at me, like doctor is selling dolls. Yeah, but the truth of the matter is that I was getting around 1,000 USD profit per 2 weeks from soft toys. People did not know this, but the money was good and it could provide security for my family, and I had to do what I had to do. As long as it wasn't illegal, it was very legal. So what I'm trying to say is I've noticed that even when you go on LinkedIn, when you go on other platforms where you come across postdocs or academics from America, they actually have side hustles, right? They've got different side hustles. Some rush novels, some do this. But however, in the Zimbabwean context, I see like it's an embarrassing feature that if a doctor or a professor has got a side hustle, they go like, but prof, with all your education, you're doing a side hustle. Why are you doing a side hustle? A side hustle does not have an educational limit, right? The most important thing at the end of the day is that you have to be able to provide for yourself and for your family. So eventually, after the end of the COVID pandemic, we got our papers to come to Liège. And then I came to Liège to this same postdoc that I'd been offered before, which was affected by COVID. But it was yet another new beginning, right? So we came as a family, and then I started working on something quite interesting. And then so for my postdoc, for my first postdoc, I looked at how a prior, it's almost similar to what I've been doing previously. So how a prior helminth infection will protect against pneumonia. So in this instance, we're looking at RSV, respiratory syncytial virus, which is a very important viral infection of babies and immune-compromised people. So most babies under the age of 2, they get RSV a lot, which presents like a cold or a flu, but it is actually it has got a high mortality rate if not well managed, because there's really no treatment for it, right? But then it causes a lower respiratory tract infection, which can result in death. So we're trying to see how a prior helminth infection with the lung stage, which is almost similar to a hookworm. So when you get a hookworm infection, it goes under your skin, then it goes into the system, then it goes into your lungs, and then so it pierces the lungs, then it gets into the lungs for about 2 days, and then you cough it up. You see, so sometimes when they're trying to diagnose helminth infections, they ask you if you're coughing at night, because usually you cough it up during the night, right? You cough it up during the night, and then it goes into the stomach where they mate, they produce eggs, and then they're released. So the basis of this research was founded on why Africa was not suffering from COVID. You see, COVID was everywhere, but Africa did not have very high numbers of mortality. This can be either we were not collecting data efficiently, but then it can be maybe there was an immune pressure that was preventing COVID mortality in Africa. So this was the foundation of my research of whether a helminth infection, which is endemic in Africa, can actually provide immune pressure on a lung infection like COVID or flu or RSV. So one of the interesting things that I got from this research is what we know as in vivo imaging. So you might be wondering why there's this picture. So you see in this picture, you've got a firefly, right? So this technique, which is used actually by many researchers, which can be used both in animals and in plants, is that they took a gene from the firefly, which enables it to produce light. And then you can incorporate it into viruses, into bacteria, or into plants, right? Then so when you incorporate this gene, it is a luciferase gene that you incorporate, which is an enzyme, right? So this luciferase enzyme, in my case, was incorporated into the virus. As the virus replicates, the luciferase gene is replicated, which produces the enzyme, right? So for you to test if the virus is still there, you give the virus exposure to luciferin, which is the substrate for the enzyme. The enzyme is going to break down the luciferin and produce light, right? So this is the system that you actually use for your in vivo imaging. And then here you can see in my mice, these are actually my mice. We've got mice on the left in the red space that are not showing any bioluminescence in the lung, because this is the area where there's the lung in the mouse. But then on the right, you can still see a signature there. Also in the nasal system, right? You can still see signatures where the virus is. So this is how the technology works, and we're actually able to be tracking the virus throughout the whole infection, whether the virus is still there or the virus is not there. So actually on the left, these are helminth infected mice. They quickly remove the virus from the system. But on the right, these mice are not exposed to the worm. They fail to remove the virus and they die. After 7 days of infection with pneumonia, they're dead. The ones that are exposed to the helminth or the worm, they don't die. So sometimes there's a benefit in being African, right? So this publication is actually in, it's almost there. It's not like a final draft, ready to go to the bioarchives. So I won't talk much about it, but this is me with my first postdoc supervisor. And then unfortunately as well, I had to leave his lab because we ran out of funds for the salary and not for the research. So I left the lab and then I went back to more new beginnings just across. Unfortunately for this time, it's just across the lab. Same department, same building, just across the lab, where I'm in the Department of Food Science, and we're working with industry giants and also with the government of our province to look at making probiotics, engineering probiotics for animal health. So there are many benefits of probiotics to animal health at different life stages. But what is interesting is that in our lab, we'll do the in vitro assessment where we use this very interesting machine. So this machine is an in vitro simulation for the gut entire system. You can program it to say, okay, I want this vat or this container to be like the stomach. It's not about small intestine, it's not ascending colon, this one the transverse, this one the descending colon, etc. And then you maintain it at all the conditions that are similar to how you have it in a human, right? And then you also create an anaerobic environment by connecting everything to nitrogen. And then to mimic the missing layers in the gut, we put what are known as missing coated microcosms, where when you add bacteria that like mucus, this bacteria is going to migrate and then going to attach itself to the mucus, and then you pull that out and then you analyze it. It is quite interesting. So it looks very nice on diagrammatically. Yeah, in person it looks like this. It's a nightmare. It's quite imposing, and it's something that you really need to train for a very long time to be able to understand which tube goes where and what does that. But it's quite interesting because you can do a lot of interesting things with it. So this is me in the lab running one of the experiments there. And this is me with my colleague actually going to take mucus from pig colons. So here we're at the main hospital. Our department is associated with the teaching hospital and the research hospital. So at the research hospital, they also have a site where they do like animal research, right, and animal training. So when I went to this day, they were doing surgery on a pig, and then the pig will be connected to everything, almost like a human, right? And then they took out the colon and then they'll sew it back up. So we took out the colon and then we're scraping the mucus, putting them into containers and then going to process it back into our lab for our assays. And the basic concept of my current project is that we're trying to create a fluorescent probiotic laptop plantarum, and then we're going to use CRISPR technology to edit to increase addition capability of that bacteria, and then we're going to test if our bacteria has got improved missing addition, and the readout will be in fluorescence. So I'm almost done, and this is the current lab I'm working at now in the left corner, and it's an all-girls team at the moment. So my current lab, which is 4 people at the moment, we do very diverse things. One person can do diverse things. Mostly we're focusing on using bacteriophages as the new antibiotics, right? And we're also looking at probiotics. So we're looking at plant extracts on the impact on the health immune system. Then we're also looking at food additives and their impact on colitis, on IBD, on IBS, and also generally on the immune system. So if you're interested and you've got anything or any collaboration that you want to talk to me about, just let me know. And then, so to round up, this is where you can find me. Some of you know me already. So this is now my current LinkedIn profile, Brunette Kasandegwaza, with the full name. And then you can also find me on Facebook. I have a Facebook page, The Memoir of a Zimbabwean Scientist, where I talk a lot about my experience, the ups and downs, and some of the tips, sometimes scholarship advice. But what you might not know is that my husband and we created a company. So we've got a company known as Bantu Science. So Bantu is bringing science to you. It's mostly for science communication, scholarship advice and tips, etc., and consultancy. It is not yet monetized at the moment because we've been doing this out of the goodwill, because in my life, I've gone to the next career, to the next stage of my career by being helped by others. So mostly we've just been helping students. I think my husband has helped more than 10 students come to Belgium on a scholarship for biostats. And I've helped other guys with their CVs and career guidance and some thesis reviews and edits. So just in case you're interested, you can find me on Twitter. Those who've been following me for some time might be asking, Brunette, why have you stopped giving us stories? You used to be so active online. And it's a very interesting discussion because in 2023, I took a very hard knock on my mental health. I was going through a lot. So I decided to cut down. It's allowed, we are scientists, we are paid to think, right? We are researchers. We are paid to use our mental faculties. So I now know the triggers, when you now see that, okay, you're going to a burnout, right? Sometimes burnout happens, but they cannot happen where I need to still go to work, right? So I could see that I was going in a burnout. So what I did is that I cut down on things that were not necessary for my day-to-day living. I started focusing on my work and on my family and on myself. I started going to the gym. I go to work. I come and take my kids. We go home. We cook. We read. We watch TV. Then we go and sleep. right? Doesn't mean that I'm no longer doing science. I'm no longer doing science communication. It just means that at that moment I was too overstretched, right? And my mental health was taking a knock. So I took what I needed to be doing for me to survive my day-to-day life. But now I'm slowly coming back to it because there are many things happening. In 2023, I was losing my job because I ran out of funding and I needed to find a new job. And my new job was linked to my permit. Without a job, I don't have a permit, then I'm being deported. So it's quite tricky. You know, this is the challenge of academia. There's no stability in academia. So we have to be open about this. We have to be open to discuss, you know, like what are you going through as a person? Even if we see academia as a job, your academia is also your life because it's affecting everything that happens in your life every day. So we should be open enough to talk about it, to discuss, and to help each other. You know, the way I got my current job is because I talked to someone over lunch. Like, my job is coming to an end. Then she goes like, Brunette, your job is coming to an end. Are you looking for a job? Then I said, yes. Then she went like, my boss is looking for a postdoc. I said, are you serious? Within 1 week, I had a job, right? But then I was left with 3 weeks to the termination of my permit. But I got a job within 1 week because I networked. So networking is very important. This is one of the lessons that I wanted to show you here that, yes, I'm showing you professors, right? But then these professors are not also my colleagues. I also have students that have gone to different places because we networked. Even coming here to present is because of networking. This current job I got it through networking. So do not be afraid of networking. Do not be afraid of being vulnerable, right? You can say the truth. Yes, I'm looking for a job. It's not embarrassing. Yes, you have a side hustle, yes, because your finances are not meeting. Can we help you with your side hustle, right? Can we buy from you, right? Can we support you, right? Which is very important, I think. So this is because if you don't do this, you're going to crash. You're going to burn out because you think that I have to present myself as a very educated person. But as an educated person, you're still part of humanity, right? You still have all the pressures that come to even the uneducated people. The same thing that affects them is affecting you, right? It doesn't segregate that you for a PhD or you don't have a PhD. So this is why I formed actually this Bantu group, because we like to talk and present information to help people. If you're in a tight spot, you don't know where you want to go, you can come and talk to us. You can talk to anyone from ZRN. And to conclude, talking about networks, everyone from this slide is from different countries, right? We're not all from the same country. Like one is from Kenya, Spain, Belgium, China, India, Greece. So it's the value of networking, because wherever they go, they will know about me. Wherever I am, I'll know about them. If a spot comes up, I'd call them, you know what, there's a spot, are you still looking for a job? Network is important. Thank you so much. And I'm open to questions.
Thank you.
Thank
Thank you so much, Brunette. This kind of ties down everything that we have been talking about today. We have started off by looking at the health out there, right? Us as researchers conducting the research out there. But now, what about the health of us, the researchers who are doing the research on health? So thank you so much for that. You've also brought an important dimension of seeking out opportunities that we need to be. Well, if you want to be a researcher, you need to be actively involved in seeking out opportunities. And at the same time, your health should remain a priority. I'll hand over to Tinaye, who's going to introduce to our next speaker. I hope you are not leaving, Dr. Brunette. We still want you for the next question and answer session. I'll let you know when you are ready for the next question and answer session. So yeah, Tinaye, go ahead and introduce Dr.
Thank you, Prof. And thank you, Dr. Brunette. Your session was quite an eye-opener, even for me. I'm now motivated to keep pushing forward. So without further ado, I just want to welcome, if you've just joined us, a warm welcome to you. We've had a very, very engaging and interactive session the whole day. And now I would like to take this opportunity to introduce Dr. Panankosi Moyo. Sorry, about that. He's going to take us through nurturing power of nature, bioprospecting of plant-derived natural products for antimicrobial drug development. Yeah, I need help with the pronunciations because it's not my field. But Dr. Pananko Simoyo is a postdoctoral researcher at the University of Pretoria. He was a lecturer at Great Zimbabwe University, and he holds a PhD in biochemistry attained at the University of Pretoria, a master's degree in biotechnology from the University of Witwatersrand, and he was previously a visiting fellow at the Department of Chemistry at Oxford University as part of the Africa Oxford University Visiting Fellowship Program, that's AFOX VFP. He has more than 20 scientific publications, including in Nature Communications. Dr. Moyo, welcome. You have the floor.
Thank you very much for the introduction, and thank you very much for the invitation to allow us and my colleagues to present some of the work that we're doing. I'm just going to switch off my camera just for the sake of internet. Can you see my screen?
Yes, we can see it.
Okay. So thanks once again to the organizers for the invitation. As already indicated, my name is Panankos Moyo. I'm actually a postdoctoral fellow in the lab of Prof. Maharaj in the Department of Chemistry at the University of Pretoria. I'm just going to see if I can find in the lab of Prof. Maharaj at the University of Pretoria. So my work is basically driven on the discovery of novel drugs from natural products. I think most of us attending here, being Zimbabweans or Africans, the use of either plants or some other traditional medicines is not a new aspect to us. It's not only something that is also confined to Africa as well. We have seen, for example, if you are familiar with malaria, the discovery of very helpful drugs from malaria, such as artemisinin and quinine from plant-derived natural products. So the inspiration for our work is to try and discover novel compounds specifically for a number of diseases. But for my presentation today, I'll focus on two aspects. The first part of my talk will be based on the discovery of tuberculosis drugs from natural products. And then the second aspect will be based on the discovery of quorum sensing inhibition agents also from natural products. So TB as Africans is not an aspect or a topic that really needs much introduction, but nonetheless, I'm just going to give you some stats on the subject from a WHO report, which was published in 2020 for the 2021 year. The report was published in 2022. So with a global population of about 7.5 billion people, almost half of the 7.5 billion is actually infected with TB. That is to say, most people actually have what is referred to as latent TB, meaning that you will have TB, but not being aware of the fact that you're actually infected, primarily because your immune system is able to reduce it such that you do not get the clinical manifestations of the disease tuberculosis. So with 2.5 million people infected with TB, every year, 10.4 million cases are actually recorded. And with 10.4 million cases being reported every year, unfortunately, 1.4 million people are actually lost to tuberculosis, which is quite a big number. And unfortunately, 50% of the 30 high burden, as defined by the WHO, 50% of the 30 high burden TB countries were from Africa in 2021. And as much as this is 2021, I can tell you that the 2022 data is almost similar. So I'm not really giving you some kind of outdated information. The current situation pretty much reflects what happened in 2021. And most importantly, if you then look at the top 5 countries affected by TB, 4 of them are actually African countries. That includes South Africa, where I'm currently based. And these have the highest incidence rates of tuberculosis. Now, already you've got a high challenge of high burden of TB. Unfortunately, there is this challenge of antimicrobial resistance, which I think needs not much introduction to most people who are attending this meeting today. But nonetheless, just to give you some figures relevant to TB, you will appreciate that the TB causing bacterium, which is Mycobacterium tuberculosis, has acquired resistance against drugs that are used to treat this infection. So the resistance actually leads to what is referred to as multi-drug resistance, or MDR, as well as excessively drug resistance TB. Just to explain it in simple words, when you've got multi-drug resistant TB, what it simply means is that this bacteria is actually now resistant to 2 of the first-line drugs that are used to treat TB. There are actually 4 first-line drugs. So you do have cases where people have got multi-drug resistance TB, wherein the bacteria is resistant to 2 of those 4. And then on the other hand, you've got what is then referred to as extensively drug resistance TB. This is basically MDR. And then in addition to having resistance against those 2 first-line drugs, the bacteria also has resistance to another second-line treatment drug. So this is what is referred to as extensively drug resistance TB. And then in 2021, there were actually 450 cases which were caused by drug resistance TB, of which in actual fact, this is actually 1 in 3 AMR cases associated with fatalities that is caused by drug resistance TB. So you've got AMR cuts across different bacteria, but then the fatalities that are associated with AMR, 1 in every 3 or 1 of them is actually caused by drug resistance TB. So this, in simplest terms, tells you how extensive a problem drug resistance is already within the field of tuberculosis. And then approximately 3 out of 5 people, or 3 out of 5 cases of drug resistance TB around the world actually go untreated. And then for those who do take therapy for drug resistance TB, this therapy actually ranges for 6 to 30 months, which is quite an extensive, extended period of time for anyone to be on drugs. And within that period, a single individual can actually consume 14,000 pills for the treatment of multi-drug resistance TB. You can imagine how taxing this is already. And because it's so many pills, chances are that individual is going to falter in taking all those pills, which not only leads to failure of the treatment, but also to resistance further developing against these drugs. And then for an individual who also has got drug resistance TB, every day for 6 months, you need to take 1 injection. And then the cost on its own is quite exorbitant. For example, for someone who is being treated having drug-sensitive tuberculosis, per patient, it costs about $257. But then for an individual who has got multi-drug resistance TB, it costs about $6,000. And then for an individual who has got multi-drug resistance TB, this costs about $26,000, which is quite a lot of money. So, and unfortunately, having taken the tablets for so long and taken so many of them and taken so many injections, the treatment outcome for multi-drug resistance TB is actually only 56%, which is quite low. So unfortunately, in as much as we might think we do have the necessary treatment, the indicators are that we do need alternatives already. Hence, the most important take-home message from this slide is that we urgently need new antimicrobacterial agents for the treatment of tuberculosis. So now then the question arises that in trying to find these drugs, which sources do we opt for? Some people might opt for synthetic drugs, that is drugs that you can sit in the lab and create. But then from a tuberculosis perspective, what nature has shown is that it is quite a prolific source for drugs that are used for the treatment of tuberculosis. I already mentioned to you that there are 4 first-line treatment drugs for tuberculosis. It is quite important to highlight that 3 of these are actually natural product derived. So these 2 drugs were isolated from microorganisms. And then this pyrazine amide is actually a derivative of a vitamin. I can't specifically remember which vitamin it is, but it's actually a derivative of vitamin nicotinamide, which is produced by some plants. So already we are seeing that plants and microorganisms have, to some extent, influenced quite significantly the development of drugs for TB. And then if you look beyond the first-line treatment options and then go to the second-line treatment options, we do notice that a number of these are also natural product derived. In fact, the first drug that was used for the treatment of TB is streptomycin. This is an antibiotic which is produced by the bacteria Streptomyces. So the most important take home from this slide is that natural products are actually an inspired starting source in the search of novel antimicrobial compounds, which is the reason why for our study, we have opted to look for anti-tuberculosis drugs from medicinal plants. So I'm not really going to go into the technical details in terms of the experimental layout, but what I want to highlight to you is that in our lab, we have got a high throughput system that allows us to generate an extract as well as 7 of its fractions. So these can actually be dispersed into deep 96-well plates, which then accommodate for the high throughput screening. So in this case, for this study, we actually used 36 crude extracts. That is 3 plates. And then from these 36 crude extracts, we generated 252 fractions, which we then used for evaluation primarily against 2 model strains, namely M. smegmatis as well as M. aurum. So now smegmatis and aurum are mycobacterium bacteria, but these are non-pathogenic. They are not infectious. They will not cause the TB disease. But then fortunately, in terms of similarities, in terms of, for example, drug response, they are similar to Mycobacterium tuberculosis. The fortunate thing about these ones is that we can easily work with them in a lab which does not require BSL-3 facility. However, for Mycobacterium tuberculosis, because it's highly infectious, one will need a lab which has got a BSL-3 facility, and very, very few labs in Africa have this kind of facility. So we screened primarily against these 2 model strains, and then we identified the most active fraction, which we then prioritize for screening against the Mycobacterium tuberculosis. Having done the biological evaluation, we wanted to get an idea of what could be the active agents from the active plant species. And for that purpose, we used what is referred to as chemometric analysis. Basically, this is just the application of statistical analysis using chemistry data. And in this case, it's mass spectrometric acquired data. So from our primary screen, basically what we did was in the first, so just to explain this, I know this is a little bit busy, but what I can draw your attention to is that, so you've got the plant species, you've got the plant parts, and then you've got the different fractions 1 to 7. Firstly against M. smegmatis, and then also against M. aurum. So what you see as red, it simply tells you that that fraction was not active against M. smegmatis. And then what you see as green, it tells you that that fraction was active against M. smegmatis. So what was most relevant to us was this plant species. Sorry. I think I allowed someone in, and then can you see my slide again?
Yes, we can see.
Okay, yeah. Sorry, if someone please can admit other people, because it's coming to me, and when I click on that, my screen disappears. So of most relevant to us, as I was trying to say, was this plant species, Crinum asiaticum, whose bulb part specifically showed quite impressive activity against both M. smegmatis and M. aurum. This is noted by the very low MIC values, which you see for fractions 4, 5 in particular, and 6. And because fraction 5 emerged as the most active fraction, we then prioritize this for biological evaluation against the infectious Mycobacterium tuberculosis. These assays were actually done at the University of Cape Town at the H3D Center. So for their assays, they use 3 different media per each compound or per each extract or fraction. And what was most encouraging for us is that our fraction 5, showed activity specifically in this media with an encouraging MIC value of 32.6 micrograms per ml. And so now, having shown that this fraction is actually quite active against the infectious Mycobacterium tuberculosis bacteria, the next question which we sought to ask is what potentially could be the active compounds within that mixture of compounds within the fraction. And for that, as I previously highlighted, we used chemometric analysis. So we acquired our data in triplicate at using DIA mode at ASI positive function. And then this was then processed using marker links, following which we got a sheet that we then used for chemometric analysis using SIMCA. So what you will notice that we first performed unsupervised statistical analysis using PCA, we actually showed good separation based on polarity. So these on your right-hand side, what you have is mainly your polar fractions, and then what you have on the left is the moderately polar to low polar compounds. And then after having shown good separation based on the unsupervised PC analysis, we then, for better resolution, we then performed supervised multivariate analysis using OPLS-DA, which is what you see here. So now you're telling the program to say which fractions were actually active and which ones were inactive, because at the end of the day, you want it to find markers which differentiate or are unique to the active fractions and not found or in less concentrations in the non-active fractions. That is what you get from this analysis here. And then having shown good distinction of separation between the active and the inactive fractions, we then generated an S-plot. So with an S-plot, what you see here is that the compounds that you have on this lower left quadrant are actually the distinguishing features between the active as well as the inactive. So these compounds are the ones which we putatively say are potentially active responsible for the antimicrobial activity that we saw. And then this is further confirmed by this contribution plot, which shows that these compounds were actually positively associated with the activity or the activity that we were observing. And so now at this point, we only know these based on their masses, but then we want to get an idea of what exactly are these compounds. And for that, we do annotation, which we do manually, as seen on this table. And then the outcome from this annotation is that we do get the structures. So basically, these are the structures that we annotated and we believe are responsible for the antimicrobial activity that we observed in the biological data. So the nice thing about getting this preliminary data is that one can do in silico analysis, which then allows one to prioritize to say, of these that we have tentatively identified, which ones can we prioritize for either isolation or further biological evaluation. And for that specific purpose, we used a machine learning model, which was actually created by H3D, and a company called Escilia. It's a company based in Spain, but does a lot of work in developing AI models to support drug discovery in Africa. So now the most important thing which I have to highlight with this model is, just like with every other experiment, you definitely need to have controls. Why it's necessary is because most AI models in drug discovery are created using synthetic libraries or synthetic compounds, and those occupy different chemical space to natural products. So the downfall is that if you then use an AI model created using synthetic data at times for natural products, it might give you false data. So the first thing, before we actually used this model for our data, we first used some control compounds. These are compounds which are natural compounds and have been previously evaluated in good labs and shown to be either active or inactive. We then used the model to see how it predicts the activity of these compounds. And from what we saw is that generally it gave quite good predictions. And from this, we then used that model to identify to predict the activity of our compounds, and quite encouraging. Some of them really do show a high probability that they could be active against the TB bacteria. And from here, we have identified some compounds, and we have already submitted them for screening again at H3D. So to discuss and conclude our work, what I want to highlight is that structurally, we do already know that from literature that some of these structurally related compounds have been previously demonstrated to have antimicrobial activity against Mycobacterium tuberculosis, which gives us confidence that our approach has really worked and has led to the identification of potentially active antimicrobial compounds. And some of the compounds are additionally predicted by the machine learning model to have a high probability to inhibit M. tuberculosis growth. And we have since now procured 2 of the compounds which we have submitted for biological evaluation. And fortunately, metabolomics has proved to be a very valuable tool in this case in allowing us to identify the potential active compounds. And this has guided us to the prioritization of the compounds to be further evaluated. I've been advised that I've got only 4 or 3 minutes left. So unfortunately, for that reason, I'm not going to be able to take you through the quorum sensing work that we have done, because it's also quite a lot. But nonetheless, I'm always happy to discuss it at any other point with whoever might want to listen. So thank you very much again to the presenters. And most importantly, I wanted to give acknowledgements to my supervisor, our collaborators, Prof. Dankwa in Ghana, as well as Prof. Lindy Mago at the University of Pretoria. And thank you very much to, this is basically Prof. Maharaj's group, that's the Biodiscovery Center, my colleagues that I work with from time to time. So thanks to them again for the contribution that they have made in this work. I'll be glad to take any questions.
Thank you so much, Doc. I've been tasked to ask you questions, but be warned that I'm asking from a very, very layman's perspective. So my first question is basically, you were talking about, the cure drug development. Have you yet gotten or found a compound that is likely to help cure TB?
Yeah, that's at this point, I would want to say so specifically for my work, because as I did point out, the compounds that we have found are only being tested at this point. But nonetheless, based on the output from the machine learning models, there is a little bit of optimism that they might be active. But that being said, I must indicate that drug discovery is a very long process. At this point, we are only at hit identification. From hit identification, you move on to early leads, late leads, preclinical. So we are right at the beginning. So I want to say we have a little bit of optimism that we are getting something that might be active, but I don't want to say we definitely do have something now.
Okay. Thank you. I have one last question. Sorry, Prof. Edmund. So what are there any plans for protecting traditional knowledge as intellectual property?
Yes, it's quite, there is what used to be the Nagoya Protocol. I think it has since changed. I can't remember what it is, but overall, globally, there used to be the Nagoya, and it was presented by something else, which I can't remember. But generally, most African countries would also have their own laws, which are meant to safeguard the traditional knowledge of their citizens, such that it's not exploited by others. So definitely, there are such laws in place for safeguarding traditional knowledge.
Thank you so much, Doctor. Please stay on and interact there. I see there's some questions and comments in the chat. And as for everyone else in the room, if you have questions for any of our speakers, please direct them in the chat and they'll be interacting with you. Over to you, Prof. Edmund.
Thank you, Dr. Panankos Moyo, for the lovely talk, which kind of answered some of the comments that Dr. Margaret Selmaya had made initially regarding the use of traditional natural products, so to speak, in addressing health concerns in our communities. So thank you so much for that talk, and I hope we are going to continue hearing from you and more on the wonderful work that you are doing. And next, we are going to hear Professor Katrina Krenzer. Katrina Krenzer is a clinical associate professor in infectious diseases epidemiology at the London School of Hygiene and Tropical Medicine, and also an honorary clinical consultant microbiologist at the University College London Hospital. Professor Katrina is based in Zimbabwe, where she's leading a research program focused on infectious diseases, specifically tuberculosis, HIV, and antimicrobial resistance. She is supporting laboratory capacity building and is a mentor for the Fleming Fellows in Zimbabwe. Today, we are privileged to have Professor Krenzer with us. If you are available, just let me know, Prof. Krenzer. Yes, you are here. I'm going to make you a co-host so that you'll be able to share.
Thank you very much, and thank you for the invitation for speaking here. Just to say, I'm in Zimbabwe and my internet is sometimes a tiny bit wobbly, but that's the reason I'm going to switch off my camera. So, as you know, the person actually scheduled to give this talk was Rashida Farand, and I work very closely with Rashida Farand. I'm going to start sharing my screen. I hope that you can see my screen. And please interrupt me at any point in time, just to say, I think I was very happy to be able to listen to the talk about novel treatment for TB, because that's obviously one of my core interests, but also to the previous speaker, which I think was absolutely fantastic to hear about how to make use of your networks. And it's something I tell my students very frequently, and I hope I will manage to convince the prior speaker to come and speak at the Health Research Unit Zimbabwe. So I'm going to speak about our kind of capacity building, but before I do that, I will just speak a bit about the Health Research Unit Zimbabwe. So we are a unit within the Biomedical Research and Training Institute. And the Biomedical Research and Training Institute, while we have a memorandum of understanding with the University of Zimbabwe, is an independent research institution and really was kind of founded in the 1990s to promote the health and quality of life of the peoples of Africa through research and training in the field of biomedicine. So we are not just doing research, we are doing a lot of training, and specifically BRTI has previously done quite a lot of also laboratory training to train up microscopists, for example, but also a lot of training with regards to TB diagnostics. So the Health Research Unit Zimbabwe has really training and capacity building
is really our kind of core vision through high quality health research. So it means we have a lot of research projects, but we use them very much as a platform for capacity building. We are responsive to local and national and regional challenges. So we are very much embedded within the healthcare system in Zimbabwe. We do not have shiny kind of clinical trials units or anything. We usually recruit from polyclinics or public hospitals. And we have a focus on research culture and development of local research leadership. So very often, because of a considerable brain drain, there isn't that much attention given to actually mentorship and supervision. So often lecturers at public universities have a lot of students to take care of. And we are trying to kind of address that by really giving very dedicated mentorship. We have diverse funding sources, grant and donor fundings from the UK, the US, Europe, Africa, and Canada, but also from China, for example. And our research and also our capacity building is actually delivered by partnership in the South, between the South and the North, between academic, government, and UN agencies, and also NGOs. So we don't do all of that ourselves. The Through Zim principles include that we really want to invest in Zimbabwean early career researchers and actively oppose the brain drain. So that means we spend quite a lot of time to embed MSc projects within our research platforms, but also doctoral students and postdoctoral fellows, and often have a hybrid model where, for example, somebody is a coordinator of a study, but at the same time, that person is also doing a PhD. But in addition, apart from the early career researchers, we also try to support certification and professional development of non-academic staff. So we have quite a lot of interns. We also support diploma courses and degree courses. But saying that, it's not that we support that across the country. We support that for the people who are actually employed by us or who work or collaborate with us. And as I said, we have a dedicated focus on research culture and development of research leadership. The themes of research we do, I mean, I do a lot of TB research and also AMR research, but actually we have a big theme, which is sexual reproductive health research, which is very much led by Rashida Ferrand, who is an HIV clinician and has recently finished a big cluster randomized trial specifically on sexual reproductive health services. We do also research into multimorbidity. One of my colleagues from the University of Bristol is actually a geriatrician and is leading at the moment a big research program through an NIHR funding, which is about healthy aging. Because she's also an orthogeriatrician, so she does quite a lot of muscle and joint and bone health. We have a big focus on musculoskeletal health, but not just for older people. We recently completed the trial in adolescents and children living with HIV, supplementing them with vitamin D and calcium with a focus on musculoskeletal health, and have really trained up quite a lot of radiographers. 3 of them have done PhDs with us, both on echocardiography, but also on specifically musculoskeletal investigations. We do a lot of work on service integration and also screening, specifically TB screening, but also what we call kind of health checks. We do that across populations. We have a big focus on adolescent health that mainly comes from Rashida's work very early on as part of her PhD and working closely with adolescents. But given that we now have a geriatrician on board, we also have expanded our age range into older age. But we also have quite a big focus on neonatal sepsis, and therefore neonates are also part of the populations we are looking at. We have many, many disciplines. I myself, I'm a clinical microbiologist and an epidemiologist. We do trials, both individual randomized trials and randomized cluster randomized trials, do quite a lot of implementation science and process evaluation. We have a very active social science and anthropology group. Epidemiology and statistics obviously comes with the trials, but also with observational studies. Health economics is something which we do not have really a very strong team member here in Zimbabwe, but we collaborate quite a lot of that on that. And then we have laboratory sciences, but as most of you will know, it is tremendously difficult to keep high quality laboratories running in a setting where you have quite a lot of power outages, and it's also quite difficult to maintain staff. So our partners are many, and we don't just have partners overseas. We have many partners in Zimbabwe, but also many partners in the region. And these partners are not just academic partners, as you can see, but a lot of them are implementers, are service providers, are Ministry of Health, or are part of the provincial health provision teams. So we have quite a heterogeneity of partners, and equally have tried to really diversify our funding, mainly because, not mainly, I mean, it's obviously having a lot of different collaborators also comes with a lot of different funding. But as you all know, especially UK funding has very much dried up over the last couple of years, and it has become increasingly competitive to the degree that that applications have sometimes only a 1 or 2% chance to actually going through. So for that reason, we have really diversified our funding portfolio. So now I want to get on to capacity building. So capacity building is obviously not just training, and it's not just learning, but it also includes like on the job training. It includes support once you have taken somebody on as an MSc or as a PhD student, and involves also quite a lot of coaching and mentorship. Now, this is what I call our training pipeline, and I will kind of go through those in a bit more detail later on as well. So as I said, we have quite a lot of interns working with us. These are not just interns working with research projects, but we have interns in our administrative or with our administrative team. We have interns with our public engagement teams. To really make sure that we provide people with possibility in a very difficult job market to actually get some skills and training, which are not just skills and training from the university. In addition, we have run something which is called the Youth Researcher Academy, and we have done 2 of those Youth Researcher Academies in 2019 and 2021, where we actually took a group of 20 young people, some of them in school, some of them in year 1 or year 2 of university, and took them through residential, a 2-week residential training course in research, both quantitative and qualitative research. And then they were assigned to research projects, 2 or 3 of the youth researchers, and basically developed their own little project, conducted that project, analyzed the data, and presented that data then in front of national and international stakeholders after having gone through a 1-week presentation skills workshop. And the reason why we did that was because a lot of our studies actually include young people, and we developed youth advisory boards, a bit similar to community advisory boards. And actually, in order to make sure that people who sit on these boards can contribute in a meaningful way and are not just tokenistically included in the kind of research arena, they really need to know what study designs are, what questions are valid. And so we felt that some upskilling would be very beneficial. But in addition, a lot of these youth researchers have then actually continued to work with us and are now part of our staff members. We have quite a lot of research assistants. So these are people who are often coming straight from university and work for us and work across different projects, sometimes a longer time, sometimes shorter time. We then have MSc students. These are all distance learning MSc students. Some of them have just finished last year or the year before. So they are all distance learning students which are enrolled at the London School. But we do support also our staff members if they enroll in MSCs at UZ or Africa University or Midlands University, because we really want to make sure that people have the possibility of continuous development. And so we support them either with providing them with study leave or allowing them to take leave when they have blocks of school, and or support them also with their fees. Then we have a whole host of PhD students, and I will introduce them a bit later on, and then a couple of postdocs. And I just wanted to also add to the presentation which was given before. It's very difficult to maintain people in academia and to maintain people in postdoc positions. And generally, some of our postdocs actually manage to get their own funding, fellowship funding, but maintaining postdocs is kind of full-time equivalent on research projects makes the research projects at some point extremely expensive. So then you actually have to split postdocs the same way as PIs across different research projects, which is very demanding for them, especially if they come straight out of a PhD, but also is not that easy to make sure that that happens, because you might have somebody funded for 20% on a research project, and you don't know if the other 4 grants you have written are actually going to be successful to enable 100% employment. And of course, in academia, no matter where you are in academia, we are never as competitive as industry is, as some of the US-funded NGOs are. And so a lot of the people we train, which are mainly PhD students, essentially leave us a couple of months after they have completed their PhDs, because they get much better offers and much more certainty. So I think one has to be realistic that maintaining postdocs is something which we might just not be able to do. And if all it is that we are actually enabling higher degrees in internationally competitive universities, and the people are not leaving the countries and finding a competitive and finding good employment in the country, then I think that's good enough. And unless the academic landscape changes, and unless the academic funding changes, I do not think we can bank on producing lots and lots of postdocs. So I just want to say a couple of things about the systemic problems we are facing, and that is not specific to Zimbabwe. Some of it is not even specific to low-income settings. It is, but some of it is more kind of more pertinent in a country like Zimbabwe and the region. So we face a lack of well-trained and skilled researchers. And we face that because, as I said, it's difficult to maintain researchers once you have trained them to a very high standards. There are very limited progression pathways. And as I said, this is not specific to low-income countries. This is the same in high-income countries. There is a poor infrastructure, research infrastructure, as there is in general. The infrastructure is kind of not that well maintained, as well as there is a poor healthcare system. The research infrastructure obviously is in a similar state. The laboratories, similar to the public laboratories in a lot of universities, in LMICs, are not very well maintained. There is power problems, there is equipment problems. Even if you have good equipment, it's very difficult to actually maintain this equipment, to get it serviced regularly. And then there is what I would call suboptimal services, and suboptimal services is support services. Saying that, I have to say there's also suboptimal support services in a lot of UK institutions, or I also partly work in Germany, in German institutions. Often even at the professor level, at my level, you're your own administrator and you're doing most of the administration yourself. So when I say suboptimal services, there is not necessarily good, grant support in writing. So, a lot of grant writing is administratively. There is not a good service with regards to library. There is not a great service with regards to financial officers who can report if you were successful with the grant. So all of that leads essentially to inadequate training environments. And then together with the brain drain means that people who then you train at the PhD level, because there is opportunities elsewhere which are much better, you end up with even more inadequate training environments because you have less high-skilled researchers. So it's kind of a bit of a vicious circle, and we are certainly not going to be able to solve the systemic problems. The systemic problems need to be solved regionally and nationally, and as academia as a whole needs to solve how do we want to go about research. Is it important for us? How much national funding do we put towards us? And that includes higher education institutions. And as I said, that is pretty much the same in the UK as well, because even there, you often have core funding is extremely reduced, and therefore most universities with regards to research rely on grant funding. Now, if I'm looking at what are the ingredients of the success of capacity building under these conditions, So we have higher education institution with efficient registration systems, access to generic training, library resources, and allowing flexible arrangement. And that higher education institution, or the two higher education institutions which we are mainly enrolling people in distance learning masters in, but also in PhDs, is the London School of Hygiene and Tropical Medicine and the University of Munich, so the Ludwig Maximilian University of Munich. For the London School, we get very much reduced fees as part of a capacity strengthening scheme. For the University of Munich, as in many European universities, there are no fees one has to pay, but people have to go to Munich for a total of 6 months to do their PhD, and then they can come back to do their research in Zimbabwe. But it means you need to be able to fund these 6 months away. We have a very experienced and well-trained and engaged supervisor pool. So that includes people altogether. There are about 4 to 5 people in Zimbabwe at the Health Research Unit, which are actually seconded from the London School of Hygiene and Tropical Medicine. But then we also have quite a lot of visitors, and they are mainly providing the supervisory pool to the students we register at the London School. We have also extremely motivated and super skilled junior researchers with field experience. So when we make the decision to actually take somebody to a PhD level, we usually have employed them for a couple of years and really offered them many, many other training opportunities to upscale them to a level that we think they will be able to complete the PhD within a given time. We have dedicated funding for fellowships and training. I will show that to you in a minute. And then we have a critical mass of diverse research studies. So we really have platforms where we can integrate PhDs and MSCs within these platforms. And that allows, usually when you have a fellowship and you don't have that much research funding, dedicated research funding for your PhD fellowships, if you are basically nested or attached to a bigger study, then the resources in that bigger study can ensure that actually your research is also covered. So that means you have access to participants, you have access to research nurses, you have access to data. So all of that obviously helps the PhD student to complete their PhDs. Now, how we made it work, as I said, we have this capacity strengthening research degree scheme from the London School, which allows us to register PhDs and MSc students with reduced fees. One still has to find the money for the fees, but it's much, much cheaper than if you would pay overseas fees. And it provides a very large pool of supervisors. We were part of the Fogarty scheme, which through BATI, which unfortunately has run out, but that covered quite a lot of registration fees. It also covered stipends and travel and had very limited research costs. But because we have these platforms, that allowed for people to actually do their research within these research platforms. The research platforms also, as I said, provide the possibility of employment. So if we support people in distance learning master degrees, then they usually work full-time for us, and we pay their registration costs at the London School. And then they do their distance learning master over 2 or 3 years, and usually one of us supervises their MSc project, and they do their MSc project on data generated within the project they have worked themselves. We have 2 big PhD schemes, which I'm director of. One is the Create PhD program. And for the Create PhD program, which is Wellcome funded for the UK side of the program, we have LSHTM fee waivers. So anybody who's a matched African fellow on that program gets a fee waiver. And we managed to get philanthropic funding for the first 10 fellowships. 4 of them have been in Zimbabwe. That Create program has other countries which are part of it. It includes Uganda, Ethiopia, Ghana, and Zambia. And that philanthropic money covered the stipend, travel, and research costs. Now, unfortunately, we do not have any more of that philanthropic money left over, but we are still in a continuous kind of funding like drive. Then we have recently been awarded, and so that's also a consortium I lead, the EDCTP. So EDCTP, for people who don't know what it stands for, is the European Development of Clinical Trial Capacity Program, which is now in its 3rd round. And in the 3rd round, we have been awarded a fellowship network, which is called SOFA. And that fellowship network has 6 PhDs, 4 MSCs, and 5 postdocs. across 3 countries, Zambia, Mozambique, Zimbabwe. The University of Munich is the consortium lead, and London School is an affiliated entity. The scientific lead of this program is the Biomedical Research and Training Institute, so in Zimbabwe. So you might have seen we have had just 2 calls out for applications for 2 PhDs as part of this scheme. So this is just to show you the Create PhD website. The SOFA network has only started 1st of October, so we don't yet have a website. But if you follow us either on Twitter or Blue Sky, I think we will migrate from Twitter to Blue Sky very, very soon. Then you can also see and follow what is happening with regards to the SOFA network. Now, as I said, training does not start with university, and this is the handbook of the Youth Researcher Academy, and you can find that on our website, which really is almost like a step-by-step kind of modular version of if you would want to run a Youth Researcher Academy yourself, or in fact, just a researcher academy for the public. That's the way you could do that. There are exercises in there. There's for each lesson, a lesson plan in there. And then there are also things like terms of references for the researchers, which were then affiliated to separate projects. Now, also, I just wanted to point out again that it's not just when you do capacity building, it's not just about academic staff. Professional development for support staff is incredibly important. And it's incredibly important because, you know, they are the people who make your grant happen. Like if you have a grant without a finance officer, without an administrator, without procurement, you will not be able to actually implement your research. So having good people and developing these people and making sure they stay with you is utterly important and cannot be overemphasized. So we recently got awarded in 2023 the EDCTP prize for the most outstanding research group, and that was for SRUZIM. And with that prize money, we have supported a lot of PhD fellows for travelers and conferences, but we have also started an initiative, which I call secretly the Lion's Den, but I called it officially the Smile and Shine, which essentially asks our staff members, non-academic staff members specifically, to apply for professional development. And it didn't matter if it was the domestic worker or if it was the driver or if it was an administrator. Everybody could apply as long as they could just really make clear how that furthered their personal professional development and how that was good for the institution. And they could apply for up to 2,000 USD. So I've received all of these applications a couple of days ago, and we will do the shortlisting over Christmas and then invite people to actually give a little presentation. And just to say, because in order to make this accessible for everybody, it was actually a paper application people handed in, and it was in handwriting rather than asking people to type it out. And again, when people will be presenting, we will not ask for a PowerPoint presentation. We will just ask for a 3-minute kind of pitch, elevator pitch. Why do you think we should fund you? Instead of making it very complicated and therefore inequitable for people to be able to apply. Now, again, it's not just about PhDs and making sure you register people. What we often do, and these are all pictures from, one of them is the ones with swimming pools from a writing retreat in Mozambique. So we took our junior researchers to Mozambique, and the Mozambican collaborating team, INS, got a whole bunch of their junior researchers together. And importantly, it's not just junior researchers being there, but also we had altogether about 4 professors there who could help people write, who could help people kind of get the storyline out. So what we did was that we sat around in a circle, including the senior researchers, and everybody was just writing for 4 hours in the morning and 4 hours in the afternoon. And then we would come together and one person would present their results table and their interpretation of it. And then the whole group would critique it and say, you know, maybe you can make your storyline a bit different. Maybe that is the main message. And so a lot of the junior researchers would then get their results essentially and their analysis critiqued. You can see in the gazebo tent, that was a writing retreat we were running in Manor Resort here in Zimbabwe. And again, there were there were statisticians there to help the junior researchers if they were stuck with their analysis. And every afternoon, one of the junior researchers would present their paper to say, you know, like, this is how I'm thinking about it. Am I in the kind of going in the right direction? And very importantly, and we do something similar. For example, we had a 2-week last year short course on statistics and epidemiology, where a lot of our staff participated, but we also had researchers from UZ and from other units at BRTI, altogether 20 people who did this 2-week training, in-person training. And importantly, you know, when you do those trainings, you need to make sure if people work for you as study coordinator, or if people work as like data officers, that you actually give people the time off so that they are not constantly called in. It's then really their time, you secure that time for them and you don't eat into that time. That is the same, and that's the whole kind of premise of writing retreats, that you take people somewhere where they can't be interrupted, where they are also away. Often a lot of junior researchers have quite a lot of family commitments, and taking them out of their normal environments for a week or two to really focus on their writing can sometimes really, you know, get over the writer's block. So I think that's very important, and it's important to understand that people often have a lot of commitments, which is not for the sake of, you know, it's not that they are not trying to stick to deadlines, but they are often torn into a lot of places, and they are often the sole income earner. So it's important to realize that and understand that especially when you're coming often from the global north, where that the family kind of, you know, like the family commitments might not be as explicit, and there might not be as many expectations. It's sometimes a bit easier to extricate yourself from that. Saying that, it still doesn't mean that you have, even in the global north, the best life and work balance. So lastly, I just wanted to say, so I wanted you to meet our PhD students, and you can see we have PhD students both from the UK as well. So this is our CREATE students. So these are UK students plus the match students, and they are registered actually because the CREATE program includes 4 universities in the UK. So they are registered not just at the London School, but also at King's College, at Brighton and Sussex. So there is a kind of broad range of researchers, and not just a broad range of researchers, but also of research specialities. So Claire Calwood is a respiratory physician. Kevin Martin is a general practice physician. Rumbi Gumbi is actually a nurse. Mary Tumusha is a public health professional. Sam is a psychiatrist. Maureen is a social scientist. Kate is a physiotherapist. Rulani is also a public health epidemiologist. Tinash is a biomedical scientist, and Lydia is a neonatal nurse. So you can see that we have also, with regards to the kind of breadth of speciality, a really big mix of specialities. And the nice thing about the matching is that often the matching works very well, because the person who comes from the UK might know more about respiratory medicine than maybe a public health practitioner. But on the other side, the person here in Zimbabwe knows much more about the healthcare system and can feed back in very different ways. So it's a really, it's a partnership and a peer mentorship which works in both directions. Our other PhD students, so these are non-CREATE PhD students. Michaela is originally a health economist. Martha is a biomedical scientist. Fari is a medic. Tafatswa is a statistician. Brenda is a biomedical scientist. Farirai is a radiologist. Nyasha is a medical doctor, pediatrician. Edson is a nurse. Tino Tenda is a monitoring evaluation specialist. And Efferson is also a medical doctor. So with regards to our postdocs, again, you can see that there is quite a big variety in our postdocs. All of these postdocs actually have fellowships, which are individual fellowships. So Justin is an anthropologist, and he has a Wellcome Trust fellowship. Cliff is also, he does a lot of climate change and has also a lecturer at UZ. He has a Peter Peart Fellowship for Global Health Innovation. So he does both social science and GPS quantitative stuff. Mandy Tembo is also a kind of mixed method researcher. She does a lot of menstrual health and has a Reckitt Global Health Fellowship. Kalpana is a GP and she is working on hypertension, has also a Wellcome Early Career Award. Edith is a radiographer and was our very first PhD student. She had an EDCTP fellowship. Now she has a Wellcome Trust Early Career Award. And Felicity Fitzgerald is a neonatologist and has also a Wellcome Trust Early Career Award. And lastly, I just wanted to say, with all of that, it's always important to celebrate. So I like to give people cakes for celebration. And you can see on the right hand up here, Chido Chikwari, that was her cake for her PhD celebration. This cake on the left-hand side, which is for International Women's Day for the 8th of March. And then in the middle, you can see Collins Timire, who recently graduated, one of my PhD students, actually in our living room because it was an online Viva defense. And he's there with his brother and me celebrating his PhD. And then on the right-hand side, one of our research assistants celebrating World TB Day with specific cupcakes for World TB Day. And with that, I say thank you. And yeah, if there are any questions, please let me know.
Thank you very much, Professor, for such an inspirational presentation. It's actually good to note that in Zimbabwe, we've got a research of this magnitude taking place. I wasn't aware that there's a research of this magnitude taking place. Maybe before I open the floor to questions, I just want to confirm if Dr. Milan is around. Okay, I think she's not yet in. Okay, I'm going to open the floor for questions. If you want to ask something, maybe you can just raise your hand or you can ask in the chat. Then Prof. Krenza can answer your questions. So if there's any question, you are free to ask so that Prof can answer all your questions. Maybe as people are typing in the chat, Prof, I just want to ask maybe 2 questions. Actually, from your presentation, you mentioned that you are doing research in HIV, TB, and also STI. I wanted to know if there are any plans to expand your research in other fields such as cancer or maybe diabetes, because these are also diseases which are affecting Zimbabwe. And also my other question is, how strong is the collaboration with local universities? For example, if you've got medicine students that use it, are you collaborating with them in their research? Also, because I saw that most of your students, they are actually in the UK, but you also have some local students maybe that you are partnering with, and also maybe university department that you are partnering with. Thank you.
So thank you very much. Yeah, no, we do a lot of research actually in the non-communicable disease space. So I'm myself a microbiologist, but I also actually do quite a lot of integrated screening and integrated, like not just screening for one disease, but for multiple diseases. So as I said, one of my colleagues is a geriatrician. So like NZDs are like the bread and butter of geriatricians. So she leads a big program on healthy aging, which obviously, for example, dementia is quite a big part of that. Frailty, osteoporotic fractures are a big part of that. She also previously, she just finished a big study across so Zimbabwe, the Gambia and South Africa, which is called Fracture C3, about hip fractures, which obviously is also much more a problem with older age. So we are not really completely focused on HIV and TB. We have done quite a lot of work in multimorbidity. Actually, Justin Dixon and his PhD student, Efferson, are specifically looking at multimorbidity and electronic health records in Zimbabwe. And we have done big studies in healthcare workers during the COVID pandemic, much more a kind of implementation, like offering people services, which was called Icarus with health checks, where we have published quite a lot of papers on that. We have a very good collaboration with the University of Zimbabwe, especially the postgraduate center. So we have early career researcher clubs, which we do together with them once a month. And now I think they are on Wednesday, every first Wednesday or every second Wednesday in the month. So we alternate between UZ early career researchers presenting and BRTI researchers presenting, with actually participation usually online of more of 60, 70 people, and in the room at the postgraduate center about 30, 40 people. So I have previously supervised students at Africa University. I have also supervised MDs, for example, in the pediatric department. We also do quite a lot of collaboration through actually trying to input on the medical curriculum, especially my colleague, Professor Celia Gregson, on the geriatric curriculum with the medical school at UZ. We have actually primarily our PhD students, out of the 20 students we have, I think 14 or 15 are actually Zimbabwean. So the kind of international students are much more limited. And those Zimbabwean students, we have tried with some of these PhDs, we have tried to register some of these students at UZ. But unfortunately, the administrative processes are sometimes so long that it's very difficult to actually get people to registration status. We do have collaborations also, for example, with the nutrition department, and sometimes take MSc students or facilitate that people can do MSc projects within projects we have. But registration, my primary concern is always the student. And if I can't guarantee that students will get slick administration and supervision, then I rather register them with universities where I know that I can push these universities because I am employed by these universities and I can make a big fuss. My kind of leverage within UZ is not as big as my leverage at London School or the University of Munich. So I think it's unfortunately not that easy to register with other universities. We also are just at the moment establishing collaborations actually with Midlands University, because one of my PhD students will start working in Gweru, and she's a respiratory physician, and I think there's a lot we can contribute to teaching. So yeah, that was a long answer to your question. Sorry for that.
Okay, thank you very much. I think I'm all answered. Are there any other questions on Professor Kenza? I see some questions in the chat. The first one is from Catherine Chinyandua. I think as researchers, practitioners in diaspora, in what capacity can we be involved in this work as part of addressing the structural challenges we are facing? Maybe you can answer this one first, Prof.
So can you repeat that? As researchers in the diaspora, how can you address the challenges we face here in Zimbabwe?
Yes.
Is that the question? Yeah, so I think one way is really about mentorship and supporting it. One needs to be realistic. And I think my prior speaker, Brunette, who has said, one shouldn't kind of spread oneself too thinly. I do think that one shouldn't try to mentor 10 or 15 people, but it is possible. The potential in a lot of people in Zimbabwe, and I think the education system is still very strong, or turns out still very, very strong and very motivated people, which is a bit different. I know a lot of other countries in the region where you could not find such superb people. I just had this feedback 2 days ago or 3 days ago when we were asking actually colleagues from Zambia and from Mozambique to shortlist our PhD applicants in Zimbabwe, and they were like jealous of the quality of people who applied. They say they would never get something like that if they put out PhD calls. So there are a lot of people, and it's not possible to mentor all of them. So if you know people and you're happy to be involved in mentorship or co-supervision, you're very welcome to contact me, and I will put you in contact with our training lead, which is Rudu Chingono and Edson Marambere. And because we often get a lot of requests, and we can't take everybody. And just to say, we usually do not take somebody on as a PhD without having worked with that person before, because it's a long journey for a PhD. It takes 3, 4, sometimes 5 years, and you really want to be absolutely certain that the person who starts on a PhD doesn't just do it because they want a degree, but they have this kind of hunger, and you see this kind of flickering in their eyes that they absolutely want to answer the question or want to know how to do research. So if you from the diaspora are able to be part of mentorship, be part of, because, you know, the amount of, for example, editing I often do to proposals for making people have competitive proposals for outside funding, for international funding, for sitting down with people and talking them through different funding opportunities, because often people don't know, being happy or able to, whatever your methodology is, to also to support maybe little training workshops when you come and visit your family. Maybe you want to come and give a talk. Usually when people visit us, like collaborators visit us, we always make them do a talk so that our early career researchers are exposed to as many specialties as possible, because we do realize, you know, if like when people go for 6 months, and often in our case, they go for 6 months to London, not on a block, but for like 2 months here and 2 months there, they all of a sudden have so much exposure to different specialities and high quality talk. That person, you know, would you be happy for me to contact you again? I'm really interested in your topic. Could you possibly read over my proposal? And it establishes relationship and provides our early career researchers with a network. And you can do that also if you say, you know, I would like to come and give a presentation at the Early Career Researcher Club at UZ, then we would be very happy to facilitate that, even as an online presentation. Because the more we can facilitate networks, obviously my networks are very TB, AMR, and infectious disease specialized. And then I know the UK, I know Germany, I know a bit of Europe, but I don't have that many networks in the US or Australia. So, you know, giving people really access to networks is extremely important. And as somebody in the diaspora, you can absolutely do that. And I think Dr. Brunette has kind of very, you know, has laid that out very clearly, how she supported some of her students, how she supports still her peers, and how she actually, from the networks of others and from her own networks, really benefits.
Thank you very much, Professor Krenza. It was actually informative. I think there are still some questions in chat. Maybe you can engage with them in the chat and also stay with us for the question and answer session. Maybe there are some questions regarding your presentation. Thank you very much once again, Prof. Our next speaker is going to be thank you, Prof. Our next speaker is going to be Professor Shinga Ferez. Professor, you can take the floor now.
Hello, I can't even see you guys. I'm just trying to join in. My name is Ishinga Feresu. I'm a professor of epidemiology and biostatistics, I think since 2010. And by that time I was in Indiana, Bloomington. My experience is varied. I've worked with many students in my lifetime. I've graduated more than 100 students. Um, Most of my work is based on numbers, you know, and understanding research and how to do research, how to get quality data, um, assisting students with sample size, with data analysis, objectives. How do you make your objectives active? And we must also remember that there are two types of data. So we have what we call the qualitative data, then the quantitative data, and then we have the mixed one. So I've worked in all those areas and fields, and using also many data sets, doing simulations, projections, and so on and so forth. But the most basic thing is for students to understand what they are going to do. Are they looking at stories, which is a lot of qualitative data, where they understand in depth from participants and from the world and they can make conclusions? Or are they looking at the numbers in terms of whether they will get allocation for their programs or projects or whatever they are trying to do? Then they have to do quantitative data. Or are they ready to mix it up so that they have both the quantitative and qualitative data? And then you think about when you are doing research, where are you doing research? What's the purpose of your research? And what are you wishing to accomplish? And so you need to think about where you are, the setting. For me, I've worked in the developed countries and then developing countries. I'm currently in South Africa, but I'm a native of Zimbabwe and an Afro-American. So I've had those experiences in different worlds. And so you have to understand where you are working, what you are trying to do, and understand that context because it gives you richer understanding of what you are trying to do. So as students, what you really have to do is to align what you are trying to do with what you can get at an institution. Don't hurry to just go there, then do something you are not passionate about. You have to be passionate about what you are going to do. Is it going to improve you? Is it going to improve your country or your organization? And so on and so forth. Those are critical. Now, when you think about data, the most important thing is what type of data are you going to collect and where and how, and the quality of that data. Because in statistics, we say garbage in, garbage out. If you bring garbage data, I can't do anything for you. So you have to think ahead of time and you have to understand the numbers. How many people do you want to do or collect data from? Is it feasible? Can I actually do this? And in my research methods courses, those are some of the things I tackle as early as possible so that people know what they're trying to do. Um, um, I I apply both methods. I apply methods. Um, I use my epidemiology background. Okay, let me give you a bit of, because I said I was late. I was late in being given the whole thing. But I said I'll introduce myself. So I started off as a nurse. I started at Harare Hospital a long time ago in Zimbabwe. And I was just one young nurse, you know what I'm saying. Then when I had a lot of, what do you call them, where you are given prizes and so on. And then I moved on. I did my midwifery. During my midwifery is when I started thinking about going further with life. I remember they would see me sitting somewhere in a corner. What are you doing there, Nurse Feresu? I was now a sister, Sister Feresu, and they would see me reading. So you have to develop a passion. So I already had a passion, and I was way before 20 years old. And by the time I was in charge of Mutoko and Modzi districts, I was now geared to community health. And I wanted to do as much as I can. I remember immunizing kids at night. We were using the back of a van to see the light and torches while we were immunizing kids, long queues. Or if I'm visiting Yamapanda, which is the border of Mozambique and Moze in Harare, in Zimbabwe, I would have a long queue of people who are waiting to be seen by me. It didn't matter if we left Nyamapanda at 10 p.m. But the most important thing was I wanted to help people. So in you have to have that passion. Then fast forward, I came back. I was in charge of some floors at Mbuyanehanda Hospital in Harare. And then I then became, because I was studying also with the University of South Africa, I remember I never slept because I would go for night duty. During night duty, I would be studying, and on nights off, I would be studying. I hardly slept because the idea was I wanted to have that degree in nursing, and that was a degree in nursing education and community health nursing. And that time, I was in different wards at Handa and so on and so on. But then I moved because I got my degree. Then I was moved to become a clinical instructor. And because I'm a little bit sophisticated, I was assigned to private wards and all that stuff because I smile a lot. So I was lucky that I got those opportunities. And then I became a tutor. But I didn't stay as a tutor for a long time before the University of Zimbabwe scooped me. So I became a director for the Kellogg Funded Project, and I was also teaching in the medical school. That was from 1990. Then I got a Kellogg Foundation because that's who was funding me now as a director to go to America. So I left for America in 1994. And that's when I did my Master of Public Health in 1 year. Stayed there, did epidemiology and biostatistics. That was in Boston. Then I moved to, I think I moved to Michigan after that for my PhD. I took courses at Harvard, Tufts, whatever school you can think of. And then I went to Michigan, I said, for my PhD. Then I went to Nebraska. There I became an assistant professor for epidemiology. I helped them develop the College of Public Health. I was like the backbone for that. And then I was hired by Indiana Bloomington because they were also starting a program there. So I went and helped them develop the School of Public Health. So you have to be bold. Remember, I'm Black, and it's not easy for a Black person in America. So I had to push all the strength I had to get those things moving. I also developed the departments of epidemiology and biostatistics, whether it was in Nebraska or Indiana. Somewhere along the line, I said, it was snowing, it was this kind of year, and I said, I'm going to go back to Africa. So I decided to come back to Africa. I came to University of Pretoria. I'm 10 years in South Africa now. I've worked with many universities here, University of Pretoria, Witwatersrand, Cape Town, Fort Hare, Johannesburg, KZN, and mostly I do their programs, I do their students, I also help with many things to do with their data. And I was sometime working with the NHI and consultant for chronic diseases and mostly cancer and so on and so forth. So I've been around for a little bit, but the work I love most was working with the students, making them grow, understanding what they're trying to do, making sure they publish their work, and getting the right things, the ethics and stuff, everything it can be very stressful. And so, and some may not have fees, I help them and support them and make sure they get funding. So those are, in a nutshell, myself and what I've been doing. Currently, I am a consultant. I'm retired. I have my institute. If you look me up on LinkedIn, you'll find me. And it's under construction, and I'm working on it to make sure we move forward. Otherwise, that's me in a nutshell and what I think I can do with students and anyone interested in epidemiology and biostatistics. I love those things and research really. Thank you. Hello, I'm done.
Thank you so much, Professor, for an insightful conversation. I'll open right now because we have many people on the line right now, I'm sure, who are interested in pursuing a career like yours. I'm sure some are interested in epidemiology, others in biostatistics, or whatever area it is in research. If you are like that person and you have a question for Professor, please just raise your hand or type your question in the chat and ask Professor. We only have 5 minutes for left for here right now. Can you just send in your questions? My question really will be relating to, we have got a lot of people who are interested in public health research. As a biostatistician, what advice would you give them really? Because one of the challenges, I'm talking now as a journal editor, what I've noticed is most of our articles are rejected because of that lack of what is sometimes referred to as scientific rigor. So how do we navigate that particular area, especially if you're advising someone who's trying to jump into public health research as a biostatistician?
The most important thing I think is they have to understand numbers. They have to know what it means to crunch numbers. What do numbers? When I teach the biostatistics courses, I try to do like we are doing right here on Zoom, but I usually do on Microsoft, the other one, and show them, and also do one-on-one, because numbers are not easy. They are easy for Chinese, for Indian people, but not quite for us. And if I tell you the truth, I remember I was in Michigan, somebody was like, "You are the biostatistics teacher?" I said, "Yeah." And how? Little girl. Yes, myself. Not many people even think that we can do it. But honestly, there are many Black people who can do it. So they need to understand numbers. They have to learn numbers. They may have to take extra courses so that they understand what numbers mean. My courses are very basic. I teach probability. I teach all those, even mean, median, what, basic things as we hit up. So it's important that they understand numbers, how to calculate, how to analyze, how to interpret everything. But it's not easy. When I started, actually, when I was, I started research a long time at the University of Zimbabwe. But when I was in Boston, one of the things I did is I always went for extra lessons, be it at Harvard or in Boston, Boston University. So if I see a course, I go and do those courses because it enhanced my understanding of numbers, data, and how to manipulate data, how to make sense of the data. So that was one of the things I did. I also, because the Kellogg was very generous, so I also had a tutor assigned to me. I asked for a tutor. So I had more time, also understanding from my tutor. Sometimes people misunderstand the role of the tutor. They think the tutor must do the assignment for them. No, 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 no. The tutor is for them to teach you, so you yourself, you are on top of things. I also find that students, which is strange, I found that here, mostly in South Africa, students pay people to do their assignments and things. So if people can run away from that culture of paying people to do their assignments and stuff, they will do better. Thank you.
Prof, you are on mute.
Thank you so much, Professor. It was wonderful to have you. Before your talk, we had Brunette, who was also giving her journey as an early career researcher. And now we also have you telling us your journey as a senior career researcher. So I think we got the best of both worlds today. And it's such an honor to have you. I'll ask maybe a question regarding your career right now. Like we are looking back at epidemiology, particularly health in Zimbabwe. I'll probably also throw that same question to Prof. Krenza if you're still here. I'm sure I understand you'll be leaving very soon. That when we are training these future epidemiologists, how are you inculcating that culture of making sure that whatever research that they are doing, is going to be relevant to their communities? I'll throw that question to you, Prof. Ferres, and also to Prof. Krenza.
Yeah, so I work with the University of Zimbabwe. I also work a bit with the Midlands. I'm trying to put myself into Africa University as well. So we actually teach epidemiology there. I used to come most summers just to teach courses in epidemiology and biostats and data and stuff. One of the things, remember, in the medical school, most of them are either doctors, nurses, pharmacists, biomedical, the ones with the labs. So one of the things when I'm working with them is I tailor make my courses relevant to the students and where they are coming from and what they want to aspire. So they themselves also have to understand. You remember when I started talking, I said they have to know where they are. Who are they trying to serve? Understand their communities and what is needed. For example, by the Ministry of Health and Child Welfare. A lot of you guys who go on Twitter saw me with the COVID. I was doing a lot of COVID posts there, trying to encourage people, particularly for vaccinations and stuff. So you have to, like I said, that passion, and then you have to understand that community. What is it they need? What is it you are supposed to do? And remember, at the University of Zimbabwe, because as the director for Kellogg projects, one of the things I was doing was helping with rural attachments. And I even went back, funded by AMO, just to follow some of the students in the rural areas. So I like that aspect. I do not know if they are still doing that much on it, because then the students, whether medical or nursing or otherwise, they know where the people are coming from. They need to understand where the population they are serving is coming, what are their issues, what drives them to seek for help, and what is their expectations, and how can they be helped. And I remember also a long time ago, I used to teach on consultations with medical students. How do they consult patients, and what a consultation means, and so on and so forth. Because that communication is critical in the patient or client service and recovery. So this is where you foster everything to do with where students are going to and what they're willing to achieve. Now, when I'm teaching research methods, one of the things is, what is the problem? So how do they know the problem? So it's at the early beginning of my research methods courses. How do they identify problems in the community which are worth research? I caution you will never change the world by one day or one research or yourself. So we go small by small. So you focus on the most. I even teach them how they identify through journals, not only journals, with the community leaders, with the a person actually on the road, and understanding and looking at the data, looking at whether we have increased numbers. We call it, hello? Hello?
Yes, we are here. You have a minute. We have our next speaker coming. Sorry.
Okay, I lost you. Where are you?
We are
I
still
lost
here. We still can hear you.
I can't see you. Okay, guys. So anyway, you can see I have a lot of passion. So
Yes, thank you so much.
I think it's enough what I'm saying. People can contact me. You have my email address.
Yes, we do. Thank you so much. Thank you so much. Tinaya, can you go ahead and introduce Dr. Milan Tondo?
Thank you, Doc. Thank you, Prof, and thank you, Professor Feresu. Our next speaker is Dr. Milan Tondo. I hope I'm pronouncing your name right. Dr. Milan is a senior research associate at the University of Cambridge. She was previously a technical officer at the World Health Organization. She holds a PhD in medicine and translational research from the University of Barcelona and the University of Amsterdam, a master's degree in public health from the London School of Hygiene and Tropical Medicine, and another master's degree in medical anthropology from the University College London. Her work focuses on health impacts of urbanization, motorization, and climate change in cities of fast developing countries. Welcome, Dr. Milan. You have the floor.
Hi, good morning, or good afternoon. Can you hear me properly? Hello, can you hear me?
Yes, we can. Yes, we can.
Good. If you don't hear me, then I'll remove the video, but I just wanted to make sure that I say hello to everybody. I've been listening now to the speakers, and it's very nice to be online. Thank you for the introduction, but you have not said the most important thing. The most important thing about me is that I was born in Zim, and a lot of my emotional ties and work ties are also in Zimbabwe. So currently I'm calling you from South Africa. But it is true, I am affiliated with the University of Cambridge right now, and I will take maybe 3 minutes to explain to you a little bit the research that we are doing. Thank you so much for the invitation. It is really an honor to be here. So what we're currently doing at Cambridge is looking at a bit of this triangle between health, urbanization, and climate change. And what we're trying to do is to look at this nexus in very fast developing cities. So most of my work focuses on cities and urbanization and what that means for health. Currently, we're working in 8 different cities. So we have South Africa, but also Cameroon, Kenya, Nigeria. We're working out of non-African cities. We're working from cities in Brazil and Jamaica. And we're trying to see whether or not in these cities there is a trend into how commercial actors, how community actors, and how policy actors respond to the health challenges of climate and urban together. What I most like about the research that we're doing right now is that it involves a lot of consultations with policymakers. So the project started in 2017. Now we are 2024, and we have until next year. So it will be a total of 8 years, during which we did a lot of consultations, again, with these 3 groups of people: policy actors, commercial actors from the industry, and then community actors. We've consulted over 400 people in these 8 different cities. And what we've been trying to do at the same time as the consultation is to collect data. What actually happens when there's a climate hazard or a climate event? It can be drought, it can be flooding, it can be heat waves, so precipitation. One, what happens with health? Are people able to cater for their health? Do they physical activity? Do they continue to be safe? What are their resilience strategies? And are the government, the policymakers, responding to these needs? And are the commercial actors responding to these needs? So this is a bit in a nutshell. I think the context is that we understand that by 2050, 80% of the world population will be in cities. There are still billions of people that do not have access to sanitation in cities. And when climate events hit, these resources become very scarce. To finish on my 3 minutes, maybe I can highlight some findings that we've had from the studies. So the first studies has been that during those consultation, the use of what we call transdisciplinary research is very important. But transdisciplinary research only can happen if we're doing knowledge translation that is both ways. So we are now publishing a paper explaining how knowledge co-creation, especially in these topics that are very complicated, the link between health and climate is very complex. The link between cities and climate is very complex. So what policymakers find most useful is actually to be able to be involved in the research very early, being able to do some methods like actor constellation, proper stakeholder mapping, understanding who is doing what and when. And I think this has been very useful in us showing that transdisciplinary research on the continent can actually work, but that obviously it has different needs that if you do transdisciplinary research in other parts of the world. The second finding is that at community base, so what we've been doing is trying to understand the coping strategies of different communities, and what we found is that communities actually focus a lot on survival rather than on more complex effects of climate and health. And there has been some findings around the mental health impacts of climate change on communities. So when it comes to commercial actors, we are looking at a series of policies in all of these cities. And we found that these corporate political strategies are actually really dominant in big transnational organizations like Nestle or like Total. There are a lot of policies that are responding to the impacts on climate, but a lot of them are actually not at local level. So very high level impacts. And at the moment, we're still kind of analyzing to see how that affects communities. So this is it on my side. I will stop. I'm very happy to take some questions. And I hope that was helpful. Thank you. Over.
Thank you so much, Dr. Milan. It was such a great honor to have you. And what's really interesting is, Prof. Julius, are you still there?
Yes, I'm here.
Yes. So when Milan was speaking, I just thought of you, the challenge that you gave us initially. Can you just kind of comment on that, just for Milan to benefit from that topic? Like she's emphasizing the importance of commercial players when we are looking at at urban health and overall in your area in the innovation aspect. If you are free, can you just comment on that one? We continue with the conversation.
Yeah, very, very fascinating points you're raising there, Milan. I was talking earlier on about tackling health disparities in urban areas, looking at the work that I've done in London, but also some ideas that I've got to look at similar issues in Zimbabwe. And I think what you're highlighting really in terms of the interests that different stakeholders have is really, really important in what kind of solutions can then be co-created. The whole knowledge co-creation angle you highlighted. So I think, yeah, there's quite a lot that we can probably explore together. Transdisciplinarity or multidisciplinarity or interdisciplinarity, whichever way you look at it, I think it's really, really quite central, because there are different traditions of knowing, different meaning-making ways that are there, but how do you actually bring them together? Because that's quite central in terms of the solutions that can then emerge for the very complex and wicked challenges that are the policy nexuses that was highlighted earlier on, I think, by Professor Mabau, that there are a lot of policy areas that are intersecting. How do we actually then draw from what their interests are and what their challenges are to then co-create solutions?
Thank you. Over to you, to Milan, if you have a comment on that one.
Yes, I think that, we tend to think that similar things are happening in cities, and with the research, we try to find communalities. But what we find is that, for instance, because the climate events are also so different, right? So when I'm thinking of our city in Belo Horizonte in Brazil, their huge problem is really around flooding. But then when you move to countries or cities that are on coastal areas of Southern Africa, you have problems like drought. Like right now in South Africa, drought is a big, big problem. So, even if the processes and the methods, we talk about, it's transdisciplinary. And I also wanted to highlight the systematic review that we just did, looking at, are these interventions multi-sectoral, right? Because the big thing is saying, oh, for us to address the wicked challenges, we have to make sure that different sectors are actually involved. And what we found looking at all the African countries in the African Union is that on paper, intersectorality within governments and within policies is really a highlight. But when you go in the intervention and you try and see, okay, in a public space, are they actually putting physical activity infrastructure to promote health? And is the Ministry of Sports included? Is the Ministry of Health included? Is the Ministry of Environment included? And as you know, in cities like Lagos and probably Harare, there are some disaster management boards, and I know there is one in Harare around water. Are these people involved? Because, if you do get a flooding in a public space, it's never going to be one answer from one ministry. It's going to have to be an intersectoral answer. And so what we find in this review is that intersectorality costs a lot of money, as we all know, but there isn't a very clear protocol about how this actually looks like in practice. And our cities, and when I say our, I talk quite generally about the continent. There is, as you said, Professor, a large diversity in the population, and the levels of inequity are very acute, and it's probably a different style of governance that we need for urban health. And we're struggling to find that, whether it's about public spaces or even about mobility. When we think about the health impact of our transport systems, and the high levels of inequity, as you see, between populations that walk, even populations that cycle in some settings, populations that take informal public transport. What does that intersectoral collaboration look in our settings? There is a huge gap of data we found in the paper, but it's not all negative. I think that we have found, at least at community level, that many communities have their own solutions. It's just that often it's solutions that is on the spot. Climate event hits and the solutions come up and emerge very spontaneously. So it's quite difficult to document them. Not that they're not there, but that they're not properly documented. So yeah, I think that's a very fascinating conversation.
Thank you so much. Thank you so much for that. You just answered what was my other question, that what are the barriers that are surrounding implementing multi-sectoral health intervention? I think you have answered that question. And another issue that you mentioned again, an earlier speaker, I think it was Dr. Tatenda, she talked about the importance of trust, really, that we can have our formal or intervention frameworks, but sometimes we are working in communities that don't trust formal solutions. In your, I'm thinking of that systematic review that you did, was there any comment on particularly on that area where formal solutions are kind of ignored because of some challenges surrounding issue of trust, really?
Yes, I think that trust is something that that sometimes even between academics, and I know there are quite a couple of academics here, that we struggle even within academia, right? How we trust our fellow researchers, how we then build trust between academia and policymakers. These are quite difficult questions because researchers often move very quickly from one place to another. It depends on the funding. And that means that you're constantly talking with different types of policymakers, and those those linkages are very, very fragile. As the policymakers, and I like to call them political economic elites, these people that are making the decisions, they are often changing with each mandates. And our style in academia is not so fast. You know, we take time to adapt to these political changes. So by the time this trust between policymakers and academia is built, sometimes it's a very long time. The second link is between the people now and the policymakers and the scientific findings. At least in our experience of working as academics directly with the communities, it's often a challenge because you have to be there and be consistent and also use the right language. The language that we use is often not aligned, even in this climate space, you know, whether we talk about hazards, disasters, events, whether we talk about resilience, mitigation, adaptation, you know, people don't use these terms. So we're often doing research that seems too complicated, and that really doesn't help with the trust. And we have to be able to build those bridges by using the right words and making sure that we're involving people from the start. I think overall the question is really, you know, when you're doing this type of research and involving people, there's also accountability. And you have to also make people understand that when they're participating and engaging actively in the research, that there is something that they're getting out of it. And coming back to your point, Professor, about knowledge co-creation, it's a new style of research. You know, the trust can only come if everybody is learning from an equal standpoint, and that everybody brings to the table their kind of knowledge. And I can see some questions coming in on local government. I think working in cities is a great opportunity, even if the scale sometimes can be very complicated. In Lagos, there's 23 million people. Even if you work in Kisumu, or if you go and work in Bulawayo, even if it's smaller, the cities are complex. So this trust needs to be central to research. And I think there's a level of humility that researchers need to start, you know, really feeding into, so that people can actually level out and learn from the research equally.
Okay, thank you, Catherine, for the question, and thank you, Milan, for the response. Is there anyone else with a question? Anyone with a question?
I can see a question from Catherine. Maybe I can see with some colleagues on the panel if you want to tackle that one. It's a very
Yes.
good question, Catherine. Thank you.
Brunette, you are still there. I see. Solomon, are you there? So Catherine,
Yes,
can you?
yeah, I'm here.
Awesome, thank you. So Catherine asked about the importance of how is local government working in communities to have people-driven policies. I understand you're coming from a music side, ethnomusicology, and I think it's a community-centered initiative, and I think it's possible that in a health policy, we can learn something from what is being done in music. So if you can just answer a little bit on the question that Catherine posted.
I can't see the question.
Okay, I'll read the question. How is local government working with communities to have people-driven policies? For instance, if you look at urban farming, it's critical for food security, but at the same time, our bylaws are redundant. They are against it. Authorities cut down crops. So we know, like Prof. Tafadzana Hashem about it, talked a lot about the importance of that WEF nexus, the water, energy and food nexus. And we have been, throughout this conference, we highlighted the importance of this cross-disciplinary talk. And she's highlighting that issue, which Prof. Ngwagwa is pointing out, that there is a lot of dissonance, policy incoherence, that we encourage people to farm more, but at the same time, we cut the crops when they do. And I understand this is more of a reality in ethnomusicology again, where what is encouraged, it's also discouraged. in one way or the other. So is there any lesson that we can learn from ethnomusicology on how it is addressed these kind of issues?
Yeah, thank you very much. Yeah, that's a very interesting question that brings into account a lot of challenges, because from my own experience as an ethnomusicologist who is interested in working with indigenous people, I noted that there's a serious issue whereby the government, when it's working with local communities and artists, as well as musicians and dancers, when it comes to policy implementation and policy design and implementation, they tend to use this approach, the top-down approach, whereby they tend to impose things. They don't consult, they don't go to the communities and ask them what works for them, how best can they integrate and take into account local ways of knowing, indigenous knowledge systems, indigenous methods of doing things. For example, when I was doing my research, I went to the Ndau communities in Chipinge, and after realizing, and as a way of trying to counteract these top-down approaches, I introduced a festival that was based on Nimbe philosophy, which is all about collaboration. And this type of collaboration is not just about a situation whereby people comes together and implement a specific project, but it also involves the idea of whereby people bring different equipment and resources to help someone who is in need. So what I'm just trying to put across here is that the main challenge that we have in Zimbabwe, and I think it's an issue across different sectors, it's about the approach that is being used. It's all top down, whereby experts, scholars, politicians, they tend to impose things on communities without consulting them. So in short, that's what I can say for now. Yeah.
Thank you so much. Prof. Mkwagwa, you proposed a fascinating framework that can address that issue. Can you just maybe elaborate a little bit on how we can really move forward with the conversation? Because the idea really is for us to, I like what Sandile did of telling us about Zimbabwe in 2050, what Zimbabwe should look like. So the idea here is, how can we get to that vision of a sustainable Zimbabwe, of a healthy cities in Zimbabwe from the framework that you proposed, so that we can answer the question that Catherine gave, that one policy says this and another policy comes to cut down what has been planted by policy A.
Yeah, that's the big question. I think that's why practitioners, academics, and communities spend sleepless nights trying to deal with these intractable development challenges. But I think for me, especially looking at it from an innovation systems point of view, just any system you can think about, when you are trying to change that system, there is a tussle between incumbent practice, incumbent institutions, incumbent interests, and any new ideas that you're trying to bring in. So that contestation is always there. And how we actually deal with that is what is important. And the whole co-creation agenda, how do we actually move away from business as usual? If we were doing top-down, and that's the business we're doing, how do we move away from that and really co-create and really value other ways of knowing? Because if what we were doing all along is what got us to where we are now, then we can't continue doing the same. We really need to be very deliberate. I'm a life scientist, as you have seen from my profile, and the things I do are drawing from there. But one thing that I've learned as I've grown older is to value history. I've actually become a very keen student of history. And one of the questions I always ask is, how did we get here in the first place? Why are we even here? Even today, talking about bridging these different elements. Why was there the chasm in the first place? How did the gaps emerge? So if we recalibrate, rethink, and really look at how we got here, I think that will really help us to be able to do things differently going forward. And there's another important reflection as well, coming from systems thinking. But someone mentioned it earlier on around even the vision that you were highlighting just now, that whatever vision we are thinking about, or these imaginaries we have, they don't just emerge. They are results of deliberate choices and actions. So we need those deliberate choices and actions, and those choices do not necessarily need to be the same as the choices we've made before, because that's what got us here. And if we need to go in a different direction, then we need to make different choices. So those are the general comments I can make, maybe more on the philosophical side, but I think it's very practical as well in terms of that it's really about doing, and then realizing that there is a tussle between incumbent ideas and institutions and any new ideas. So how do we co-create the space for moving forward? Thank you.
Thank you so much. With that, I would say we will conclude our session. It has been a very productive session, and it was really an honor to have you, Milan, and I hope we are going to have more of you in the future. We are part of Zimbabwe Research Network. It's a network of around 3,500 researchers of Zimbabwean origin all around the world. This was one of our initiatives to have this conference where we bring people who the best and brightest minds from Zimbabwe to answer the pertinent question on how can we address the urban health challenge in Zimbabwe. So like what our Professor Mgwagoga mentioned right now, that we are not here to just think about it and forget about it. We want to get to the doing side of things, that at the end of this conference, it would have failed if it becomes just a line on our CV. But the success of this conference is going to be from the number of fellowships that people are going to apply from here, the number of engagements that we're going to have with our policymakers, with more engagements with our local governments, not only the local governments, but also our traditional leaders, so that I remember the pertinent question, does your mother know what you're doing? I hope as we live here, we are going to have a 3-minute pitch on how we are going to pitch the type of research that we do to the people around us who have got nothing to do with science, so that they can be invested in what we're doing. They can also be able to, because they are the ones who fund the science that we do. They are the ones who invested in the research that we are doing. So they need to know what we are doing, because they are the ones who invested part of their income for that. So this is the challenge that we have from today, that let's go for collaborations. Let's interact with one another. Let's reach out to someone who's working in what you're interested in, talk to them, introduce what you are interested in, and let's work together. The goal is we want to bridge the different gaps that we have, and we are going to have another session indeed to answer what Prof. Mgwagwa said. How did we get here? So I think we need to have a separate day where we just sit down a round table and ask ourselves, how did we get here? And have a scoping study really to look at how we got here and how, so that we can start planning to move forward. So with that, I thank you everyone for attending. Special thanks to our speakers. If you can give them an applause and tell them we love you so much for what you have done, and we are happy that you spent your day with us. If you can open your camera so that we see where you are, that would be wonderful. Then we take a picture. Is Emmy around? Emmy is the only one who knows how to do these things. Is Emmy around? We need you, Emmy, here. We need a picture. So, cheers, everyone. All right, thank you. It was great to have you. It was a wonderful. I hope everyone enjoyed the session as I did. And so bye-bye for now.
Bye. Thank you. Bye-bye.
Thank you so much, Brian.